Dr. Raja Ashok, sir.
8 minutes. You have 8 minutes, and sure, you will have 2 minutes for question and answer.
Your
Dr. Dheeraj Divakar is your judge.
Okay, so Dr. Raja, your time starts now.
Very good morning. I am Dr. Raja Ashok, and I'll be presenting my work on devising a novel formula to estimate the pre-procedural insertion length of PIC line in units. So this was done during my tenure at AIIMS New Delhi and under the guidance of Dr. Jeevasan. So the background of this study is that PICs are the lifelines in the NIC, and accurate placement of PIC dip is essential to avoid complications. Inserting PIC to a length as measured by surface anatomical landmarks, followed by confirmation using radiography, has been the conventional practice, but we know it is inaccurate. Even though we have real-time ultrasonography and intracavitary echocardiography, newer tools with superior accuracy, but they require expertise and they have limited accessibility. So there is a need to devise a technique for estimating pre-procedural PIC insertion length. Even though such formulas exist for umbilical lines, there are no such formulas for PIC lines. So with this, we set out with an aim to formulate an equation to determine the pre-procedural insertion length of PIC when inserted via the cubital fossa using one or more of the anthropometric variables, along with this traditional surface anatomy length in preterm and low birth weight neonates, the placement of which is guided by ultrasonography and the tip position confirmed by contrast radiograph. So the anthropometric variables that we chose were weight, head circumference, chest circumference, sternal length, shoulder umbilical length, and foot length. So we conducted a prospective observational study in the neonatal unit at AIIMS New Delhi. So we included all newborns which required a PIC line insertion as decided by the treating team in the upper limb at the cubital fossa. We excluded babies with neck and chest malformations and parents not providing consent. So we used a 28 gauge 1 French size catheter, Y-gauge cath, which had markings up to 20 centimeters, and researchers played no role in determining the indication or site of insertion. So in our unit, we use ultrasound guided real-time focus to localize the PIC dip at SVCRA junction. However, for the purpose of the study, we confirmed the position by using a contrast radiograph. If the PIC position was optimal on a radiograph, which I'll be mentioning in subsequent slides, the PIC was used for infusion and it was analyzed. However, if the tip was falling short of the optimal location, it was excluded from analysis. Or if it was too in, it was pulled out, a radiograph repeated, and it was again analyzed. So these are the pictures of how POCUS helped us in localizing the PIC tip. So as you can see, we have the PIC tip that is lying between the SVCRA junction. So for surface anatomy length, we defined surface anatomy length as the length between the elbow crease to the ipsilateral acromion and ipsilateral acromion to the ipsilateral manubrium sterni. We have used the same definition in an earlier study that was done by our group, which was published in Journal of Perinatology in 2018. So for the purpose of the study, we have defined optimal PIC tip location if the PIC line met all the three above criteria. That is, it has to cross the first costochondral junction, the terminal portion of the tip should be directed medially and downward from the first costochondral junction, and it has to stay above the base of the heart. So to account for variability of the site of entry around the elbow crease at the cubital fossa, we have devised a new tool called the actual PIC length. For example, if a PIC was inserted below the elbow crease at the cubital fossa, we would subtract the length that we noted for the purpose of analysis. And if it was inserted, above the elbow crease, we would add it so that is standardized. So that was used for analysis. So a sample size calculation, we did it using G-star power based on an R-square increase on multivariate linear regression, and accounting that 20% of the tip position may not be confirmed by X-ray, we arrived at a final sample size of 58. So we used univariate and multivariate linear regression analysis, and the independent variables for the predefined anthropometric variables and surface anatomy length, and dependent variables for the estimated PIC length. We calculated the coefficient of determination, that is R square, for each model, and we also devised an outcome variant called the predicted risk of malposition that was calibrated for each model. And malposition was recorded as yes, with the absolute difference between the estimated length from the model using the novel formula and the actual PIC length that we note down was more than or equal to plus or minus 0.5 centimeter. So during the course of study, we noticed that there was a consistent yet slight, when the pics were inserted on the left side, they were slightly more than those that was inserted on the right side. So we decided to do analysis taking into consideration the laterality of the arm of insertion. So that is why we created two data sets. And when we did univariate linear regression analysis, we had 3 of them which had the highest R square. 3 of these variables that I have defined previously were chosen for multivariate linear regression analysis. So this complicated statistical exercise led to the creation of 12 models, that is 6 from each data set. And among the 12 models, the best 3 with the highest R square, that is coefficient of determination, was selected. And the single best model with the least predicted risk of malposition was chosen as the optimal model for peak length insertion. This is the study flow. During the course of the study, we had 881 units requiring eco admission. And after applying the inclusion-exclusion criteria, we had 70 eligible picks. Out of them, 67 were enrolled and 52 were analyzed. In 52, 25 were in the left arm and 27 were in the right arm. So this is the table showing the baseline characteristics. So the mean gestation at birth was 30 weeks and the median birth weight at birth was 982 grams. Majority, 50% of the babies were small for gestation. And at the time of peak insertion, the median age of insertion was 0.5 hours. And we used basiloquine in the majority of the times. So this is the regression analysis of the different models that we created. So as you can see, to your left is the models which did not take into account laterality, and right are the models which took into account laterality. And these are all the, the R square and the predicted risk of malposition. So elbow sternal length, weight, and head circumference were the variables which had the best R square on univariate regression analysis. And their combinations were assessed by using a multivariate regression. So as you can see, the ones that are highlighted in blue, that is elbow sternal length and weight, had the best R square and the least predicted risk of malposition. Accounting for laterality did not add any benefits, so we dropped that one. The primary outcome is that the peak insertion length in centimeter is equal to 2.4 plus 0.7 into weight in kg plus 0.6 into surface anatomy length. This formula is applicable for preterm and low birth weight neonates for peak inserted in the cubital fossa. This model has a coefficient of determination of 0.84. And it reduced the risk of malposition from 65.4% to 25%. That is a relative reduction of 61.7%. That was significant. So this is the Bland-Altman plot showing the agreement between the two. So the mean bias was minus 0.04 centimeter and the limits of agreement ranged from minus 1.1 to plus 1.1. The proportional bias was not statistically significant. So we also did a post hoc analysis based on an observation that the surface anatomy length actually overestimates the correct insertion length. And we found out that the surface anatomy length overestimated the actual peak length that is required to be inserted by 0.9 centimeter. So by inserting peak to a depth of 0.9 centimeter, what you measure to landmarks, that is the surface anatomy length, even then the malposition rate would decrease to 38.5%. That is a relative reduction of about 41.2%, but this is just a post hoc analysis that we did on us.
For the interruption, sir, your time is on.
Yeah, this is my last slide, sir. So the conclusion is the proposed novel formula is insertion length in centimeter is equal to 2.4 plus 0.7 into weight plus 0.6 into surface anatomy length. The surface anatomy length overestimates the peak insertion length. So the implications are that the formula that I proposed needs validation in a separate cohort of newborns, and it forms the implication for future research. Our formula could serve as an accurate alternative to predict the prepositional peak insertion length in units that do not have access to ultrasonography and intracavity echography. Thank you very much, sir.
Good presentation. One thing I would like to ask, you have included less than 2.5 kg in your sample size. And you have used only 28 goes big line.
Yes.
Why not 24 also? Suppose a baby 2 kg.
Sir, as I described in my baseline characteristics table, The median birth weight, which were enrolled was just 900 grams, 980 grams, sir, if I'm not wrong. So these babies being very fragile, 24 gauge, at the cubital fossa would be a large bore catheter. So we could only use 28 gauge.
And 28 was PICC line is available with guide wire.
Sir, for the purpose of the study, we used a PICC line without guide wire. But yes, right now in the market, we have a supplier who gives 28 gauge with guide wire.
So in your study, you use without guide
I
wire.
use without guide wire.
So that also during final placement, without guide wire, the insertion technique require expertise and some variation at the time of insertion. How did you adjust without guide wire PICC line? That also 0.5 centimeter variation can be there. So final fixation.
Sir, as a unit policy, only those we have a central line insertion team as a unit policy, and only those residents who have assisted or observed at least 10 PICC line insertions are allowed to put a PICC line. So, there was no problem with the expertise of insertion of PICC line. And while the PICC line was inserted, I used to stand bedside because I had to do the focus so as to localize the PICC insertion. So that's the answer, sir.
And did you use a particular vein, basilic, cephalic?
So we preferred to use the basilic vein, sir, but the one which was more prominent and which was easily visible and wider bore, that was preferred. But as a unit policy, we tend to try to put PICCs on the right side and in the basilic vein. We use left only if the veins are better seen in the left.
So you could manage putting right side in majority of your sample size.
27 right, 25 left.
I think the formula should be different for the left as well as the right, or is it the same?
Sir, that's why we used in our statistical analysis, we included laterality as one of the variant, but after we did the statistical analysis, that didn't improve the coefficient of determination or didn't decrease the risk of malposition. But while doing the analysis, we had this in mind, sir. So we addressed that while doing the analysis. Thank you, sir.
Do we have with us Dr. Rohit? I can see Dr. Sandeepan Sen. You're in the list. Dr. Sandeepan Sen, can you hear us?
Yes, ma'am, I can hear you.
You can start sharing your screen. We'll let you know.
Okay. Am I audible, ma'am?
Yes, you are audible and we can see your slides. Can you just change it to one slide next to see if it's changing?
Yes, ma'am. It's is it?
Yes, it changed. Yeah. So we.
Hello, ma'am. You are not audible actually.
Now am I audible?
Yes, yes, ma'am. Yes.
Okay. So we are going to give you 8 minutes for your presentation, 2 minutes for question and answer. Your time starts now.
Good morning, everyone. I am Dr. Sandeepan Sen from NRS Medical College, and today I am going to present my paper on quality improvement initiative to improve kangaroo mother care at least 6 hours per day in postnatal ward among neonates with birth weight 1.8 to 2.5 kg in a tertiary neonatal care unit of Eastern India. As per operational guideline of SNCU by Ministry of Family Welfare and Health, all babies weighing less than 1.8 kg get directly admitted in SNCU or NICU if indicated directly from LR. Once stabilized, they receive KMC in SNCU and NICU, later in our 8-bedded KMC ward. On contrary, low birth weight babies of 1.8 to 2.5 kg birth weight are shifted to postnatal ward along with their mother. And it was observed that the practice of KMC wasn't adequate enough among the postnatal ward group. And as well, there was increased case of hypothermia and readmission in SNCU from the postnatal ward. That's why we had to plan to observe and quantify the practice of KMC in postnatal ward among those mothers and improve this practice using POCQI project. Initially, the potential barriers of KMC were identified, and it was found that undue delay in KMC initiation after birth, lack of sensitization, lackadaisical counseling, lack of staffs were the major problems to start KMC. A quality improvement team was formed and baseline phase were conducted for 1 month involving 101 mother-baby diet. As it is said that if you can't measure it, you can't improve it. So we have to came out with parameters that will quantify KMC procedure. And when we did it, the result was quite horrifying. Only 11.5% of the eligible babies were receiving KMC of any duration in the postnatal ward. And believe me, none of them were receiving KMC for at least 6 hours a day in that ward. Also, we calculated the average and it was only 1.9 hours per day. Now we set our, and this is the run chart. So we set our aim to improve the percentage of vaginally delivered baby receiving KMC at least 6 hours a day from 0 to 50% with average duration 6 hours within a period of 40 days. Before intervention, we analyzed the problem using flowchart. And we found out initially the babies were being kept under radiant warmer. There were provision of irregular STS, lack of proper counseling was there, irregular monitoring of diet were there, and they were further evaluated by fishbone diagram showing the cause-effect analysis. In the implementation phase, 4 PDSA cycles were conducted for total 40 days. We prioritized the problem and anticipated that early skin-to-skin contact after delivery can motivate the mother to continue this practice in form of KMC beyond labor room. And in our first PDSA cycle, early STS practice under the supervision of on-duty pediatrician in LR was started along with antenatal sensitization of expecting mother, also their family. Here we can see how the babies are put on mother's abdomen just after birth, and early STS was skin-to-skin contact was initiated even before cutting the cord. In this cycle, we also started mentioning KMC in the daily treatment order, and the result was quite encouraging. We could improve the practice to 25%, and the duration also increased to 4 hours. This is the run chart. Now in the PDSA cycle, in the first cycle, we saw that it was difficult to find out which mothers were doing KMC in the overcrowded, busy postnatal ward and then monitored them for fees. So in the second cycle, for easy observation and monitoring of the diet was prioritized. We came up with the concept of KMC corner, and we also could improve the practice of KMC in this case because we were separating the mothers who were doing KMC. And here the median of the babies receiving KMC increased almost to 50%. But we found out some problems that non-addressable mothers during KMC, resulting in discontinuation of KMC after a short period. To solve this problem, we plan to improve the nursing care of KMC diet in PDSA 3. It was done by allotting a dedicated nursing staff in each shift who will continuously monitor the KMC diets in the KMC corner. And in PDSA cycle 3, after this intervention, we could increase the mark to 64%. We achieved it, but we saw that the mean duration was short of our target. Anyways, the plan was adapted, though the future implementation was uncertain because we had always a persistence of manpower crisis in our setup. till now we address the problem en masse. In PDSA cycle 4, we intend to improve the duration of KMC by individualized approach. So we came up with the idea of bedside KMC sheet and centralized KMC registry maintained by a nursing staff, using which those who are not doing KMC adequately could be identified and they could be counseled and their issues could be addressed. These intervention actually increased our percentage of KMC to 75.5% and average duration increased. Average duration also increased. And this is the run chart of the whole 4 PDSA. And now in post-intervention period was conducted to check the sustainability for 3 long months on total 275 babies, and for to see if the 4 interventions were actually sustained. These are the whole step of the post-intervention period. And in this post-intervention phase, we found out that 68% of the babies were receiving KMC during this time, and the average duration increased to 8.6%, and 91% of the eligible babies were receiving KMC of any duration, which was first 11.5%. And this is the run chart of the whole study period. And this is the run chart of this whole study period on those baby who were receiving KMC of any duration. And we can see that there are so many 100% marks touch. And this is the comparison. And we saw that there was decrease in cold stress and hypoglycemia among the babies in the post-intervention phase. And also we followed up the babies for 1 year, and firstly short-term follow-up for 1 month and then monthly for 1 year. And we could see that there was decrease in duration of attaining birth weight. There was increase in duration of KMC at home, that is home-based KMC. Also, exclusive breastfeeding was improved. And most importantly, our interesting finding was that the healthcare coherence of the post-intervention phase was more than the baseline phase. Our limitation was it was a small scale single center study. More extensive large scale studies regarding implication of early skin to skin contact in improving KMC practices required to find out further association. Only vaginally delivered low birth weight babies are mentioned. Weights were included. We included in our study. We could not include the cesarean section babies. And further strict monitoring is required for ensure adherence of all the practice undertaken in this study, because it was shown that post-intervention the percentage decreased a bit. So what are the future plans? To obviously include the babies to include the babies born out of cesarean section, and also effective follow-up and community KMC, because we have seen that when the mothers were going back to the community, they were not being monitored. The community-based KMC was not at all good. So that might be improved. And now we are during this COVID pandemic also, we have started doing this cesarean section baby. We are putting these babies on mother's chest to do STS, and this project is undergoing in our setup currently. Hope we will have a good result in this case also. Thank you. Hello.
Hello.
Hello, sir.
Your time is up. I have 2 questions for you.
Yes, sir.
The first one is, which factor do you think was the most important in improving the KMC rates?
So statistically, it was found that the early initiation of early skin-to-skin contact was the factor that actually helped most to increase the percentage of KMC. And secondly, sir, the monitoring improvement of the monitoring was the second.
Wonderful. Second question is, if you were to redo the study, what are the factors you think you would have taken first?
Sir, monitoring monitoring and early sensitization of the mother. That is the main thing we observed that can motivate the mother to continue KMC, to start KMC early as well as to continue the KMC. So, and also there is, it is a proven fact that the family involvement is a very important thing. So during the antenatal period only, we are starting to sensitize the mothers from I mean, just the expecting mother before going to labor room, or when the mother were getting admitted, we were counseling the mother. But in the antenatal period, if they could be sensitized, that would be more, and that will have more impact.
Thank you so much. Thank you.
Thank you, sir. Thank you.
The other virtual participants, do we have you all here? That is Dr. Rohit, Dr. Kamirul, and Dr. Rameshwar Prasad. Do we have you all here? If you all are here and you all can hear us, kindly join links of Hall 1 and Hall 2 for your paper presentation. Thank you. So moving on, welcome everyone to day 2 and the final day of National NeoCon. So starting our day with our conference today, we have a sponsored talk by Roche India, and it is being presented by Dr. Sir, can you hear us? Dr. Chandra Kumar, sir?
Yes, I can hear you.
Yes, welcome, sir. So, Dr. Chandra Kumar, sir, is MD, DNB, DM, Senior Consultant and Head at KKCTH, Chennai. His areas of interest are nutrition and ventilation, and he has 25 publications in national and international journals. We welcome you, sir, and thank you for gracing us with your presence. This session is being chaired by Dr. Soma Shekhar, who will be joining us shortly. And sir, we can see your screens.
Yeah.
Yes, sir.
Please tell me when I should start.
So we can start now.
I can start?
Yes, sir.
Okay. Thank you. Thank you for that kind introduction, and good morning, everyone, those who are offline and online. And I thank the organizers of the NeoCon 2021 for this opportunity. So I'm here to talk on resuscitation with intact placenta and what is lotus birth. The objectives here in the talk for the next 20 minutes would be to discuss about what is lotus birth, what is the history behind it, where and how it is being practiced, what are the benefits and risks, what are the recommendations from official bodies like RCOG with regard to lotus birth. Then a few slides on resuscitation with intact placental circulation. So where do we stand with regard to science and evidence? So let us start this lecture with a quote. So it was told by Mr. Erasmus Darwin in 1801 that another thing very injurious to the child is the tying and cutting of the navel string too soon, which should always be left till the child has not only repeatedly breathed, but till all pulsation in the cord ceases. As otherwise, the child is much weaker than it ought to be, a part of the blood being left in the placenta, which ought to have been in the child. And at the same time, the placenta does not so naturally collapse and withdraw itself from the sides of the uterus, and is not therefore removed with so much safety and certainty. So this one single quote probably summarizes what we are going to discuss in next 20 minutes. So when you Google, you can see a plethora of pictures on lotus birth where, beautiful, cute looking babies are lying next to a placenta, which is, kind of placed next to the baby, or in a beautiful bowl or decorated with some leaves, medicated leaves. Okay. So here in this picture, you can see the couples are delivering in water bath, and, there is umbilical non-severance, otherwise called lotus birth, being practiced here. So let us come to the definition of lotus birth. It means lotus birth or umbilical non-severance is the practice of leaving the umbilical cord uncut so that it and the placenta remain connected to the baby until it detaches naturally. So usually up to 7 to 10 days after birth, the placenta and the cord remains attached to the baby. So where do we get this terminology from? So we get this terminology based on a woman called Claire Lotus Day. She was the one who transferred this practice of unity of newborn and placenta based on the model of an anthropoid ape in 1974. So these anthropoid apes, mammals, they do not, sever the placenta after the baby is born. Placenta remains attached to the baby, and then it dries and shrivels off. Some of the mammals may eat up the placenta. You would have seen or heard of. Okay, so based on this practice, people started applying this to human mammals as well. In 1980s, a yoga master and midwife called Jenin Parvati Baker, she introduced and popularized this in US. Then it became a bit popular in Australia also, and it was propagated by a person called Shivam Rachana. So there are anecdotal lotus births which are being conducted in India. So when you look into the steps of the lotus birth, you can see that, the basic requirement is that, like, umbilical cord is not clamped or cut, and it remains attached to the placenta. So midwife who conducts the delivery waits for spontaneous expulsion of the placenta, and especially the third stage of labor is, passively managed. There is no oxytocin. Mother is not given any medicines, or uterine massage, or nothing is being done. So placenta is allowed to separate spontaneously from the uterus, and then it stays remain with the baby. So placenta is kept in a bowl or a sterile cloth, and maternal infant bonding is encouraged because they strongly feel that during the active management of third stage of labor, the maternal infant bonding is disturbed a lot, so that they just do passive management of labor, and let the baby lie on mother's abdomen or chest. So here is a baby who has delivered through, underwent lotus birth, and you can see the placenta being attached to the baby. So placenta, because it will take few days for the cord to shrivel and fall off, this placenta has to be preserved. So what they do is they place it in a bowl or wrap it in a cloth, and then they repeatedly apply salt to the placenta, and they think that it will prevent infection. And then some herbs are also applied to prevent bad odor from placenta. So such as lavender oil, rosemary, some herbs are applied so that it does not produce any bad odor. So umbilical cord is allowed to dry and shrivel with the placenta. That usually takes as short as 3 days to up to 10 days for the cord to shrivel and fall off. You can see here the shriveled cord still being attached to the baby. So when you look at the case series report from Monroe et al. In Clinical Pediatrics on, almost 6 women who underwent lotus birth. So the duration of separation of the cord, you can see here that, it varies from a few days, as low as 5 days to up to 10 days in such deliveries. And when these mothers were questioned on, why did they opt for lotus birth, one mother commented that she wanted the blood from the placenta to go to the baby. Placenta is like a twin to the baby and nurtures him. Cutting is traumatic for the baby. The other mother opined that it is a DNA download. It helps the babies develop better, walk at 8.5 months, and talk earlier. So lotus births were in her family for years, but stopped during slavery. So there are a lot of personal beliefs behind this lotus birth. People have their own beliefs and preferences towards this lotus birth. So is there any scientific reason behind it? What are the benefits, if at all? So to consider the benefits of lotus birth, to understand the benefits of lotus birth, we need to understand what placental transfusion means. So placenta and umbilical cord contains almost 1/3 of the fetal circulating volume. Placental circulation contributes to almost 2/3 of the blood which is there in the placenta re-enters the fetal circulation. So when you look at this picture, you can understand that in an infant who does not have any spontaneous respiration after birth will have low pulmonary blood flow and low venous return. So because of this low pulmonary blood flow and low venous return, left ventricular preload will be reduced and there will be unstable cerebral blood flow, thereby affecting the cerebral perfusion in a baby who is not spontaneously breathing. This low umbilical pulmonary blood flow and venous return is due to lack of negative intrathoracic pressure, resulting in low umbilicus venous flow. Okay, so a baby who does not have spontaneous breathing may not have adequate intravascular volume to improve the cerebral perfusion. So, but in a baby who has where this intact cord resuscitation or milking of cord or delayed cord clamping has been practiced, there it leads to improvement in the venous return. So, a lot of blood returns into the pulmonary circulation, and then restoration of the left ventricular preload, which in turn causes improvement in pulmonary as well as cerebral blood flow, thereby stabilizing and helping the baby to breathe and recover from asphyxia. So when you look at the evidence for this placental transfusion, so there are the benefits of placental transfusion in term babies and preterm babies differ. So when you look at this, the benefits which you would expect in term babies, the benefits include higher mean birth weight, higher hemoglobin at birth, better iron stores at 3 and 6 months, and there is no significant risk of polycythemia, and it has been proven to be safe for the mother. On the other hand, there are some disadvantages in term babies. There is higher incidence of jaundice requiring, more phototherapy, but there is no impact on mortality, morbidity, or neurodevelopment. When you look at the benefits for preterm infants, this was the Cochrane published in 2019, which summarizes that there is less mortality before discharge if you practice placental transfusion in babies, less IVH all grades, less need for inotropes for low BP, so less need for transfusion and better BP percentiles on day 1. So there is no difference in incidence of severe IVH, CLD, periventricular leukomalacia, or NEC. So this is the latest Cochrane on the benefit of placental transfusion in babies who are born preterm. So it appears that it is helpful both in preterm and term babies. When you look at the effects, if at all any effects on the mother, so they say that we may think that risk of PPH may be high in such women because the labor is not actively managed, third stage is not actively managed. But what they say is that there is less risk of PPH because uterine vessels constrict better if placenta is empty. So if placenta is holding some blood in it, the uterus may not be able to contract well. And also they say that fetal-maternal hemorrhage may be less as the blood contained in placenta is less if cord is left unclamped. So they may be the benefits, for the mother in term when this placental transfusion is being practiced. So there are a lot of safer methods for placental transfusion. So all of you, you will be hearing it in next lecture. So all of you have heard of delayed cord clamping. So WHO recommends, ILCOR, NRP recommends that at least 1 minute, 30 seconds to 60 seconds of the delay in cord clamping should be practiced in babies who are spontaneously breathing after birth. So there are other modes to ensure placental transfusion as well. That is umbilical cord milking with intact placenta, umbilical cord milking with cut cord. So all these things are going to improve the placental transfusion. So should we take the risk of lotus birth by allowing the placenta to remain attached to the baby for a few days? Are there any risks? Yes, there are some risks which are reported after lotus birth in babies. So there was one report in 2016, a case of idiopathic neonatal hepatitis following lotus birth. Even though scientifically you may not be able to explain why it could have occurred, it could be due to some sort of infection which occurred in the baby, where the bilirubin remained elevated and baby had to be readmitted for the management of hyperbilirubinemia, and there was direct hyperbilirubinemia in this baby with elevation of liver enzymes. There was also one report following lotus birth, they reported Staphylococcus lugdunensis sepsis and endocarditis in a newborn following lotus birth. So this is usually coagulase negative Staphylococcus, which is often considered as commensal. This caused an endocarditis in this baby, which resulted in some degree of tricuspid regurgitation, and baby was admitted on day 20 of life with respiratory distress and was treated with antibiotics. So when it comes to the recommendation from official bodies like RCOG, what RCOG says is that if left for a period of time after the birth, there is a risk of infection in the placenta, which can consequently spread to the baby. The placenta is particularly prone to infection as it contains blood. Within a short time after birth, once the umbilical cord has stopped pulsating, the placenta has no circulation and is essentially dead tissue. So RCOG warns that probably there could be a higher risk of infection if you practice non-severance or lotus birth. So even though we understand that placental transfusion is beneficial for the baby, there are other safer options to ensure placental transfusion, like delayed cord clamping or umbilical cord milking. So the lotus birth as such is not recommended, endorsed by RCOG, and there are anecdotal reports of side effects such as infection. So we have to practice it carefully. Then we will discuss a few slides on resuscitation with intact cord or placenta. Where are we? So far we have seen that a baby who has transitioned well after birth can remain attached to the cord and placenta for a while.
You have 5 more minutes.
Yeah, sure. Yeah. So if the baby has not cried and baby requires some sort of resuscitation, is it safe to practice resuscitation with intact cord or placenta? Is it feasible? So the current practice, what we do is, if a baby does not cry after birth, requires resuscitation, we immediately clamp the cord and cut, and then take the baby for resuscitation. So what does this practice do? It does increase the systemic vascular resistance abruptly because cord is clamped. That is elevated pulmonary pressures, decreased pulmonary blood flow, decrease in cardiac output by 30 to 50%. There is fluctuation in heart rate, and there is fluctuation in cerebral blood flow. This causes hemodynamic instability, and it can cause superimposed insult on a baby who is already asphyxiated. Whether this can be circumvented. So these babies, if they are resuscitated with intact placenta, more likely they can be benefited. So they are more likely to benefit from continued placental gas exchange and placental transfusion because asphyxia, due to asphyxia, baby is not breathing. So placenta can take part in gas exchange to some extent. So that is probably the most ideal probably one area which we need to explore, whether this would really help in management of asphyxiated babies. But the questions which stand before us include whether it is feasible to resuscitate a baby with intact placenta. If it is feasible, what are all the resources, both in terms of equipment as well as manpower resources, which will be required, and is there any benefits, if at all, of doing resuscitation after assessing the benefits and risks. So one of the trial, which is called Australian Placental Transfusions Study, which is the largest trial so far reported in preterm infants, they did not find any difference between death or major morbidity, which is the composite outcome which they looked for in babies who underwent immediate versus delayed cord clamping. But the problem is that the implementation of this procedure, even in a controlled environment in this randomized trial, was very difficult. Even in the delayed cord clamp group, 25% did not follow the protocol and they went to immediate cord clamping because the treating physician felt that for the baby's sake, the cord has to be clamped immediately. So implementation always is going to be a problem, even if you choose to practice, even if the benefits of the required intervention is proven. So we have evidence, feasibility study from our own colleagues from ICH Chennai, published from Dr. Usha Devi and Mangala Bharati from in Journal of Perinatology. Here they devised a warmer, which is called ICAN RIPC warmer, that is ICH Center for Advanced Research in Neonatology, resuscitation with intact placental circulation warmer. So here they, devised a warmer wherein, there is a sliding trolley for keeping the baby with the placenta intact, and there is a warmer overhead to help the baby help the baby be resuscitated with intact placenta. What they found here, authors found here, was the intervention was feasible in almost 98.9% of the cases, and failure was noted only in 1.1%. Normothermia was achieved in almost 100% of the babies in 5 minutes, and resuscitation as per NRP protocol was they could follow in 92% of the cases, and maintain operating field without breach in sterility in 92% of the cases. And the interventions they could practice in the newborns include plastic wrap for thermoregulation, positive pressure for ventilation, what they could use in 97.8% of the cases, endotracheal intubation in 53%, chest compression in 14%, and umbilical venous catheterization in 11%. So it seems feasible to practice resuscitation with intact placenta. But whether do we have any difference in...
Time is up. Thank you, sir.
Yeah, just 2 slides more.
Sure,
So
sir.
we do not have any hardcore clinical outcomes reported as benefits or adverse effects. And there are numerous trials which are going on in this regard, which have explored the feasibility of resuscitating the baby with intact placenta. So what they have found out in one of the smallest study which has been recently reported is that, the body temperature on admission may be lower in babies who are resuscitated with intact placenta. So we need to be careful, even though it appears that it is feasible to practice resuscitation with intact cord, immediate and long-term clinical outcomes are still not known, and we should wait for larger studies which can prove the perceived beneficial effect of practicing intact placental circulation in babies who require resuscitation. So I would like to acknowledge Dr. Usha, who has contributed some of her slides based on her study on this subject, and thank you.
Can you hear me?
Yes, sir. Yes, sir.
Yeah, Dr. Somsekhar here.
Yes, sir.
Thank you for a very nice presentation, and you have spoken both lotus birth as well as on resuscitation with intact cord. As you have alluded, there's not much of support for lotus birth. So should we be actively discouraging lotus birth in any form? What would you think of? Because there are no randomized control studies for sure, and there are even no observation studies published except for a few case reports, and most of it is just personal experience. And it looks though there is good science supporting placental transfusion, but waiting for a day or 2 days for the placenta to drop off. So those things are not really scientific in any way. So what would you think should we do to actually discourage lotus birth?
Yes, sir. Thank you for the question, sir. I mean, I would say that I would prefer to put the facts in front of the patients and ask them to take an informed decision, because that would be better, because nowadays the parents are more demanding. If they want something and they want, they want to do that. Like, I mean, if you deny that practice, probably they will go to some other, obstetrician or pediatrician who would offer that facility for them. So we should put the fact in front of them and ask them to choose whether they want to undertake the risk or they do not want to do this practice.
Because many of the lotus births, they don't use oxytocin, they don't use, so those things for the normal obstetric practice are not being used.
Yes. So, I mean, I mean, obstetrician has to be convinced that they can manage labor in this way. But even though they do practice passive management of third labor, I think the official bodies recommend that oxytocin be used in the third stage of labor to prevent PPH. So, and Cochrane evidence also is there that the use of oxytocin would reduce significantly PPH in third stage of labor. So that's why this part obstetrician has to be convinced whether to, allow the couple to practice lotus birth or not.
Thank you. And a last question. There is more and more evidence coming for resuscitation with intact cord. So would you kind of, if somebody said that we want to, because people read online and they read stuff and they say that it's something which is useful, and somebody requests you that if something happens, you would want to follow that. What would your approach be? Because it is not yet as a part of guidelines or recommendation.
I think it needs a lot of practice and experience. Like, I think we need to train our team on this practice before, liberally using it. So I would definitely, be concerned to practice it on a preterm baby whom I expect that, baby would require some kind of resuscitation after birth. So I would be really skeptical in, accepting this as of now, because neither me nor my team are, kind of trained in this sort of practice, and we do not have an equipment which would suit for I mean, placing it near the mother, wherein we can place the baby as well as the cord intact and initiate resuscitation without compromising the transition and effective implementation of resuscitation protocols for the baby. So I would be skeptical in doing it right now.
Thank you very much, sir. Thank you very much.
Thank you so much, sir, for joining us. Now we are moving on to the next exciting talk is updates in umbilical cord management by Dr. Teja Pratap. He is DM Neonatology from AIIMS. Current position is HOD and Department of Neonatology at Fernandez Hospital. He is an executive member of NNFTS. He has more than 50 publications under his belt, and his interests are neonatal hemodynamics, quality improvement, and developing low-cost intervention and using AI in health. We welcome you, sir, and thank you so much for being a part of this discussion. Sir, can you hear us?
Yeah, thank you. Shall I start?
Yes, sir. Your screen is visible and we can hear you, sir. You
Yeah.
can start. Thank you, sir.
Thank you for a nice introduction. So after listening to Dr. Chandra's lecture on the lotus birth and intact cord resuscitation, most of us agree that umbilical cord management has to be more rational with evidence-based. As Dr. Somsekar sir was also asking us that if any parents ask for a intact cord resuscitation, what should we do? And if they ask for a lotus birth, what we should do? Let's go through the science and evidence right now, what is there on the umbilical cord management, and then we can form some regional protocol for our own institutes or for our own Indian state, so that we'll be able to implement it more rationally. So why this worry about? Why can't we delay the cord clamping, or why can't we manage the cord properly or umbilical cord properly? As a pediatrician, we might think that we need to do Apgar scoring and assessment early. And some people will feel that if the mother has a ABO incompatibility or RH incompatibility, the baby is more prone for hemolytic disease of newborn because more antibodies will go to that side. Is it hypothermia that is the problem there? Or OBG people will feel that sterile field is disrupted. Anesthetist will feel that if during the LSCS or this thing, there might be more transfer of the medicines there or this thing. So all these things were worried or this thing, but we are not looking at the benefits, because this blood which is getting transferred from the mother is at the mother's temperature, that is at the very good hot blood that is going and helping the baby or these things. And we all know that large amount of RBCs, iron amount, and lot of stem cells, all these things are there in our umbilical cord blood or these things. Apart from this, many of the growth factors, antioxidants, cytokines, which might help our babies in the immediate newborn period to tide over the crisis of this thing. Okay, so roughly many of us agree that 30 to 35% of the baby's blood will be there in the placenta at the term, whereas in the preterm it will be near to 50% of this thing. So this much amount of blood, we have to manage it more properly and more rationally to give the better benefits to the baby. So currently, these are the three available methods for us to have good placental transfer of the blood from the placenta to the fetus. That is the delayed cord clamping, cord milking, and the intact cord resuscitation. Last part already covered by the Dr. Chandra. So I'll be covering the first two parts in my talk. So if you look at our fetal circulation, so the placental circulation is a low pressure circulation, and very high pressures are in the pulmonary vasculature. It's a low pulmonary blood flow will be there. And with the help of 3-4 shunts, we will be able to manage the baby's systemic circulation and other things in the fetal phase. What will happen when the baby born? Once the baby born, baby cries, and there will be a well aerated lung. You can see some of the graphics have changed here. So there will be a little increase in the pulmonary vasculature, and thereby increase in the left atrial input, thereby left ventricular output also will increases, and that will indirectly will increase the cerebral blood flow for us, this thing, thereby shutting down other shunts. What will happen when we are not doing it rightly? So before the baby cries properly, if we are clamping the cord, so that the high PVR which was there will remain a little on the higher side. It will decrease the pulmonary blood flow, thereby reducing the left ventricular output, which indirectly causes the lesser cerebral blood flow, which can cause a little problem to our brain. There are numerous experimental studies which looked at the same, which narrated that there is a better pulmonary blood flow and better transition when we had done the bunch side of this thing. Currently, a lot of guidelines are there which says that at least 30 seconds we need to delay while we are after the baby is born before we can clamp the cord. Some will advocate even the umbilical cord milking also if the baby is born more than 29 weeks of gestation. Less than 29 weeks, we have a little evidence that which can increase a little intraventricular hemorrhage. However, right now the guidelines are not telling anything about the non-vigorous infants. So what are the factors which will influence this transfer of blood from the placenta to the neonate? As Chandra has previously mentioned that some of the factors like uterine contractions and the umbilical arterial vasoconstriction, spontaneous breathing of the baby, because the more the respiration, the lesser because the placental flow is from the low pressure area. So we need to have a better flow here. And also if you keep on the baby's different positions from the placental height, there will be a little influence of these blood flows to these babies. And also depending on the timing of the delayed cord clamping, there could be a little influence on the amount of blood that is transferred. So people looked at the flow patterns while before delayed cord clamping, both in the artery and the venous. You can see here up to 43% of the babies flow continued almost for 5 minutes on an average, even up to 10 minutes also. 17% did not have any flow. Even in the venous also, you can see 1/3 of the babies almost had near to 5 minutes blood flow. On an average, 65, almost 57% of the babies had at least 4.5 minutes of blood flow. Many of these studies also have told that the notion that we will feel that it will be related to cord pulsations is actually not true at this. Since even there is no cord pulsations also, some amount of blood flow will happen in these neonates. So depending on the timing of that means that 30 seconds, 60 seconds, 2 minutes, 3 minutes, 5 minutes, the placental flow, the transfer of blood volume will be different. So as you see here, up to 3 minutes, it is rising steeply, whereas after 3 minutes, the rise in the steep is a little lesser. You can see also here the change in the volume also. In the initial phase, it is very higher, whereas after 5 minutes, it is little lesser. Even the residual volume also has been studied by the people in the placenta. That also has been shown that after 3 minutes, there is not much of the change that will happen in the placenta. So roughly around 3 to 4 minutes is the reasonable time we can delay for the cord clamping if the baby is good. So also people worried about the effect of gravity because we don't know when the pulsation stops, and then if you are not chasing it and other things, whether it will have any effect on the blood flow or these things. Numerous studies have seen that if you kept a little on the held above and at the same level of the uterus, and they have compared also if you keep it on the little on the lesser side. So till 2 to 3 minutes, there will be a little difference, but after 3 minutes, there is not much different. So if you are keeping the babies below the uterus, even 1 to 2 minutes is sufficient. But if you are keeping on the upper, on the chest of the mother or this thing, maybe you need to delay a little further. But this has not translated into many of the things while we people have looked at the just based on the weight and other things, there was no much different and significant. And these are the studies which looked at different positions and timing also in these neonates, whether it will have any effect of gravity or this thing. So some of the conclusions from the many of the guidelines say that about 10 centimeters of the intrauterus, better to delay it a little further to 2 to 3 minutes at least. Less than 10 centimeters, you can practice the routine guidelines. If it is below 30 centimeters of the fetus, a baby is placed below 30 centimeters of uterus, you need to 1 minute is more than enough for us, so we can do a short clamping also there. But again, it has to be monitored properly while they are doing. So as we have discussed in the first few slides, lot of benefits are there. It can increase the iron stores. It mainly protects the anemia. Almost 10% decrease in the incidence of anemia at 1 year. Apart from that, there is an increase in the myelin and improved fine motor and functions, especially in the term units at 4 years of age. It has been documented in few of the studies. So Cochrane, if you look at it, which looked at the 15 trials, around 4,000 infants, which looked at 30 to 180 seconds. So the main difference was there is no difference in the mortality. However, hemoglobin at 24 to 48 hours was very higher. And also infants who were less than, who undergone ECC were iron deficient at 3 to 6 months. At the same time, the safety profile of PPH was also not different in among the two units. So there are multiple meta-analyses which have been done on the delayed cord clamping in the term units. These are the conclusions they have given. Higher hemoglobin at 4 to 12 months of age, higher ferritin, improved total body iron status at 1 year of age. And also in the where the regions are more prone for malaria, there is increased survival. And in the lead pollution areas also, because the iron can compete with the lead. So thereby these children are at lesser risk of the lead pollution. So let's see the preterm units, how it will benefit us. If you look into the preterm units, then the DCC before discharge was just marginally lower. If you look at 0.54 to 0.98 certainty that they have given it. At the same time, many of the other meta-analyses have also looked at it in the delayed cord clamping. So there was no difference in the IVH, especially because we had that notion that the extra volume of blood, whether it can cause the intraventricular hemorrhage, and possibly there is a little higher incidence of phototherapy. So that's what they have done from all the studies that have been done, all the analysis, meta-analysis that have been documented in this. If you look at the neurodevelopmental outcomes in the same units, few studies are there in the DCC. If you can, this is one of the study from the Mercer et al. It has shown that DCC was protective against for the motor scores for the babies to have lesser scores. So that means that almost odds ratio was 0.32 if you follow the delayed cord clamping. So there are again multiple trials which have been conducted in the same. They say that there is a limited data for the better motor, cognitive, and language scores and decreased incidence of cerebral palsy. So this is the recent trial that has reported 2 years outcomes who were born less than 30 weeks and followed the DCC versus ECC baby that Chandra has previously shown you. So that death before 2 years was a little lesser, almost by 5 points, 3 points, and death or severe disability was also a little lesser. So these are the benefits that are there in these things. Some of the misconceptions that we have is that whether during alloimmunization, that is the RH isomination or AB1 immunization, whether it will have more effect on these babies, whether we require more DVET or this thing. It has been recent study from our my mother institute, that is from the All India Institute from the Tanushree, has reported that there is no difference in the DVET or phototherapy. Actually, it will increase the hematocrit. This thing. Even in the SGR, LGA babies also, they have shown that improved iron stores are this thing. During HIV also, even all the guidelines says that there is no need to defer the DCC or these things. Again, we are living in the COVID pandemic. So even in the COVID also, studies have told that there is no increased risk. In fact, it might protect because more amount of IgG might be transferred to the baby. Can we practice in some of the other situations like CDH? There is a DING trial which has shown that better mean arterial blood pressure, though there is no difference in the clinical outcomes there. So even in any of the deliveries, whether it's a C-section or normal delivery, you can practice. You can see that there is a difference, and DCC is found to be very safe in these units also. Okay, and DCC has been shown to have between the umbilical cord milking and DCC, it has shown that higher umbilical cord milking led to better hematocrit and higher bed volume, both in the DCC and umbilical cord milking when you are doing compared to the ECC in LSCS babies. So what are the contraindications that we need to practice in the delayed cord clamping? If you look at it, so if the mother is hemodynamically unstable and severe antepartum hemorrhage that is occurring, in some of the cases like abnormal placentations, maybe you need to defer it. So, and as now the guidelines say that there is no immediate, if there is in the non-vigorous babies, we don't have the guidelines, we need to rationally manage it. And also in monochorionic twins with the twin-to-twin transfusion is at more risk. So people will say that there is no better to avoid in these cases till further rational evidence is available on this thing. Individualize the cases in the IUGR with abnormal Doppler. We practice it in our institute. We did not find anything difficult at this thing, but a baby has to be vigorous in those things. Also.
Sorry to interrupt, sir. There's 5 more minutes left for the talk.
Yeah, I'm aware of it. Okay. So if you look at the surveys that people have looked at it, so preterm cord clamping services that have been looked in the LMIC have shown that not even 50% are practicing the same as this. Even in our institute, as a part of one of the QA, when we have done to reduce the blood transfusions, we looked at it that our practices are still 65 to 70% in preterm units as this thing. So early cord clamping with asphyxia can reduce the, can cause problem. Again, this slide has been shown by this Chandra also, because preterm babies who are non-vigorous or who require a little early resuscitation, they are also at more risk of having the practicing of the early cord clamping. So what options do we have right now? So we have two options, that is the delayed cord clamping and milking. So DCC is a passive process, whereas the milking is an active process. It is gravity independent and short duration is more than enough for this thing. So among the cord milking, you have both the cut cord milking and also intact cord milking. So how do you practice this? So in a uncord, in the intact cord, if you see, while we are practicing it, you just need to take the, you don't need to clamp it. Before the clamping, you just need to strip it for 2 seconds each time. So 2 to 5 times it is practiced, which is sufficient. So if you want to practice the cut cord clamping, so then you need to cut the cord at least 30 centimeters away from the, at least 30 centimeters, 25 to 30 centimeters cord should be there, from where you need to again do the stripping in the 3 to 5 times so that it will be easier this thing for you. Between the cut and intact cord milking, obviously the intact cord milking might increase the blood volume much better way than the these things. So there is a little concerns about while we are doing the umbilical cord milking about the IVH, because it can increase the cerebral blood flow suddenly, which can increase the fluctuation and then cause the blood IVH. Let's see what is the evidence that is available right now for us. This is one of the Qatar article which has shown that there is slightly increased IVH incidence when you are practicing these in the 23 to 31 weeks. Severe IVH statistically significantly higher in these neonates also. So then, even if the Elgans, when you look at it from the study from the Kumba et al., so there also it has shown that there is a little slightly increased in the IVH of this thing. So from these studies, we can say that there is a little higher incidence of IVH. Even the Indian group, which has done the meta-analysis and been publishing, it has shown that all-cause mortality is not much different. So IVH of any grade, it doesn't differ, but severe IVH is a little higher. But however, the requirement of blood transfusions was a little on the lower side. So other concerns with the placental transfusions like over-transfusion, symptomatic polycythemia, jaundice, hypothermia, PPHN, delayed transition, and postpartum hemorrhage, from all these studies have shown that there is no evidence to suggest that any of these risks are increased on these things. I think Chandra has covered on these things on the inter-head resuscitation, so I will not be going through it. And these are the machines which are available in the market. And there is one more study yesterday people have reported from the Chandigarh unit also. So if you look at the Indian data on the late preterm and terminate on the placental transfusion, numerous people have done the studies, including Dr. Amit sir, who has almost done 3 to 4 studies from our from Meerut, while he was HOD of the department there. So all the studies have shown that the mean hemoglobin, hematocrit, and iron levels were a little on the higher side. People even looked at, you can see the Akash Chopra has done for the SGA babies also. It has also shown that it can increase the iron stores. People even looked at the cerebral hemodynamics also. And even in the preterm units also, our data from the Indian group suggests that the mean hematocrit was on the higher side. And one study from the PGA has looked at the 40 weeks outcomes about the mortality or neurological outcomes, which has not been different, both at the 24, even for follow-up of 2 to 2.5 years also. So numerous studies from even Indian data says that the benefits which have been shown in the meta-analysis are not different. So we need to practice this as our protocol of these things. How to follow the protocol? There is a mnemonic called transfuse. Tell the team, request for the supplies, assign the roles from our side, take the note the time, and take the support from the OBG people. Without them, we cannot be able to practice this. And document the fetal transfusion period for our quality and other things. Utilize the simulation methods and stop and cut once the baby is when the time is over, then re-evaluate and then go ahead with this thing. So this is the protocol right now we are doing. We will see that initially counsel parents and discuss about same management with the OBG people, and then we will assess that birth, and then if the no resuscitation is required, then we will go with the DCC for 1 to 3 minutes in our unit. If the resuscitation is required, then if it is more than 29 weeks, we are practicing the umbilical cord milking, and if there is then we will do the ongoing evaluation on this thing. So from my point of view, the take-home message is that DCC is very safe and easy to do. DCC has many benefits and should be the norm in all normal births. And umbilical cord milking seems to be a good alternative in moderate preterm and term non-vigorous infants. And ICC needs more resources and might be the future. Umbilical cord milking should not be practiced in extremely preterm units. So these are my two messages. Thank you all the organizers for giving me this opportunity.
Thank you so much, sir, for that wonderful talk. Do we have any questions from the audience? No questions, sir. Thank you so much for joining us.
Thank you.
Now moving on.
Moving over to the next talk, which is the need of the hour, that is resuscitation in COVID times. This talk will be given by Dr. Ramesh Chaudhary, sir. We welcome you, sir. And this session will be chaired by Dr. Vamshi, sir. Dr. Vamshi is a consultant neonatologist and pediatrician at Rainbow Children's Hospital, Vijayawada. The certified training in research methodology and biostatistics. Is a national trainer for neonatal resuscitation program India and neonatal emergency simulation team training in India. He's a member of the editorial review board, which is the Rainbow Pediatric Journal. Executive committee member of IAP AP State Branch, has published around 7 research papers in journals national and international. His areas of interest being the point of care ultrasound in neonates, care of extremely low birth weight and sick neonates. We welcome you, sir. I would request you to introduce Dr. Ramesh Chaudhary, sir.
Very good morning to all the elite panelists. I would take pleasure in introducing the speaker of the present session, Dr. Ramesh Chaudhary. He is an associate professor at SMS Medical College, Jaipur. He is also a EB member, NNF West Zone, Secretary of NNF Rajasthan, His areas of interest are community neonatology, nursing skill upgradation, developmental supportive care KMC, managing of basic NRP program and spreading the knowledge, SFCs. He has 18 national and international publications. So we welcome Dr. Ramesh to take over the session.
Dr. Ramesh, sir. Also, could you unmute yourself?
हेलो हेलो हाँ जी गुड मॉर्निंग कैसे हैं वो अभी तो कुछ प्रेजेंटेशन चल रही है लग रहा हॉल ए में जो लिंक आया था हाँ हाँ ठीक है ठीक है नो इश्यूज आई एम कनेक्टेड सुन रहा हूँ मैं क्या
Dr. Ramesh, can you hear us?
हाँ हाँ
Sir, kindly unmute yourself, sir. Yeah. So you can start sharing your screen with us.
आप पहुंच गए वहाँ हाँ अच्छा ओके कैसी अटेंडेंस कैसी है कम ही होगी आज लास्ट डे है हाँ नेवर माइंड ठीक है ठीक ओके चलिए ग्रेट ओके बाय
Am I audible now? Hello.
Hello, sir.
Am I audible now?
Yes, sir. You're audible now, sir. And we can see your screen as well.
So, good morning, all. Today's talk on the recession and the COVID time. As we all know that this novel coronavirus-related infection that we spread from the Wuhan is December 19 and declared as pandemic on March 11th by the WHO. And main routes of transmission was droplet and direct contact. And if at all are concerned is about the new node. So incidence of positive test amongst babies who are delivered through COVID positive mothers is ranging between the 0.5 to 30. And as per the NNF code density, in our country, it was around 10%. And in our center itself, it was around 6%. So this is our standard management of the newborn, those who are being born before the COVID era. So once the baby is delivered, baby is being dried, skin-to-skin contact, with delayed cord clamping, and baby is shifted to the newborn care corner if required. Then initiation of the breastfeeding and baby and mother shifted to the NICU or mother side. So if we analyze how the COVID has affected neonatal resuscitation and its teams, so our aim is to provide an effective neonatal resuscitation, which is providing a safe environment for the all healthcare providers and minimizing the risk of cross infection. So in the procedure, we have to wear now PPE kits, we have to provide skin-to-skin contact, we have to provide delayed cord clamping, we have to provide the respiratory support if required. So new additions were initially viral filter for intubation safety, providing the breastfeeding. So currently there is a rapid influx of the evidence, and that too in little there is no policy for the how to perform simulation drills, continuous policy evaluation, communication between the team, reduced number of staff while the station, how to call help, how to involve the family, and how to involve the learner. And that too, we have to resuscitate in the separate at a distance, and how to provide air exchange and how to transfer the baby. So problem while resuscitating a newborn born through a COVID positive mother, and our aim here is to provide a healthcare provider safety, infection control, and effective neonatal resuscitation. What are the procedures has been changed and impact? Just like initially we were doing with viral filters, with modified intubation, we here used to PP to protect ourselves. That may hamper delay in the neonatal resuscitation start. It also hampers our task while doing CPR. We have to communicate with our team. It also changes our teamwork efficiency and workflow. And distancing and social distancing affected the skin-to-skin contact at birth, communication between the team, and family involvement. So this all disruptions happened when even there was uncertainty of the vertical transmission of SARS-CoV. So risk of vertical transmission is there, but it is very negligible. For the good, the indication for start of resuscitation are same irrespective of the mother's body status. Assessment for resuscitation is the same. And what is this? It is the standard approach that it is changed in order to avoid the potential risk of transmission. So we will discuss as per the area characteristics, neonatal team and physician, delivery room and newborn care, infection control measures, 2 precautions for the healthcare provider and patient, environmental dysfunction, biomedical waste, and some questions are still awaited. So amongst the area characteristics, we should resuscitate a newborn in a separate designated area for suspect or proven COVID mother. A negative pressure room is the preferable. If that possibility is not possible, then we may provide air isolation, or if that is not possible, then it should be at least 2 meters away from the mother and a partition in between. So area we have to provide for the doffing and donning and equipment storage, disinfection, and biomedical waste management. For the neonatal team and preparation, we have to inform and prepare the area before mother land in the delivery area. So area should be prepared well before the mother's arrival in the labor room. The number of persons entering in the labor room or neonatal should be minimized. And as per the NNF FOCSI IAP guideline, 1 person for low risk and 2 for the high risk. And person entering should be experienced in the neonatal resuscitation or all intervention process. Additional members may be sitting outside that chamber, and they may be called by using some bell or any appropriate device as per the local needs. So once the baby is about to deliver and the area is being prepared, neonatal team should be called earlier, because once they reach, they have to wear their PPE kit and recheck their arrangement. So immediate management of baby following the delivery in the presence of suspect or confirmed, it remains safe. Mother should perform hand hygiene and wear triple mask at every time. Neonatal registration should follow the standard guidelines, and delayed cord clamping, early skin-to-skin contact should be practiced as we were doing before pre-COVID era. And we have to do oral and nasal suction only if there is visible secretion in the airway. And because we have to remember that suctioning is the process where we are generating droplets. So we have to be very judicious. And if we have to provide the positive pressure ventilation, self-inflating bag or TP resuscitation with a disposable circuit may be used. All the disposable parts, even if they are not used, must be discarded, and all the reusable parts should be disinfected thoroughly after each delivery. Indication for intubation is not there because of the maternal COVID status, and endotracheal administration of medication preferably be avoided and must be. And
hello.
Yes, plexiglass boxes with accessible portholes
Dinesh,
are initially being advised. Now they are not in our.
हाँ अभी वो neonatal resuscitation चल रहा है, मैं connected
हूँ. Doing well after delivery, they may be.
कोई बात नहीं. सुमिता घोष आ गई क्या कि नहीं है?
Milk and to skin contact, and buzzing is not recommended in the view of hypothermia and hospital-acquired infection. The presence of viable
I am connected. So
COVID virus in the breast milk and its transmission has not been proven till date. So we are following the early initiation of the breast milk. If the baby is doing well, we maybe keep the baby and mother due in same room with all respiratory etiquette. So amongst the infection control measures to prevent COVID from baby or mother or environment to transmit to the healthcare provider. So as we all know that it is being transmitted to the aerosol, droplets, or contaminated substrates or supplies. So we need to protect for both of them. We need to follow the standard precautions to reduce the transmission through direct contact with body fluid, and we have to follow the transmission base to reduce the risk from the droplet and airborne. Powered air purifying respirator masks are associated with a lower risk of contamination as compared to N95. If they are available, we may use them. So, question. As per NNF guideline, we have to wear N95 or FFP2 with face shield and polycarbonate glass or visor. Eye protection should be fully face cover with goggles and face shield. And we have to perform hand hygiene using 60 to 95% alcohol-based hand rub and washing hands for at least 20 seconds. Hand hygiene should be performed before and after every patient contact with the equipment, contact with the bed or any other potential infectious subject, and before putting and after removing PPE and all gowns. So precautions, equipment dedicated for the units who are being delivered to the COVID mothers are not to be mixed with the non-COVID areas. And strategies to ensure the healthcare personnel follow the recommended precautions and correctly adhere to the donning and doffing. This how we can using videos, posters, availability of the PPE supplies, and spoken instructions given by a senior nursing staff or a designated person while doffing and donning. So disposables, whatever is there in the resuscitation area, even if they are not used, like endotracheal tube, suction catheter, OG tube, or fixation devices, must be discarded at the end of resuscitation, even if they are not used. So amongst the environmental dysfunction, luckily there is no new disinfectant proved exclusively for COVID. All chlorine-based, alcohol-based, detergent-based, glutaldehyde, iodine containing are same, and WHO recommends 17% ethyl alcohol for small areas like the stethoscope and all, and for larger areas they recommend 0.5% hypochlorite. And CDC along with them also approve the hydrogen peroxide. So we have to, before disinfecting, we have to wear PPE kit and all the protection equipment. If the equipment or surface is soiled, we have to clean it with water and soap and then 0.5% hypochlorite. Hydrogen peroxide also can be used to clean the transport incubator, open care system, pulse oximeter, ECG weighing scale, and it is only to be used when the patient is not there. Biomedical waste, because we all know that they are the potential source for the community spread. So we have to follow the all national and recent state guidelines for the biomedical waste disposal, and they should be segregated at the point of generation and must be discarded in a bin or bag with label of COVID-19. This is an indicative area of COVID registration. So there are some answers still left with our researchers, that when to discontinue. Is it the same before COVID or after COVID? When to withhold the resuscitation? What should be the simulation drill frequency in the medical institution handling life-threatening infectious diseases? Like we are facing COVID-19 now. We may face certain deadly viruses in near future also. So we have to conduct the studies for simulation drills and their frequencies in the medical institutions handling such type of situations, and routine periodic testing for the asymptomatic healthcare workers. So I am thankful to all the researchers who were involved in the preparing such an guidelines while facing a deadly pandemic. I'm thankful to the NNF IAP FOPI for providing us with the nice guidelines. AIMS Delhi, Dr. Dinesh Shirla, all unsung coronavirus researchers from the world over, India, and COVID-19 virus itself, because he is the person, he is the agent who again draw our attention towards importance of asepsis in the neonatal resuscitation. Thanks to all.
Thank you so much, sir, for finishing well in time. That was a wonderful session. Do we have any questions from the audience? Dr. Vamsi, would you like to say something?
Yeah, I think I thank Dr. Ramesh for his excellent lecture delivered just now. Ramesh, sir, I think I would just like to ask you if you could add a point or two about the importance or how effectively can we establish direct breastfeeding post resuscitation in neonatal in neonates in this COVID-like era, because most of the people I think we hear they say to avoid breastfeeding, which is very easy. So having known the benefits of it, could you just add a point on it?
Yes. If you go to the local circumstances and if you go to the available evidence, like evidence suggests there is no chances of transmission through the breast milk. It could be postnatally acquired by the immediate environment or caregivers if they are not following COVID appropriate behavior. So first thing that we have to emphasize the breastfeeding, early initiation and its sustenance, vis-a-vis following the standard precautions like wearing triple layered mask, following hand hygiene and respiratory etiquette while caring for the baby and providing the breast milk. And if you go to the local, just like if someone saying that they are the international guidelines, we are working in Indian different scenario. So ours is not a different center. And in a year or 16-month period, in our institute itself, we have 513 deliveries of COVID positive mothers with all newborns being practiced of early rooming in and breastfeeding or EBM feeding. And only 13 out of them, 30, that is around 5.84%, they acquired COVID infection. So it is a negligible if we look at the Indian scenario, and NNF registry also says the same because they are covering wide. So our duty to provide the baby with the best nutrition, that is the best milk.
Thank you very much, sir, for highlighting the importance of breastfeeding. So the important take-home message is, if the mother is stable, definitely, as sir is saying, mother can practice hand hygiene, wear a mask, and directly breastfeeding can be encouraged. The mother is sick, the baby can be segregated, and express breast milk under strict aseptic precautions can be given to a caretaker, and the express breast milk can be fed to the baby. Formula milk comes only the last. So I think this is one important take-home message. Thank you, sir, and thank the organizers for this opportunity.
Thank you so much for sharing the session, and thank you, sir, for your talk. Now we'll move on to our next session, which is the plenary. Just before that, a reminder, kindly please follow COVID protocols. Please maintain a social distance from each other. Kindly wear masks at all times. We have masks at all our stations, and also please use sanitizers. Thank you so much.
talk only is primary, right?
Good morning, friends.
Given the slide changer, right?
Which was scheduled from 4 to 5.
Like yesterday, no,
has
make
been
a folder,
removed from 12
make
to
a
1
folder
in hall
for plenary.
C.
Next hour and a half talks about protecting newborn services during the pandemic. And I think what more opportune time. We have been hearing so much about the new variant which has come up, the Omicron. And we also know issues about following COVID protocol and the conferences, annual conferences in medical fraternity which go on at this time. So what more opportune time to talk about lessons that we have learned since the start of the pandemic, and how can we use these lessons for ensuring continued services for survival and development of newborns. So in this panel today, we will have the opening from our senior colleague from WHO Southeast Asia Regional Office, Dr. Rajesh Mehta. And we will have talks from Dr. Arvind Shenoy, Dr. Avinash Kavi, and Dr. Basavraj, who will share their experiences about the impact of newborn care practices during the pandemic and how we can use these in the coming months and year. And then we will have a session from our colleagues from NIMHANS, Dr. Janardhan, who's a professor there. So we must also remind ourselves that to care for children, we also need to care for the caregivers, and which is us. We all know that as healthcare professionals, how much the fraternity has gone through during the pandemic. And there is also importance that needs to be put to the fact that we should invest in psychosocial support, the mental health support, and safety of healthcare workers. So we will also have colleagues from NIMHANS talk about this, and our own Dr. Manoj from the Kerala NNF chapter, who will talk about what interventions within the fraternity we can do to ensure safety and wellness of the healthcare professionals. So with that, I would now like to invite Dr. Rajesh Mehta, who's the Regional Advisor for Maternal, Newborn, Child and Adolescent Health at the WHO CRO office. We have all heard Dr. Mehta yesterday, and today in his opening remarks for this important plenary, he will talk about the impact of the disruptions in the essential services, especially for the newborns and their mothers, and what can we do to take these lessons that we have learned to make sure that the rights of children to survive and full development during the forthcoming phase is done. So with that, I invite Dr. Mehta.
Yeah, thank you so much, Vivek. And thanks to the organizers for this opportunity, for this very topical theme. Everyone has been affected by this for last 2 years, almost 2 years. And we have learned along the way, and technology has certainly helped us. Therefore, I am able to connect remotely from New Delhi. Very good morning to all of you in Bangalore. I thought to set the stage for my co-panelists who will give you very specific learnings from Indian context. Let me share with you a survey with more than 150 countries. This is what they reported. On this axis, there is percentage of countries who have reported disruption of services. Red and darker yellow are 50%, 25 to 50% reduction in services. All essential services were affected in most, especially during the big waves when lockdowns happen and the system is overwhelmed with a lot of COVID-19 cases. So there is huge impact on the essential services, including the critical maternal newborn care services. This is our own summary of assessment in 2020 when there was a big wave and all countries reported there was essential services for SRM and CAH, which is sexual reproductive, maternal, newborn, child and adolescent health. Varying extent, the services were disrupted. Actually, the countries who have very good data systems also already reported some additional maternal and newborn deaths and stillbirths during that period. So this must have continued during the big waves which came later. So we are very concerned that the progress towards SDGs in India, for example, may have been put to a setback because of this pandemic. We all know from big services to small hospitals, health workforce has been diverted. Currently, we see many SRM and CS staff is actually working for vaccination for COVID in most countries because that's the priority. Because overall health worker numbers remain less than adequate. So we have to divert staff from essential services to immediate attention to address COVID pandemic. But it is so useful that technology was used for training of health care workforce related to COVID-19. We just had a couple of sessions prior to this, how resuscitation practices were improved, for example, for neonates and the caring practices and all that was possible. Some countries actually in the beginning reported PPE, personal protection equipment shortage, which led to further chaos. But luckily, all countries have prepared guidelines for continuing services for women, children, and adolescents. And those guidelines were, distributed at sub-national level, and many attempts were made to continue services. There were national plans based on guidelines, and some modification of services was also undertaken. Some attention to telehealth, teleconsultation services were done, but some services were also postponed or stopped, like adolescent health care, for example. Some sessions were stopped Antenatal care was converted to at-risk approach in some areas. So a lot of modifications of services also happened. So we have a lot of attention now, luckily, but still there is some disruption still going on in health services, including maternal newborn care services. There are a lot of reasons we by now know that contributed to service disruption, both from demand side and from service supply or the service side. Commonest feature was, the people reporting to OPD and indoor services actually reduced because of the scare, because they were afraid that COVID will be prevalent in these hospitals and they will get COVID. Why should we go? Let us postpone. There were severe travel restrictions and there were financial difficulties during the pandemic to access services. There was a lot of, fear among the people. Health workforce related issues came up very, apparently because there was staff deployment issues. Immediate attention was to be given to COVID-19 cases and the numbers were not adequate. So some elective procedures and care were done and some, so there are a lot of factors which led to disruption of services. With UNICEF, we actually undertook this modeling estimation that if services were disrupted to this extent, would there be more mortality? Although countries already had started sharing data that additional deaths have happened. So this particular study from 6 countries in South Asia suggested that if present that 25–50% disruption in services continued, there would be more than 200,000 additional deaths in under 5 children. And more than around 1,100 additional maternal deaths might happen because services have not been accessible. So India being a big country, there was a concern that additional deaths would have happened. We haven't had the solid data later on to prove or disprove this fact, but this concern has been lingering in our minds. In addition, we all know there was indirect impact of the pandemic. Economic depression led to job losses, unemployment, financial strain, nutritional insecurity happened. There was stress among people, fear, domestic violence. So all of that affected the population. And this clearly impacted the health part of the society and also impacted the healthcare workers equally. So this is a survey which we conducted among countries of the world, including our own countries. So this survey was among the healthcare workers to understand what had happened to the newborn care. These 2 slides are on newborn care, how it was affected. So number of hospital births actually decreased. This yellow color is reduced by 50% and significantly reduced from between 25 to 50% and reduced slightly, which is 25%. So most countries actually, the hospital deliveries decreased. And number of newborn admissions automatically, even extramural admissions also decreased. So serious disruption actually happened. So there were national level reporting, and this is health workers reporting themselves. So naturally, staffing at newborn units were affected. Shift hour, the hours were changed, staff being absent due to symptoms or quarantine. So some of our warriors, frontline warriors themselves suffered. So about 25% reduction because of the COVID, direct effect of COVID in the staff. So, and additional staff could not be provided. Only 6% respondents said that they had some additional staff. Otherwise, there was huge deficiency in staffing. And PPE availability, you look at different components, and people have suggested that, for example, apron and gowns were available to only 40% during that period of time. So this is the kind of problem. N95 masks, eye protection equipment. We just heard from neonatal resuscitation that goggles may be essential because While resuscitation, there is aerosolization. So N95 masks and eye protection may be required, and those were not available. KMC and breastfeeding suffered, although the WHO has been consistently sending out guidelines that we do not have any transplacental transmission reported so far, and there is no excretion of the virus in the breast milk. And yet the common practice was that KMC was, in positive cases, also it was recommended we could continue the no separation of baby and mother, rooming in, breastfeeding. These were the guidelines. But in positive cases, as high as 80% did not get KMC, and the babies were separated. Breastfeeding was not allowed. So similarly, in suspected cases, again, too much of disruption in our practices, which is not supported by the guidelines. And even in negative cases, because of the fear, 20% were never recommended KMC because the hospital environment, the provisions, people were worried that if they are rooming in the child, a baby and the mother, and there is COVID all around, what will happen? So a lot of practices were also disrupted. So this is about follow-up care for a small baby at home and when you want them back to hospitals. So a lot of issues were noted by the healthcare workers. Appointments were not given, scheduling was changed, the families themselves were reluctant to come back, and therefore, if there was no transport, they could not report to hospital. So a lot of neonatal care was affected, and my co-panelists will share with you some of the more specific effects. And Vivek is correct, we are part of the society and the whole society was affected. So healthcare workers themselves were under quite a lot of mental strain, and there was initial fear about the transmission. And over the time, we have seen serious burnout. One of these studies from England suggested in NHS, more than 50% healthcare workers suffered post-traumatic stress disorder. And NIMHANS has been working very strongly to provide some guidance and support which is required for our frontline warriors, nurses, doctors, paramedics. So everyone actually, this is the same survey where healthcare workers said they were 80%, more than 80% said that their work was affected and their personal stress level had increased, substantially higher in 30% and somewhat higher than usual in almost 70%. So this is the reality of this pandemic. Fear on health was reported by 85% workers during that big wave of pandemic. And the practices also kind of changed among the health workers because of all this stress and perceived fear of transmission. So we have learned that uninterrupted and in fact improving services would be critical to sustain. We should be better prepared because new waves will keep on coming. Now we are under threat of Omicron. We don't know yet, but we might get affected and we should be more prepared than earlier. So we must continue to prioritize these services, especially for vulnerable population like women and newborns. So NNF can particularly contribute to this. They have done a lot of good work in bringing out best neonatal guidelines during pandemic, which was acknowledged in global literature. They have been training all their own members. So a lot of things, can be supported by the professional associations. Then the supply chain and the service delivery mechanisms and essential medicines, etc., we must continue to maintain. There is no point if doctors are there, nurses are there, and there's no oxygen, then we are in trouble. Or if there are no antibiotics which are required, we are in trouble. So we must actually prepare much better. And I think the government is prepared much better than earlier. So we should not divert financial or human resources from essential services. The government of India actually did very well using the integrated government online training program, the iGOT platform. And the most recent is when led by Professor Ashok Derari, the previous president of NNF, they have brought out through the teams of experts, the Indian experts, a lot of training material on COVID management among newborns and children, because the last wave suggested we might have a next wave where more pediatric cases would happen, and we are well prepared. So training must continue. The safe environment, both physical as well as mentally supportive environment is essential. And it is found that sometimes community-based services may be easier to continue. So some of the services through community health workers, because they work in open areas, may be better organized sometimes if there is a big pressure on health facilities. Telehealth technology must evolve, and we have made use of it to some extent. NNF can further invest and look at how the smaller units or subordinate units can be supported by the experts at tertiary level to continue essential services during pandemic. So, for example, eICU was considered a success. All India Institute of Medical Sciences continued to provide collaborative support from experts in ICU care. Similarly, NICU care can also be probably supported from higher level facilities to lower level facilities in these difficult times. We must communicate well with the population at our own hospital, but on larger community also, which must address the fear among people. Trust in health facilities must be focused, and safe transport, etc., from demand side, so that people can come to the hospitals. Caring of carers is a very important. So today it is good that Vivek has invited, the organizers have invited NIMHANS, and we will hear specific examples from them. So my request is that as individuals in the healthcare system, whether private or government, it is our responsibility to continue to the healing business and also support the government efforts to continue essential maternal newborn care services. So over to you for further deliberations. Thank you so much, Vivek, UNICEF and organizers, NNF, for this opportunity.
Thank you, Dr. Mehta. And what most opportune time than this to be having a session on how can we protect the newborn services during a pandemic. And it is not over yet. The choosing of the alphabet also, Omicron. Let us hope it doesn't become omnious. And all the preparedness efforts that have gone during the last 2 years, I think we are very well poised, and I would pick on the fact that two very important points, that there were plans for service continuity, RMNCHA service continuity, which were talked about, thought through. All the states have prepared with a lot of efforts from multiple agencies, civil associations. Just this morning, Dr. Pejawar, Deepti, myself, we were discussing last year, we have seen that coming together of professional organizations and mainstreamed with the government work, we have never seen, and at least Deepti has more experience than me in this, that in last decade, we have not seen this kind of professional associations. So, if all of us on this can keep ourselves mute. So one specific example I'll give, we were in Shillong with the child health in charge, Dr. Sumita Ghosh, yesterday, and we asked the only pediatrician that we met there, are you an IAP member? And he said, I am an IAP member. Are you an NNF member? I have applied for it. I haven't heard, but I mean, that's a minor thing. But what I asked is, what are the kind of capacity building initiatives you have been part of that makes you feel confident that, you know, let's say if this Omicron wave comes, will we be able to provide better services to our newborns and the children? And he said yes and no. So I think there's a great opportunity that all our constituents, the membership in the public sector, if we can make sure that especially those in the public sector where a lot of these services disruptions can also happen, to see if they are on board with you, and on the other side, all the resource materials which were developed. The platform mentioned was this iGOT platform, and I remember it also has these flyers with QR codes of different topics of capacity building resources that are there on iGOT. So there's huge opportunity to use all the preparedness that has happened. And I'm sure we will have good lessons from this study also, which is published. And I'm sure Dr. Mehta will share this with the organizers, and we will have this disseminated to the delegates. So with this now, and with thanks to Dr. Mehta for his very useful opening presentation in the panel, I would now like to invite our other three panelists today, Dr. Shenoy, who's a senior neonatologist and has been part of many national committees as well. And then Dr. Avinash Kavi, who's a WHO collaborative center. And then finally, our own secretary of IAP, Dr. Basavaraj, will speak.
This one is.
Over to you, sir. So next 30 minutes, we will have these demonstrations.
Yes, sir. At the outset, I'd like to thank our President, Dr. Ranjan Kumar Pejal, and the NNF team for having invited me to discuss this very, very important topic. And I must confess that there will be some, Dr. Rajesh Mehta has really set the stage, and there may be a slight overlap in what I'm speaking on. For Dr. Kavi, who will be following me, will specifically speak about Indian studies. So I'm actually going to talk about data from the rest of the world and what lessons we have learned from it. May I have the next slide, please? The key messages are, we know that there was widespread disruption. And rather than actually talk about what actually COVID did to the mother and baby, my talk will focus on what really happened to the newborn services. And what is interesting is that there was a difference between what happened in high-income countries versus that what happened in low and middle-income countries. What we see was that there was increased stillbirth rate reported in the low and middle-income countries. There was an increase in LBW, prematurity, and neonatal mortality, but there was a varied effect across the low and middle-income countries and the high-income countries. There seemed to be a uniform, both in high as well as in low and middle-income countries, reduction in breastfeeding, and there was a reduced rate of skin-to-skin contact and KMC. This is all in addition to the direct damage caused by the infection in the mother and to the baby. And as you know, reports are coming out about conditions like MIS-C or MIS-N, where the neonate is affected by the mother's COVID infection. Let's see the developed world first. In the Netherlands, they had a very, very interesting thing, and I think people in WHO should note it, that if you see, they had this period of lockdown. The pointer doesn't seem to be working. You see, they had 3 periods. And as soon as they started the lockdown process in the Netherlands, there seemed to be a drastic reduction in the preterm births. This has not been explained. And as the lockdown progressed, the baseline preterm birth, as you can see in the middle chart, started rising and then reached the similar levels as to earlier, even when the lockdown measures were continued, and then slowly came back to the baseline order. It is very difficult to explain, and it would be worth studying whether there was something in the COVID protocol or measures which resulted in the developed countries, a sudden reduction in the preterm birth. And this, I think, is a very, very interesting clinical phenomenon. By the time they reached total lockdown, again, the rate had started rising. So something in the containment measures itself, or maybe what was the fear of it, started the process of reduction in preterm births. If you looked at Ireland, there was a similar large dip you can see, and they have done it over many years. The VLBW rate also plummeted with the onset of the lockdown measures. Similar data has been reported for ELBW rates, and this was also seen in Japan and also in Denmark. So it looks as though that in some high income countries, when the onset of the containment or lockdown measures were done for the COVID, there was a decrease in preterm need, a very interesting phenomenon worth studying, because as far as I know, no other intervention has reduced preterm births to such a large extent, as far as I know. But did this happen in New York? Across the Atlantic, this effect was not seen. In this elegant data analysis, they have shown that there was very little change or a slight marginal increase in the increase of prematurity and in the NICU admissions in New York. And this is very, very interesting, because it doesn't look as though it is something just to do with income. Maybe there were other factors which were responsible for changing the prematurity rate in the countries where it did. But the story from our part of the world, and this is a beautiful study which came in the Lancet Global Health from Nepal, which showed there was a marked fall in institutional births in Nepal, and this actually must have influenced the increase in the preterm birth rate. As you can see, the stillbirth rate also nearly went up by 50%, as you can see, 1.5 times, and the neonatal mortality climbed by 3 times more in Nepal. So obviously, the factors which were playing in the developed world did not seem to work in the low and middle income countries, and there was a marked increase in these rates. So the varying incidence of prematurity and low birth weight with some countries like Japan, Netherlands, Denmark, Ireland had a marked fall in prematurity in VLBW rates, but this was not marked across. And in Nepal, as we saw, and probably in our country, and I'm sure Dr. Kavi will address that, we might have seen increase these rates. Now, if you look at this meta-analysis, what happened is there were a couple of meta-analyses. I'll just quote one of them to begin with. And what these showed was there is a slight varying effect. And if you run through this column of numbers, you'll see that most of these ratios are crossing 1, meaning that it looks as though that if you pull the data across the globe, the effect seen on prematurity, low birth weight, VLBW and ELBW is not something which is across the globe, but there is a trend towards increased neonatal mortality, as you can see in the lower slide, but that also the confidence interval crosses 1. So it does look as though probably we should not club these data and probably look for specific things. So there is this nice another meta-analysis which specifically looked at low and middle income countries versus high income countries, pooling 40 studies. And when you see that, what you see in the high income countries, it does look as though overall there was a reduction in prematurity. And if you see the stillbirth rates, they were slightly increased, but this stillbirth increase was predominantly because of data from low and middle income countries. So it does look, and neonatal mortality, whether you split it into high income or low and middle income, doesn't seem to have been much affected. So it looks as though in high income countries, this effect of reduction in prematurity was there for reasons which we can't explain. Now, coming back to the Nepal study, it was an extensive study which looked at many other factors, some of them which have been mentioned by my esteemed previous speaker. And what we notice in this slightly busy slide is that if you look above, some of the care practices changed. And the good thing was in the pandemic, the hand washing rates, as you can see in the first line, significantly increased. Though they are not really very ideal, we would have preferred much higher, but it does look as though hand washing increased. Though the use of gloves and gown, the next line, did not was also changed. It looks as though use of PPE and hand washing and care has increased. And as you go down the chart, you see the lower 3, and that is really worrying. As my previous speaker had mentioned, skin-to-skin contact came down markedly, breastfeeding came down markedly, and even cord clamping came down significantly. I'm not sure why this happened, but there could be many reasons for it. But this is really worrying as if we gear up for further epidemics. We should keep this in mind that this could happen. Going deeper into the Nepal data, you can see that the breastfeeding rates dropped significantly during the pandemic, and they have again started climbing. I think this is a good thing to keep in mind, that not all is lost. We should work towards enhancing. Should there be a pandemic, look towards increasing. Was this only the story in low or middle income countries? The answer is even in Italy, as you can see, that the exclusive breastfeeding rates dropped. So the drop in breastfeeding seems to be a phenomenon across the globe with a pandemic. Various reasons have been cited by the authors. Probably we can take it in the discussion. If you see, even in Thailand, there were fall in breastfeeding practices significantly. And these authors actually looked at what might be the causes. Was it the crowding, everybody staying at home? Was it due to family stress, lack of family support, did not get support from the healthcare worker for lactation, and did not get enough maternal health support? Was some of the significant factors identified by this study. So it does look as though many of these factors, direct as well indirect, caused by the pandemic, do it. If you look at this large meta-analysis, which is from 18 countries, the inter-COVID multinational cohort study, and if you look at it, what does seem, as I discussed earlier, was the reduction in preterm rate and fall in birth weight, maybe as a result of prematurity, one can't say. But last, most worrying, a dramatic fall in the breastfeeding rates, as you can see in this meta-analysis. So again, it does look that we are, when we are faced with a pandemic, there's a dramatic fall, certain very, very important parameters. And of course, when breast milk feeding is falling, so also human milk banking. And the virtual collaborative network collected experience from milk banks across 35 countries. And you can see that they had identified 7 pandemic-related vulnerabilities. Donor milk availability increased demands, but there were concerns about spread through breast milk. Pre-screening for COVID-19 exposure in milk donors was a big hassle, added to the cost. Donors were dissuaded by logistics of serological screening, difficulties in communication between human milk banks and potential donors, milk collection and transportation problems, and donor human milk handling, with exaggerated concerns about infectiousness, even though, as was mentioned earlier, enough messages were given by the WHO saying that the virus is not transmitted through the breast milk. And lack of contingency planning was also there, and need for extra stock. A nice study, a survey done by Dr. Suman Rao from here, St. John's, spanning nearly 62 countries, came out with 5 levels of problems which were there, which rendered less KMC during the pandemic. At a policy level, the paper pointed out that there was an unclear policy response. No major organization said that KMC can be done safely. Community level response, there were a lot of societal barriers to access to healthcare and hospital care. Staff and equipment, most of the staff was removed and moved on to so-called COVID duties. Staff stress, my previous speaker has already mentioned, and we'll probably discuss much later on. And at the family, there was reduced mother, the last line, please look at it, mother and newborn covered, even in COVID negative cases. And if you look at the actual data, this is really worrisome, that even though the mother was negative, the skin-to-skin contact or routine KMC rates fell down considerably. And if the mother was positive, as you can see, dismally low. Look at the last line. What is very, very worrying, that formula feeding rates went up during this period. So this is a very worrying, and the key messages of my talk would be that there is an increase in stillbirth rate. We need to know that there is a change caused by pandemics in the prematurity rates, maybe for the good in development, but not necessarily so in the LMIC countries. What we should focus on, I think, is the reduced rates of breastfeeding and reduced rates of skin-to-skin contact. Why? Because not just for the benefits, we probably will also land up with a disadvantage through the pandemic. They don't have the good bacteria from the mother, either through the skin or through the breast milk. And with this thought, I thank you all for a patient hearing, acknowledging the help of Dr. Saurabh Datta from DGI, who helped me through many important points in this talk. Thank you so much, sir.
Thank you so much, Dr. Shenoy. And I think these are very useful collation of all the evidences. I'll take home one message. You know, as fraternity, all the NNF members, IAP members, a colleague of mine who's a practicing cardiologist was asking the difference between a cardiologist doing public health vis-a-vis public health. And I think all of us now looking at this need to wear that hat of being in public health. And the difference I told him was that if you see an aberration in your clinical practice of cases that come to you, the first case became a case study. If you see 2 or 3 cases and you make that a case series, if you went outside of your own clinical practice of not just interacting with that patient, but going to your fraternity to discuss that 1 case or 3 cases, that becomes public health. Because your practice now has public health implications. It might inform the science there and it might be used wider quickly. And I think that's what COVID has taught us. And especially with this new variants of concern that has come every day. And in fact, evidence is churning by the hour. What we saw that if we club evidences from all the places in the world, there will be so much noise that we will lose that what is relevant to our context. And in India also, the context, we were speaking facilities, communities, it could be so different. So we all have to wear this Public Health Act, share as much evidence as you see day to day, collaborate with others. Is it what you are also seeing, or am I the only person who's seeing it? And I think the last point which I take from this particular topic is that as IAP and NNF, if we can continue publishing this research synthesis of what is most relevant to a country in our quarterly that we have. So with that, now I would invite Dr. Kavi for his talk. And he will be sharing his experience from a WHO collaborative site.
Very good morning, ladies and gentlemen. So at the outset, I would like to thank NNF and WHO and UNICEF for giving me this opportunity so that I can share some of my experience, what we did during COVID pandemic. So this whole session is about impact on the newborn care practices during COVID pandemic and lessons learned. As Dr. Vivek was just mentioning, it's all about collaboration between the professional organizations and institutes so that we can have a good outcome. Especially when it comes to research, whenever we present Indian data, the international fraternity will look at it in a very skeptical manner. So it is the onus on the professional organization like us, where we can really give about a valid data so that we can give the actual picture in the worldwide. So instead of directly sharing the results, I'll be sharing 2 studies, one recently completed and one which is ongoing. At the beginning of my presentation, there is a disclaimer: the contents of this presentation are confidential since the study results are at various stages of publication. So for this obvious reason, I'll not be able to share the direct results, but indirectly I can share what happened in reality. So COVID pandemic is a pandemic of a century, has affected every aspect of human life. and especially the pregnant women and newborn were considered vulnerable due to various clinico-social and cultural dimensions. India reported the first COVID infection pregnancy on April 2nd, 2020 at AIIMS, New Delhi. And there was a limited data on the epidemiological susceptibility of COVID-19 in pregnancy and of course the perinatal outcomes. Past clinical experiences, especially like COVID, other COVID-like viruses like SARS and MERS raised serious concerns about the susceptibility and outcomes in pregnancy. And currently available findings are restricted to high-income countries. And just now, Dr. Shana has beautifully rendered what the current evidence suggests regarding that. So, an additional concern was the vertical transmission from mothers to the baby. So, with this, WHO country office took an initiative to start this study, that is standardization of data collection and protocol for improving the quality of evidence on clinical characteristic outcomes of COVID-19 in pregnancy, abbreviated as COPE. So these are investigators on whose behalf I'll be presenting this data. The objectives were to undertake the surveillance of the clinical outcomes, pregnant and postpartum women admitted to the hospital during COVID infection, and identify the document the factors associated with COVID infection, including that of the vertical transmission, and to standardize the treatment protocol for COVID in pregnancy. So this was an ambidextrous case control study. Retrospective data was collected from April to September 2020, and the prospective data from September to November 2020. So how did they select the site? Presently in India, there are 4 active WHO collaborating centers who are working in the field of maternal and newborn health. That is AIIMS New Delhi, PJ Chandigarh, MJMS Sevagram, and JNMC Belgaum. And WHO country office approached each of these WHO collaborating centers to come in collaboration and also in turn collaborate with the other partner hospitals which they are already working with. And that is how the JNMC Women's and Children Health Research Unit, which is being functional since last 20 years, doing community-based research, especially with respect to maternal and perinatal outcome. We collaborated with 6 hospitals, 4 from Karnataka and 2 from Odisha. They are reputed medical college hospitals. And other 3 WHO collaborating centers instead also collaborated with 5 to 6 satellite centers across India. So this gave a pan-India representation of the data which we are presenting today, covering nearly 7 states and 1 union territory of Chandigarh. Almost across north, east, west, and south population is covered under this scope study. All pregnant women and postpartum women who reported to these hospitals, the designated COVID care hospitals, were included for the surveillance. Those who were tested positive for COVID using RT-PCR or RAT were taken as cases, and similarly those who were tested negative were taken as controls. So this was the study flowchart. We followed the ICMR protocol and the Government of India guidelines in triaging and screening and the following whatever the treatment protocol that was followed at various recommendations of the state governments as well as the professional organizations. The cases were recorded based on the WHO CRFs. So whatever data we have are comparable at international level because we use the same CRF what WHO advised for standard data collection during pregnancy in COVID. Of course, for controls, there was no standard CRF. We designed a validated CRF and which was approved with the consensus of all the investigators. And these pregnant women and newborns were followed up for 6 weeks post-delivery for clinical recovery and well-being. So there were additional laboratory specimens collected, including minimum, that is nasopharyngeal swab for maternal and neonatal, as well as histopathology of placenta was undertaken by some centers. Additionally, optional, there were some amniotic fluid RT-PCR, breast milk, cord blood, and cord blood IgM also was done in some other studies. So total number of deliveries under the surveillance of the WHO collaborating centers across these centers in Karnataka and Odisha, we had around 27,000 pregnancy, of which 60% were vaginal deliveries during this COVID pandemic of April to November 2020. When we looked at how many COVID cases we actually surveyed was 938 spread across these many sites. And among them, 818 COVID positive pregnant women and 1,190 COVID negative controls were enrolled in our study. Similarly, when we looked into other collaborating centers working in the similar fields, so AIIMS was the highest with 1,295. And of course, altogether, we have the data of 3,512 as compared to 4,000 controls for this study. So the study outcomes, the main salient features of the outcomes, what I'd like to highlight here is the cases and controls were matched for age. So that ambiguity or the is lost. So the cesarean rates were considerably higher among the cases. Maternal mortality was significantly higher. There were 34 maternal deaths which were reported among the cases of the 3,500 odd. And there was no change. See, please note down, no change in the stillbirth or preterm delivery rates across the cases and controls that was observed. That was a very strange observation that we made. Similarly, maternal complications, which we saw among the cases where these many, these were the general maternal complications, that is gestational hypertension, including hemorrhage, placental abrasion, and eclampsia and preeclampsia. When we looked into neonatal outcomes, comparable outcome, there was no change between cases and controls, that is mean gestational age at birth, that is there was prematurity was almost the same rates among cases and controls. Mean birth weight was almost comparable. Mean Apgar scores and median Apgar scores, and obviously the congenital abnormalities were also much comparable with respect to cases and controls. But in COVID positive mothers, more than 70% of the neonates, the birth weight was more than 2.5 kg normal, and nearly 80% of neonates were apt for gestational age. Coming to the SARS-CoV testing, so all these mothers who were tested positive were recruited in the study. But what about the neonates who were born to these mothers? First time, nearly 80% of the cases were tested compared to less than 10% of the controls. The first time positivity rate among the cases was 3.5%. As compared to, strangely, 1.6% of the neonates born to COVID negative mothers were also found to be positive. When we did repeat COVID testing for the same neonates, around 1/4 of the cases as compared to 0.3% of the controls, 3% were tested positive at the second time after 2 weeks, and nil positivity among the controls. Early newborn care practices, what hampered was delayed cord clamping was seen in less than 50% among the cases. Skin to skin contact was approximately done in only 1/3 of the positive mothers. Neonatal required resuscitation was more than double among the cases. Early initiation of breastfeeding was done in less than 2/3 of the babies. Kangaroo mother care, only 10% of them who were actually eligible for KMC actually received KMC during this COVID pandemic. And vaccination at birth, nearly only 2/3 of the babies actually received the vaccination which was supposed to during birth. When nearly 50% of neonates were kept with COVID-19 infected mothers compared to more than 90% in controls because of lot of apprehension because of COVID and the lockdown and other things. And neonatal management was, all these parameters were considered to be higher in COVID, in the neonates born to these COVID mothers. So the lessons learned with this collaborative effort undertaken by WHO Country Office, enabling policy environment was much important. High-level advocacy involving the national and global experts, which will generate the momentum and sensitizing the key decision makers to make the decision in a timely manner. And the it's all about the collaborations, and they are the fundamental for achieving an impact and create opportunities. And that is what we achieved by this collaboration between the WHO collaborating centers. And dedicated training, of course, there was a training was rather hampered during this COVID lockdown. And we built the capacity by the training of healthcare workers, especially for the data collection and also for the collection of samples. Priority setting and alignment is very important because we need to prioritize our needs, and because the resources were minimal. So the optimal utilization of the resources so that we can align with the objectives so that we can attain the sustainable research outcomes. And that too for a country like India, where we have such a huge geographical representation with a huge cultural differences. We need to have some champions or the decision makers who can identify the program synergies and ensure the interested policy makers, especially from the ministry, and relentlessly focusing on the results and achieving the target and the quality assessment and performance, which will form the core of all the collaborative research activities. So we did face a lot of challenges, especially obtaining the study approvals during this, because once we want to do any study, obtaining approvals became a major constraint. Identification and recruitment of staff. People were not able to work in the hospitals which they were already working, and how to get people to conduct this research. And staff training, virtual mode was completely new then. So training was a constraint and quality monitoring, of course, but still we did manage. And what the opportunity and strengths of us collaboration is pan-India representation, which gives the validity of the data, considerably larger sample size, a unique model. Very typically, such things happen in India. A very unique model where the central institutes, state government medical colleges, private hospitals, deemed universities come together for research collaboration. And formulation of a technical report which is in the pipeline, which will form the basis for management of COVID in pregnancy, not only in COVID, for managing any of such pandemics in future, which we are anticipating. So this was about the hospital data. What about the real world scenario? Any community-based data do we have from India? For this, I'd like to just give you an overview of the National Institute of Child Health and Human Development and the Global Network for Women's and Children Health Research, which is functional since 2001. And we, the Belagavi JNMC Research Unit and the Jain Medical College of KL University, is a part of this global network since 2001. And presently, we are in the 4th phase of funding till 2023. And this is a unique model where we have representation of 3 continents, that is Central America, Africa, and Asian sites, and typically having one collaborator from a reputed US university. And our collaboration is with Thomas Jefferson University, one of the 2nd oldest university of United States. So from Central America, we have Guatemala, and from Africa, we have Kenya, Zambia, and DRC. And from India, we have 2 sites, one from Belagavi and one from Nagpur. And Pakistan and Bangladesh are the Asian sites. So this, as a part of this initiative of Global Network, we have a prospective community-based research, community-based registry, which is being functional since 2008. This is functional in 100 clusters. One cluster is equal to one primary health center area, covering approximately a population of 20 to 30,000. So where do we enroll and follow pregnant women and newborns up to 42 days postpartum? And till date, we have 781,000 mothers and infant dietes enrolled across the globe. And from Belagavi site alone, we have the data of 184,000 pregnant and infant dietes as on December 1, 2021. This registry is functional, and the funding is ensured till 2023. The outcomes we capture here is maternal newborn mortality, stillbirths, and measures of the healthcare. So this is what the area we cover across 2 districts in Belagavi site, of covering 16 clusters across Belgaum and Bagalkote districts of Karnataka. So as a part of this registry, as a part of Global Network, we initiated this study of COVID-19 prevalence during pregnancy and pregnancy outcome in 8 LMIC countries, a Global Network study, which is an ongoing study. So the aims were to determine the prevalence, to compare the maternal and neonatal outcomes, and also to assess the knowledge, attitude, and practice regarding the pregnant woman related to COVID infection. So this is a study which is ongoing along with MNH registry. So all the women who are a part of MNH registry were asked to participate in this study. And additional to what the registry did, we also collected a maternal serum sample plus or minus 14 days and in and around delivery, so that we can estimate the COVID-19 antibodies as well. So because this registry is functional since last 13 years, we studied what happened in the COVID era as compared to pre-COVID era. The pre-COVID era was March 2019 to February 2020, and March 2020 to February 2021 is the COVID era. So when we looked at all the data from all these LMICs, so we had around 57,000 pregnancies of which 29,000 odd were in the pre-COVID and 27,000 in the COVID era. So I will just give you the overall overview of the study, what happened to these this analysis, what we have. So Asian sites saw a double rates of home deliveries across the pandemic. African sites showed an absolute increase of 4 times in the home delivery rates. Central America was also significantly higher rates in home births as compared to other sites. Look what happened to stillbirths and neonatal deaths. They almost remained same as compared to pre-COVID era, as compared to COVID era. That was also a similar finding in our SCOPE study as well. So overall, to give you a summary of what we achieved, there was an increase in home births, fewer deliveries attended by physicians, no different with respect to antenatal care received. Please remember that. And no increase in neonatal mortality or stillbirth rate during the pandemic period. So counting ANC in peer visit is not sufficient to establish a measure of obstetric and newborn care. If high quality obstetric and neonatal care is not provided, delivery facility is not likely to be associated with decrease of fetal or newborn mortality. So the implications, the summary of my presentation here is predictions that the COVID-19 pandemic would cause larger reduction in pregnancy-related care and substantial increase in adverse outcome in LMICs are currently incorrect based on the data which we have. Outcome projected by data modeling at times can be useful to help research think through the potential ranges in the outcome, but needs a cautious interpretation. And to fully understand the impact of the pregnancy of this pandemic, it has to be substantiated with the population-based data. So, this I acknowledge all the collaborators and of course WHO country office and also NIH for having thought of this wonderful studies. Thank you for this wonderful opportunity.
And we have certainly seen the value of these research collaborators during pandemic with the general population talking about the observations, the respiration, the hazard, and where does the null fall and all that. I think these collaboratives should continue, and the most important point again with regards to where we can as professional association collaborate with the government. Now Government of India has said that there should be centers of excellence in different states, hand-holding district units and other management teams. And these are mostly in medical colleges and other institutes of repute. So agencies which are in the private sector, we can also continue to be part of this collaborative. Very good example. Another important point is looking at perinatal outcomes rather than the mothers and the neonates in silos. So with that, and thanks to Dr. Kavi, now I invite Dr. Basavaraj, who's the Secretary of Indian Academy of Pediatrics, and he will share his experiences on the impact of COVID on newborn outcomes and how we can lessen them in future ways.
Good morning. At the outset, let me thank our NNF President, Dr. Ranjan Pejawar, most active President of NNF, and Dynamic Secretary, Dr. Dinesh Tomar, and Team NNF for inviting me to share the experience of what Indian Academy of Pediatrics, which has played the role during the COVID-19. As we are aware, when the COVID-19, which is first reported in 2020, we were clueless how do we go about with not only the newborn care as well as in children's care, where we did not have any guidelines. This was a new disease. What are the challenges we really faced during those times as an academy? One of the things is which is related to the neonatal resuscitation. How do we go about? That was the time where NNF and IAP came out with an excellent guideline along with epoxy. That is the thing which is really created. The first organization we collaborated with an NNF, WHO, epoxy, and all. We came out with the guidelines. These guidelines have been implemented, and that really changed a lot of things. The one of the common thing which has related to the newborn care, one which is related to the neonatal resuscitation, which is disrupted in a big way. Kangaroo mother care, breastfeeding, and stillbirth rate, which was increasing, and prematurity and hospital deliveries is also affected. All these things where Indian Academy of Pediatrics, which is played in a major role, sensitizing our pediatricians, coming out with a guideline, sharing all the guidelines, and really that is given a big boost. And in fact, we have rolled out more than 100 COVID module by online and training in more than 25,000 pediatricians across India. And that is really, this is not only the newborn care, breastfeeding, and neonatal resuscitation, and the psychosocial issues, which was causing issues in the children as well as in healthcare provider and children and adults. This is where this module, which is really played in a big role in that. And second thing, which is related to the research, Indian Academy of Pediatrics, which is collaborated with the country office of WHO. The data is one of the things where we have shared within a case regarding SCRF forum with the 15 institutions we took across India, and we have promoted in a research, and that is going to be published shortly. So that's another thing we really play within a Indian Academy of Pediatrics. Of course, our more than 35,000 pediatricians within 300 branches, within 30 state branches. We have motivated all the things with these educating, they're conducting an online workshop and giving in a guidelines. That really, which is changed in a course in the things. And routine immunization, that was the thing which is really disrupted a lot during the COVID-19. We came out with a guidelines of IAP, came out with a position paper. How do we strengthen the routine immunization in the newborn as behind the newborn also? That was the part, and even COVID vaccination guidelines, which is going to be published in a couple of days in Indian Pediatric. This is also another thing where we played in a major role in that. Other thing what we observed is in a newborn, especially which is related to if there is a huge gap between the private and the government sector, where the newborn care is disrupted a lot, where IAP can play a big role in closing things along with NNF, where the Ayushman Bharat is one of the big thing where which is a lot of good package systems are there, and whatever the likeness which is there, we can play in a good advocacy role with the government of India along with WHO and UNICEF. That is the thing where it can be implemented. It will reduce our goal of INAP goal of single-digit neonatal mortality and single-digit stillbirth, where the INAP program, which has been disrupted because of this COVID-19, restoring these things. Of course, the looming around of this Omicron is also a thing. So we, as of now, the guidelines remains to be same. But in case if there is anything needs to be changed in the guidelines, once again, we need to relook at these things in the future. And definitely, we can close down the gap in collaboration with the government and our 35,000 pediatricians with NNF, WHO and UNICEF can play a role with the government of India where we can do that. Another observation, what we are really faced during some of the states across India, where the healthcare, the moment we talk about healthcare system, apart from in the government itself, there are one is a medical education, another is an health and family welfare. This is where we need to play an advocacy role for a good coordination between the medical education and health and family welfare department. This is where, as an organization, professional organization, with NNF and WHO and UNICEF, we can play the advocacy role to better coordination of the things. Another thing where we can play, which will directly affect the newborn, this one is, which is related to the maternal nutrition. Women and Child Welfare Department is another thing where the maternal nutrition is the thing which is affected, that's directly affecting the newborn things. Well, as a professional organization, we can closely coordinate and play an advocacy role in the, along with the government of India as well as the state government things. And coming to the breastfeeding, the 6 pillars of our INAP, where Indian Academy of Pediatrics is played in a major role, especially neonatal resuscitation is one thing. Previously, we had a bit of a difference of opinion with NNF and IAP. Now, for the last few years, so everyone is talking about the same thing, and NRP we have taken it in an mission mode where we have rolled out across India. This is really which is going to make a big change in the neonatal resuscitation. So with these few words, we commit on behalf of Indian Academy of Pediatrics of 35,000 organizations, whatever the Dr. Rajesh Mehta sir is already shared, and Dr. Arvind Shenoy sir and Avinash Kavi, they have shared on all the experience. We'll take these things from here. We'll play an advocacy role closely with NNF, WHO and UNICEF at the Government of India level. Thank you. Thank you.
Thank you, Dr. Basavaraj. I think a few points that Dr. Basavaraj has mentioned are worth re-emphasizing on. And one of them is that India as a country has a newborn action plan, which was a response to every newborn action plan globally to come to the SDG target of 12 newborn mortality rate and stillbirth rate by 2030. India set it for itself more ambitious goals of single-digit NMR by 2030. There was an articulated and written commitment to revise the whole strategy in 2020, which gladly the government, realizing that COVID might undo some of the progress, great progress in fact, that has been made in the country. So this is the right time to review the strategy and come up with a decadal plan till 2030 that how we are going to achieve the single-digit NMR. So a lot of lessons that how we can ensure that we protect the survival and development rights of newborns during the coming waves is going to be very relevant, very important point. And the coming together of the different professional associations, a lot of actions which Dr. Basavaraj has mentioned. I'm sure the members were listening and they will all be able to participate. So with that, now we go to the last part of our very interesting panel and talk about caring for caregivers. And here I would like to invite Professor Janardhan from NIMHANS, who's a family psychiatry practitioner and is a professor at the Department of Psychiatric Social Work. And I must also mention that Dr. Janardhan's team has pioneered with a self-care app that whatever actions health professionals need to take at their own level to manage something which is quite natural and it is best left to him. We will listen from him. Being stressed in the situations like we were all during the pandemic, it's quite natural, but to accept that and how to cope with it for resilience of the most important part of the health system, which is us, the practitioners. You can replenish oxygen, you can replenish all the equipments, and you can build facilities overnight. But I think this is the most important part of a health system. And welcome, Dr. Janardhan. And you'll also share your work about that app that NIMHANS as well.
So good morning, all of you. So first I would like to thank the all organizers for inviting me to be part of this plenary session. We as health workers during this pandemic have been a lot of pressure, not only from the hospital side, but also from our family side. We were unable to give the time what our children wanted or our spouse wanted. which is contributing towards the stress, and that would have an impact in terms of my outcome, what I'm going to provide in the hospital. So this has become a global health problem. So when this pandemic started, we didn't have any solutions, ready-made solutions. Everything we learned over last 2 years now. And we quickly realized that this is not just a physical health problem, but it is also a mental health pandemic, which we need to pay attention. It is not just paying attention to our clients, but also paying attention to ourselves is something we quickly realized, and we started working on those lines. Health workers, like all of us, we all are human beings. We do have our own emotions. During this pandemic, it has disturbed us and it has led to a lot of stress to us. A lot of studies have estimated that 90% of our clients who come during this pandemic do experience mental health problems at the time of their intake. But over a period of time, it is at least 30% of them would come back to us for mental health intervention. So we need to be equipped in terms of how we can provide mental health intervention rather than just depending upon our professional colleagues who are mental health professionals. We all have certain skills which we have picked up. So let us just recognize those skills and start working with our clients so that we can enhance their mental health. So frontline health workers often do not have the luxury of just taking off because we have been asked to work in the ICU centers and there is no other go. We need to take up this workload now. So as we are taking this workload, a lot of emotions also been attached in terms of our work in the ICU. So we do get feelings of anxiety, feelings of sadness, which need to be recognized, and we need to start helping ourselves. I want to just bring in the definition of what is mental health here. Usually the term mental itself being understood as madness, but we need to understand the definition of mental health, which talks about behavioral and emotional well-being, and not just people what they think, feel, or behavior. It is not just an absence of illness. It is about how we cope with the situation. So mental health is applicable to everyone. It is not just for people with mental illness. So let us recognize that mental health means for everyone, not just mental illness. So this I want to stress here. Mental health is more than the absence of mental disorders or disability. So it is applicable to all of us. We all need to work in terms of enhancing our mental health. Once we enhance our mental health, our productivity is going to be better and we can have a happy disposition in our life. So in the initial phase of pandemic, so we were worried in terms of getting sick, passing on the virus, and we didn't have enough resources in terms of dealing with the problem. Phase one, we had doubts about the preparedness, we had fear of safety, concern about urgency, then information being given overloaded with lot of information. Sometimes it was misinformation also, and rapidly changing guidelines because no one were prepared in terms of what should be the proper guidelines. So every time there were new guidelines which were confusing all of us. So we need to understand that psychological stresses, the health workers do have such stresses, which will be presented in the form of fear of exposure to self and transmitting. So we were often worried in terms of transmitting the virus back at home because we do have children back at home and they do expect us to be part of the family life, and uncertainty of support from the organization. Even though we were working in a health setup, we were not certain in terms of in case if my family members or if my parents are going to get this virus, how would I manage them in the hospital? Would I be able to get the beds in the ICU? Would I get oxygen? Those were the questions we had. Even though we were part of the health system, but still we had our own questions. So we had a lot of information and communication which has been existing, and personal and family needs with work demands being too much on us. So we were not able to give time in terms of our work or maintain this work-life balance is something we had difficulties in maintaining. So all these things would contribute in terms of my mental health. Top of this, we also had a lot of cases in terms of violence against the health workers, which has been reported in many newspapers, like physical assault was there, psychological threat, then individual weapons were used, heavy weapons were used against health workers, which all made us to be more scared and fearful. I'm just giving few case studies which have been reported in the newspaper. Ms. H is a final year medicine resident who is posted in the COVID management ward. Her duties includes attending the infected patients, maintaining their record, report the progress, and send sample for testing. She wears PPE kit all the time during her duty hours. Of late, she complains that she has been feeling a bit unsettled and occasionally sleep is disturbed. She is getting irritable on and off, affecting her interaction with her colleagues and patients. Despite this, she is managing to carry out all her major responsibilities, both at work and at home. So this situation is almost similar to all of us who have worked in this pandemic situation. We did have a lot of emotions which have been triggered in us. So we need to recognize that this is something I need to take it seriously and start working in terms of dealing with my emotions. So we also need to understand that normal people are exposed to extraordinary situation. So what we are experiencing now is a normal reaction to an abnormal situation. Now the abnormal situation is the pandemic which has created. So let us normalize it rather than just recognizing it as a mental health problem, mental illness. So we look it as a mental health and look in terms of how I can enhance my mental illness. So a lot of mixture of clinical presentations has been there, and it's a clear link for psychosocial stresses, and most of them would recover with minimal support. What we need to do is a lot of self-help, which we need to put it into practice. So let us see what is that self-help we can put into practice. So I'm not going to read the case studies because I think time is less. So burnout, we need to recognize. How to recognize burnout is all these symptoms, like take undue leave, abscond from work, make medical errors, disbalance in the ecosystem, become terrible, losing loving relationship. All these things are signs of burnout. So let us recognize that we also are human beings. We also can get burnout, and let us start dealing with my burnout. So when does it become abnormal is something we all need to look at it. When it dysfunctions the personal, social, and occupational functioning, then only we call it as mental illness. So how it can be presented is, like as I said earlier, it is more in terms of absenteeism, reduced job performance and productivity, reporting to workplace intoxicated, poor memory, impaired physical capability, and daily functioning. When we have all these things, it means that I am undergoing some mental health problem which need to be paid attention. So some of the signs of anxiety which we see during this pandemic is uncontrolled worry, stomach and digestion problem, so trouble with concentration, memory, and thinking clearly, increased heart rate, change in energy and difficulty in sleeping, and irritability and other things. Like we need to just recognize ourselves, and there are a lot of self-rating questionnaires which can be used so that we will know the distress level what we are facing, and depending upon the scores, if required, I need to be open in terms of taking support from mental health professional. It need not be medicines. It can be just a platform for you to ventilate your feelings. That itself will sort out your mental health issues. 50% of the problems can be resolved by venting out. So there was recently one study was conducted in Karnataka where 2376 healthcare professionals were interviewed. So I'm just giving the details of who are the people who got interviewed. But it's interesting for us to know that workload was 32.3% of them have reported workload, increased workload, and inadequate PPE. Even though we are in a health setup, government is not able to give us enough PPE kit. Getting family infected was another worry. Getting infected, inadequate training, and getting quarantine were some of the worries which need to be paid attention by the government. So what generic interventions, what we can do is that breathing exercises, mindfulness meditation, progressive muscle relaxation, loving kindness meditation, and some tips for self-care. So breathing exercise, we all would have known about it. So we need to just put it now into the practice. For that, I don't think we require any different platform. Even while sitting in your workplace, it's possible for us to practice breathing exercises. Then loving kindness meditation is something where we need to think about positively, think that I am doing well today. My friend is also doing well. Repeatedly, when we are talking, giving a positive messages to ourselves, so the mind is going to get relaxed and it will help in terms of dealing with my fearfulness or anxiety. So breathing exercises, just start with 5 minutes and slowly once you feel comfortable, you can increase it. And there are a lot of breathing exercises available online itself. Through our mobiles, we can access and we can start using. So when you are inhaling and exhaling, so your entire mind is going to be in terms of counting how many times you have inhaled, how many times you have exhaled. That itself will break a thought flow, what you are undergoing. So that will help in terms of relaxing yourself. So there are some tips for self-care. What you have to do is have a routine and keep in touch with your relatives and friends. Make it a point that at least once in a week or at least once in a day, you are going to talk to your parents or your relatives, your close friends. So that would really help you in terms of boosting your energy so that you can go back and work in the healthcare setup. Exercise regularly and have a healthy diet. So we know that it's a time like a lot of food is being brought out from outside. So don't try to depend on outside food. Try to have a healthy diet. Even if you are depending on outside food, try to have a healthy diet, which is going to have an influence in terms of your mental health. If you are a religious person, get involved in religious activities. So this also would really help you in terms of relaxing your mind. Ensure breaks and have adequate good sleep. So that is something you need to put it into practice. Carry out some activities and hobbies unrelated to your work. Don't do hobbies related to your work, unrelated. What desires you had or what dreams you had, you can now bring it back and start putting it into the practice. Practice relaxation exercises and then make time for yourself and for your family. We know that it's a busy schedule, but even then we need to pay attention towards family. We have children who are looking forward for our attention. So we need to take all precautions and also give time for our children. So we do have elders back at home. So we do have parents either at home or in our native places. So make a plan for them. Check them daily through using technology tools. So we have WhatsApp, we have mobile phones. So it's possible for us to get in touch. So distance doesn't matter. So we need to just make a time to call them. So it will help in both the ways. One, you are relieved from knowing that your parents are safe. At the same time, parents also are relieved that you are safe. And it will really boost your energy. So offer assistance to them wherever required. Now we have a lot of facilities available. It's not necessary that you need to be there every time. So you can get the services from others. Give them purpose, help them to stay active and keep their mind busy so that they are not going to be worrying much. So you need to do some activities to make your brain active. So we do have a lot of games in the internet, in our mobiles. Play that. Even if you are spending 5 minutes on that, it's really going to help you in terms of breaking your thought flow and help you to relax your mind. So if you are involved liking cooking, so you start cooking. Cooking is a very good stress buster, which you can put it in practice. So nurturing your marital relationship is very important. It's not just you are a health personnel who need to be always helping others, but you also need to take care of your marriage. So you need to pay attention towards your spouses. So shut down your mobile wherever possible. Back at home, as we are, sometimes it's required for us to use mobile, but at least have judiciously start using your mobile phones. So laugh together, do a lot of activities with your spouse, so that spouse also feel that she is important in your life. So eat meals together, love and intimacy, all those things you need to pay attention for your spouses. So dealing with stigma is another big issue we had during this pandemic, because people were worried that we become a chance in terms of like passing on virus to others. So we need to start working in terms of stigma. We need to first understand that this stigma is due to ignorance. It is not that they don't like us. Because of their ignorance, they are showing that behavior. So once we have that understanding, we may not carry any negative feeling towards them. So ventilate your negative experiences with your friend. So identify who is a good friend with whom you can talk anything and everything with them, so that will really help you. And don't give it up. Share your feelings. Lock yourself for a few minutes in case if it has a lot of negative feelings. Rather than reacting, it is always better to lock yourself and don't take things personally. So taking care of children during this pandemic is very important. So we need to reassure our children, and we need responsibility for themselves, maintain calm with them, engage them. It is always, it's also possible to engage them remotely, not necessarily we need to be with them. Through remote also it's possible to engage. Beware of social medias, how it is been disturbing, because we do it had our children asking us, Papa, in case if I'm going to get illness, how would I be saved? Because we were talking of third wave, it's going to affect children. So these were some of the questions which have been asked to the parents. So we need to be prepared in terms of answering to those questions also. So quality time with loved ones is something we need to put it into practice. There are many things we can do together, like playing games, starting a hobby together, look for books that your son likes and start getting it online so that they can start reading, exercising or working together. So it creates a platform for you to build up a good rapport and good friendship with your children. So let us use this as an opportunity in terms of giving time for our children. So when we are working in a health setup, so we need to focus in terms of the long-term plans, ensure that most of our staff are getting trained. Mix and match is something which has worked out in this period. So seniors and juniors, if we can mix up, a lot of inter-learning is going to happen. So try to put that into practice in your workplace. Ensure staff rotation. Not necessarily everyone should work in an ICU. It can be less stress and more stress like that. If you can identify and start rotating people, it will really help them in terms of taking care of their mental health. Have regular meeting with your staff, quality communication with the members, because we do require multidisciplinary approaches. We are working in a setup where we require support from others. So let us have good communication with everyone. So create an opportunity for debriefing in your workplace so that team members can share about their feelings, discuss about common mental health issues your team members can have, so that it will create a platform for them to talk about it and have a flexible schedule. People would have got infected during the work process. Let us try to accommodate those needs also in our plan. Identifying a buddy is something very much required during this pandemic. Let us all identify a buddy with whom we can just vent out anything and everything with them. So buddy is going to really help us in terms of dealing with our mental health. Access to the services. We need to have a list of mental health specialists which are available in our district, in our areas, so that we'll be able to take the support whenever required. So we need to make referrals whenever we feel that I would require some help or some medicine. I need to come forward independently and take a referral so that I will be helped. Once I am helped, I can help many others. So let us work in terms of our wellness. Wellness includes social, emotional, spiritual, intellectual, physical, environmental, financial, and occupational well-being. So let us pay attention in terms of concentrating on all these areas so that I can be a better person. When I am a better person, I can support others. And let us also go with this feeling that this too shall pass. This is not going to remain with us. So we thought that this will pass in our first wave itself. Then we saw the second wave. Now the new virus, they have been talking, but this is not going to remain with us. It's going to pass. So let us hope that it's going to go away fast and we'll be back to our normal life. So thank you for giving me this opportunity.
Thank you so much, Dr. Janardhan. And I think one self-realization that I had when I started working with the team at Enhance, led by Dr. Janardhan, was that these are not normal reactions. These are natural reactions, which many of us, so we are just ordinary people put in extraordinary situation and absolutely normal to feel psychosocially disturbed. And I have also sought care. What Dr. Janardhan didn't mention is that with a curation of some best innovative practices, NIMHANS has developed an app which is on the Android platform. You can see it in your mobile apps. It's called the Share Care app. So the buddy system that he was mentioning, sharing each other's stresses and how we feel and venting out. So it's called the Share Care app, which takes you through wellness products across the ranges that he has mentioned. It has wellness product, including from the yoga center at Enhance. Then it has self-assessment questionnaires. And if you feel that after self-assessment, you are stressed enough to seek care, there is a list of service providers you can directly contact through the app via Enhance. So please do try that and try to disseminate it to as many healthcare workers as possible. So with that, is Dr. Manoj here? So last but not the least, Dr. Manoj, within the fraternity that, we'll wind up in 5 minutes, but what can as fraternity we do within our family of LNF to keep the caregivers also, stress-free? And we have seen a lot of activities throughout the year from the Kerala chapter. So with the possibility that the other units can also benefit.
Respected seniors, my dear friends, at the outset, I would like to thank Dr. Vivek, WHO Country Office, NNF and UNICEF for having asked me to speak on a totally non-conventional topic and not discussed in any other neonatal conferences. As time management seems to be a problem, so from the original 25 minutes, we'll try to run through this concept in the next 5 to 10 minutes. Can I just have a few of the slides? Talk. I would just try to bring your attention to the whole concept of what the previous speaker left off, preventing burnout when you address the issue of pandemic. Let me take it a bit further. Even before the pandemic, were we not burned out? We were burned out. And we always used to have this feeling of I am overworked and I am always, and I have no time for my family. I have no time for myself. Well, to quote the outgoing president, Dr. Anjan Pejawar, he always used to say, everybody has 24 hours only. So it is only how well you manage your time. Time management is what you need to do. Unless you are not convinced that until you exist, your family doesn't exist, and until your family doesn't exist, you cannot take care of your children of your patients. So remember this concept. If you lose the oversight and then try to, I have one more case to go, I will have one. You will have cases, you need to do justice to them, but you need to first do justice to yourself. Learn to love your body. Learn to do justice to your body, learn to do justice to your family, and then so that your productivity will be much more. You will be working at your full cortical level, not at spinal levels when you rush off cases in your OPD. So I would just like to just show you one of the studies which was done by IMA, commissioned by IMA Kerala, which was an eye-opener. Whereas the average, this is published in Times now in 2017, the average life expectancy of an Indian at that point was around 68 years, and the Kerala it was 75 years. But the Kerala doctor at that time was only 62 years. And this was analyzed in detail, and the causes attributed were diabetes, hypertension, stress at work, heart disease, and malignancy. Unfortunately, all these, including malignancy, are lifestyle related. And until you improve your lifestyle, you will be in a race to achieve everything without enjoying the whole process and burn out. And then finally, you will have an untimely exit from this world, or you will be a burden. Our aim should be to age with grace. Aging with grace means keeping yourself fit. And let me just quote the recent WHO statement: physical inactivity and unhealthy lifestyle is a larger pandemic than the pandemic we were discussing in this plenary. Can we do anything about it? Of course, we have solutions, simple solutions which we could have adopted when you are young. And the problem is, when you are young, you have no time for this because you're already healthy. It is like putting SIP in the bank. you put small investments right from the beginning, the amount that you're going to get later are going to be huge. But unfortunately, those of you, I challenge you, those of you are below 50 would not have given much thought unless you are convinced about this. Only after 50 or 60, you start thinking about it, but then it's too late. I don't know, these are the things that I was just saying, and I was in your absence, I was quoting you, sir, about you saying 24 hours is there for all the people. It's not for somebody who does things and somebody who says I am busy. So all these are actually, if you think any of these are there, these are all myths. Even including the disability that you have, you should be fortunate to think of the disability you don't have. Think positively, and from that disability, how can I lead on to an active and healthy lifestyle? This is what you should be thinking about. And then these benefits, all of you know, I would like to stress on 3 things that are going to really make your life very miserable or prevent you from aging with grace. Type 2 diabetes, heart disease, and malignancy. And these 3 are now well proven to be related to your lifestyle. Let me just, for the beginners, since I'll skip all the middle portion of my talk for a want of time, let me introduce you to the concept of fitness and then tell you what is the recent advance. So there are 3 types of exercises you should do. You should do all the 3. It's not that you do one type alone. You need to do all the 3. Always it's better to start with cardio, including that is otherwise called aerobics, the speed endurance. And then once you do that, you realize that is not good enough. It will help you lose weight, but then probably that is just how you start your game. It's like when you do therapeutic hypothermia, you need to reach your target temperature, the initiation of cooling. Once you reach, then you go on to the other 2, strength and power. So resistance training is what is important at this level. And of course, the third one is easy if you don't know it, and very difficult if you do it. That is improving the flexibility and balance. So the examples of this, all the exercises that you think mostly are cardio related, the most popular form of cardio these days all over the globe is Zumba, which we have as a regular online fitness session for since the pandemic. Before that we are doing. Since 2017, we have been experimenting with group fitness. Individually, we are all doing it. Group fitness in our state, and then probably with the pandemic, it was a boon for us. We converted it to advantage. We went over because this was happening in my place, and then from Thrissur we went to. Now we have this group of online doctors and family fitness group. We have members from all over the globe. NRIs from outside. We don't have any non-NRIs from outside, but from all over all the states. Most of the states we have. It's a large group. And how does this happen? So that is probably the boon of COVID. Now, this is where we lack the resistance training, and then typical examples of flexibility and balance is yoga or the Pilates. I will skip all these. How about all these? The high intensity training. This is a video. I just want to show you this. Tabata is a high intensity interval training. This is our South Neocon before which we held in Kerala, where you do high intensity exercise. Then you for 20 seconds, then you stop it for 20 seconds, then you do it for another 20 seconds. So such 8 stages. This is one form of fitness. I want to show you just to make you picture this concept. It is not for beginners. Because the exercises are very, very hard. But then the problem is you need to start somewhere. When you start, if you start somewhere only, you will go on to the next step. You need to challenge yourself. You don't look at what other person is doing. So and so is doing exercise so nicely. I am not good. Don't look at that. You challenge yourself. What am I doing today? And what am I doing 5 days later? That is a challenge. Keep it hairy, and that is how you progress in this. So we used to have before. This is before pandemic. The last South Neocon we hosted before pandemic, and we used to have every conference. We used to have this fitness session. Thankfully, it has been adopted by so many conferences now. So, but that fitness session is not going to give you fitness. It's going to motivate you. Who should lift weights or resistance? Just if you want to do only one form, you do weight lifting. or rather resistance training. But you should, if you do it as a only form, you will injure, you will land up with spine injury and whatever. You should be cardio fit before you start this. So everyone, and it's like an SIP, what I told you, you start an investment only after some time the investment will grow. If you start younger, you get better investment. Only in old age, you try to get better benefits. Skip all this. Probably for those we can discuss lately, the various FAQs you have. And so I would like to tell you, I mean, see the recommendation, before I tell you the recommendation, how much exercise you should do. It is actually, if definition is moderate intensity activity. You're breathless, but it's easy to talk. You run and you're able to talk. That is moderate intensity for you. It may be vigorous intensity. You're difficult to talk on day 1. After day 15, it will be moderate intensity. So the challenge is between yourself and not with somebody who is running a marathon. So American College of Sports Medicine recommendation is 150 to 300 minutes of moderate intensity. And once you are in it for some time, go on to 300 minutes. And from moderate intensity, you scale up. So per week, which translates to something like 1 hour per week, because there will be cheat days. So 5 days a week is good enough. If you 1 hour, if you can do, you will achieve the target. This is what we do in our, we had 2 online sessions for doctors and family. And it's not an NNF program, it's an IMA program, but then now largely adopted during Ranjan Pijavasa's time too. We have a group called Now Fitness, where steered by NNF, and where all doctors, not only neonatology, all doctors and families do join. So for the first phase is what I told you, every Sunday, 7:30 to 8:30. Even today we were having online the session, and then those who are going to the next level, we have this recommendation based 5 days a week training. Skip that. Just go on to the second part of what gives you adequate SIP or investment, that is healthy. Now, all of you know about the MyPlate. Food pyramid has been replaced by MyPlate. Now here, the major chunk is by the vegetables and fruits. Now, grains do stay. There is a problem with protein and dairy in the recent advances, which I will not just only touch upon. But then this is the MyPlate. Probably the dairy will disappear in the next revised MyPlate. So the newer concepts I'll just summarize because of lack of time. So there are 3 concepts which are actually we have gone back. Like we go back to delayed cord clamping now. These are all concepts which we come back. We realize that plant-based nutrition is the way to go. So which means that not even dairy, not even eggs and things like that. So this is probably one thing. Again, still now we have some evidence, and it's still a matter of debate. I'll just leave it at that. The second concept is intermittent fasting. It used to be called intermittent fasting. It is actually fasting, but I adapted it to our scenario for all of us who are very busy practitioners. Intermittent fasting, the new terminology, time restricted eating. Fasting is a bad word. It is a time restricted eating. And the third is adapt to the day, chrono nutrition. So these are 3 old concepts which we have gone back to, and the new revelation. That's what I'm saying. That's why probably the protein and the stress on the protein and dairy may go. So the mTOR receptor genes and insulin sensitivity is what is now guiding the nutrition of the future. Means that the original mammalian target or rapamycin gene, which has a receptor, which is the one that we know that mTOR gene is the one that controls most of the metabolic activities, and this leads to you stimulate mTOR genes and you build up muscles. So actually, and then we all know that strength training, I forgot to point out one thing. Strength training is important because we are studying now physiology classes. Our muscles atrophy. There's a physiologic atrophy of muscles, which if you want to prevent, you need to keep on stimulating those muscles. So that is what strength training does. It causes micro trauma in the rhabdomyocytes. So what is going to happen is slowly the muscles will continue to remain like that, or rather it will delay the muscle atrophy, which all of us will have in old age. And the new addition is that insulin is the base of all your disease. So probably IgF, because this actually is the same set. You have, so insulin resistance is likely to happen if you are you are going to be stimulating your muscles by taking more and more protein, and then eventually you will land up with diabetes. And the other, I'm just simplifying a concept. We can discuss subsequently the details. And the other thing if you are going to take is that if you keep on stimulating IGF-1, so diabetes is sure shot, but you will gain muscles. Like you drink protein drinks and you will gain muscle, you will be very chubby. But that may not be normal, because what is going to happen, there is a concept called the malignant cells also do require this for its growth. So you will progress the malignancy. So probably what is going to happen is your incidence of cancer is very, very high. As I showed you in the initial Kerala IMA study, the rate of malignancy was pretty high than the. So I'll skip this, and then just a few words about intermittent fasting. Anything less than 12 hours is not time restricted eating. Minimum 12 hours to give you so you need to have between which you can do either a dry fast or a water fast. Water fast means only water. And ideally what is practical, which people like we do is 16 to 18 hours or 14 to 18 hours. 18 hours you can't do, but easily if you have an early supper and delay your breakfast, you will get that benefit. So for 14 to 16 is probably most practical for a busy practitioner. Chrononutrition is following the circadian rhythm and have all the food when the sun is up. And probably this is a concept that has not been totally proven by evidence. The autophagy can be stimulated by fasting also, not only by down-regulating the mTOR genes, by fasting also, so that the chance of malignancy or even the malignant cells are there, they will slow down. What I'm saying are things of the future based on solid animal studies and some observational human studies, mainly by people like Professor McGregor and others who have published. And so much so that we now have a separate branch of medicine called plant-based medicine, and or the other terminology which used to be lifestyle medicine. And then we have a lot of people, these are mostly in the US, who are practicing. So if you want to consult a cardiologist, you would go for a plant-based cardiologist. So these are things, the terminology that are coming totally new for us. And the last concept about the thing, we are all worried about fat. The villain is fat in your body. You reduce a fat, your problems will come. There will be more chance for your muscle to grow and all that. Total fat is less dangerous than your visceral fat. The ectopic visceral fat is most dangerous, and probably the ectopic fat in a pancreas is what is going to reduce the insulin secretion and then increase the insulin sensitivity, increase the insulin resistance and create problems for yourself. So probably this is again by revelation. All this came after the genome project is what threw the light into all this, and then now we know so much about microbiome. It's another concept I know touched upon. So probably I'll just summarize talk. Already Vivek is standing. So 5 or more vegetables. Include all 4: aerobics, muscle strength, bone strengthening, flexibility, 3 days of vigorous activity every week, less than 2 hours of screen time, 1 hour of physical activity, and 0 junk food, which includes, unfortunately, all the conference foods that the food that we have in conferences, but nobody, including myself, had dared to make a change in the diet of the conference. Probably because now that is where the food has to be good if a conference has to be successful. So until we change from ourselves, don't blame the organizers for providing junk food in the conference. And we enjoy junk food. For this, let's just remember your success lies in the works that you try to avoid. Okay, can I just 1 minute? Exactly 1 minute. Good posture is very important when you sit also. When you sit in your in your office practice also, the posture matters a lot, as well as your life expectancy goes on, and then probably these are concepts. So I will finish here. When you go as a patient to the doctor, physician, he tells you so many advices. Probably now the advice you are going to get is the doctor is probably update with the concepts is I want you to meditate for 20 minutes, twice a day, exercise for at least 30 minutes a day, avoid processed foods, eat plenty of organic fruit and vegetables, spend more time in nature and less indoors. Stop worrying about things you can't control and ditch your TV, circadian fast and come back in 3 weeks. If you do all this and you go back, probably the doctor doesn't need to do anything. The question I want to end my talk with is, we preach this. Are we practicing any of this? Just ask yourself. Thank you.
So, thanks to Dr. Manoj and Dr. Janardhan for ending this very useful panel. I hand it over back to Dr. Dinesh, but not without saying that as we continue our lessons to make sure that services for children don't suffer the newborns, we also need to take care of ourselves. And don't forget, this year is dedicated to healthcare professionals globally for all that. Thank you.
Thank you, Dr. Vivek. Now we'd like to felicitate our panelists and moderator. We start with Dr. B.C. Manoj. So please come on the stage. Dr. Siddharth, sir, please you also come and felicitate the panelists. Next, we'd like to felicitate like to call Professor Janardhan on the stage. Next, I would like to call Dr. Arvind Shinoy. Next, I will invite Dr. Avinash Kavi.
See, I have mentioned this before. 2021 was a year of collaboration. We collaborated with IAP, FOXI, UNICEF, WHO, Government of India, ISOPAB, and many other organizations. We had the opportunity to felicitate the FOXI representative. We would like to, we have two main collaborators here. We did felicitate the WHO representative. We now would like to call upon Dr. Basavaraj from IAP. Let me tell you, we have collaborated with them as far as DETECT is concerned, as far as many other programs are concerned. And most importantly, we hand over our babies to the pediatric fraternity after they cross the age group of our limits. UNICEF is very near and dear to us. Every program of NNF has been supported, has been encouraged by UNICEF, and the man here today to represent is the one who is our direct link to UNICEF, Dr. Vivek Virender Singh. We are very grateful to you, Dr. Vivek, and thank you. Thank you, delegates, to have stayed back plenary. And I'm sure you will believe yesterday's plenary 1 and 2 were the first time we are having 2 times or 2 big organizations. Thank you.
So you have another batch. So I'm not the only one who's carrying this.
Next, moving over to the sponsored talk, the GSK sponsored talk on PCVs by Dr. Satish P, who has done his MBBS, DCH, DMD, MRC, PCH at UK, trained in neonatology at Monash Medical College at Melbourne. He is currently working as a consultant neonatologist. We welcome you, sir.
GSK sponsor Dr. Satish. So just a minute. ಇಲ್ಲಿ paste ಮಾಡಿದ್ರಲ್ಲ column.
इसको क्या करना है?
This is a method. That's a play ಮಾಡಿ.
We can start.
Hi everyone. Good afternoon to all my seniors and respected teachers here and to all my friends who are here. I'll just begin my talk a typical scenario, a typical office practice. See, the time is around 1:32 p.m. We're all sitting there. It's just a tiring day. We're all very, very tired, hyperglycemic. After you finish with your patients, there's a huge queue of medical representatives waiting there to address you. So what do? One by one, they walk in, of which 3 to 4 representatives are from a very typical vaccine-based company. He walks in and he says, "Sir, look at these are my products." He opened his iPad, beautiful iPad, and he starts speaking about his products. He says, "I would just say with reference to the pneumococcal vaccine at present, sir, this is my product.
This is a pneumococcal vaccine. I have this is the serotype. These are advantages. These are disadvantages. And time and again, he stresses on the his counterpart or the other brand about the vaccine. So subsequently, the next representative walks in of a different company, bringing the same product, and if you find 3 or 4 representatives of the same product. After some time, you really ponder, what is I do? He says, this is the best. The other guy says, I am the best. And nobody quotes on what is the disadvantage or advantage. So how is it for us to decide which is the best? So we have to look for evidence. That is what is the focus going to be today. So let's make an evidence-based choice whenever we prescribe any vaccine. A brief history of the pneumococcal vaccine. In 1977, the first licensed purified vaccine was introduced in the market. Subsequently, over the years, in 1983, the 23rd polyvalent vaccine was introduced. And in the year 2000, where there was a remarkable change in the technology, and we got a conjugate vaccine. The first conjugate vaccine was perhaps the PCV7, which was introduced in the market overall and particularly in India in the year 2004 to 2007. And subsequently, in the year 2010, there was again a ban, and we got PCV13, which is nothing but an improvised version of the PCV7, for which 6 serotypes were added to that. And in the subsequent year of 2011, we had one more advantage of one more vaccine, which was PCV10. Now, friends, we all know pneumococcus is a common organism which causes various diseases, starting from a mild acute otitis media to severe infections like pneumonia, bacteremia, sepsis, and even a fulminant disease like meningitis. So, and studies were done prior to 2010. What did we notice? The pneumococcal deaths were more than 1 lakh. It was too much for the government and for the public. In spite of, we had PCV7 from 2004 to 2007 in the market, and it was given by the private setup. It didn't make any difference. No. Soon after the launch of the vaccine in 2010 and 2011, the awareness about the vaccine increased. There were huge campaigns which was going on, and the access to PCVs also helped for the patients to be aware of the vaccine and take the vaccine respectively. In the year 2017, when this was going on smoothly, the government of India realized that the cases of PCV were still increasing also in all parts of India, particularly in the northern part of India, in the principal 5 states. Which are those 5 states where they found real increases, though the cases was prevalent all over India, but yet it was more prominent in Himachal Pradesh, Uttar Pradesh, Madhya Pradesh, Bihar, and Rajasthan. So what did the government immediately? They took an action and they started rolling out the vaccine on the government setup. So this went on, and till date, all the 5 states were getting the vaccine, and government still tried to go further and started introducing vaccine all over the country. So now we have PCV vaccine all over the country, which is given by the government. And what did they do in 2018? Another study was done perhaps to know what is the incidence and the prevalence of pneumococcus and what is happening to the deaths. Though in the private setup, we did have both the strains of vaccine, pneumococcal 13 and pneumococcal 10, but what was happening to the deaths? Did it make any difference? Of course, a very slight difference. Still, the disease was rampant. So what is the next plan? We have vaccines, the deaths were increasing. What should we do from the doctor's perspective? We need to know about the vaccines before we give it. Why is it important that PCV vaccines, which is that, what is that, why is that? All these questions comes to our mind. Now, before ever we start prescribing a PCV vaccine, these things should be borne in the mind. Number 1, the vaccine serotype, and what is the coverage of the vaccine? What is the manufacturing process? What is the conjugation technology? What is used? What are the carrier proteins? What is the effectivity or the efficiency of the vaccine? And what is the indication? Can this be used in special cases like a preterm babies? Can it be used in adolescent population? Can it be used in elderly population? These were the questions which were raised. And of all the 3 vaccines which are available in the market, I'm just going to list all the 3 as of now. The number 1 being Synflorix, manufactured by GSK. And we have the following serotypes which are covered: 1, 4, 5, 6B, 7F, 9B, 14, and 23F. And the main carrier protein here is the protein D of non-typable H influenza. That is the active carrier protein where the conjugation happens. The 18C, the conjugation protein there is the tetanus toxide, and the 19F, the conjugation protein is the DT, that is diphtheria toxide. Now, though this lacks 19A, Synflorix, it is approved for use in all the countries or all the places where 19A is still rampant. Why is 19A important? It is one of the commonest serotype prevalent all over the globe and which is known for its multi-drug resistant and known to cause severe disease. Now the second vaccine being PCV13, manufactured by White Letter initially it was PCV and now it's Pfizer. Even they do have all the 10 serotypes plus the 3 other serotypes, and where the conjugate protein is the diphtheria carrier protein, which is nothing but CRM 197. The newly introduced vaccine is the Pneumocell, manufactured by the Serum Institute and which contains all the strain. Why is that? I've highlighted 418C in both the things. These the earlier older vaccines, I call them, like the earlier 10 Synflorix and the other 13 PCV 13. The strains, the serotypes of 14 and 18C has been replaced by 6A and 19A, which we'll be discussing in the future. Now, we saw there were two prominent serotypes. One was PCV10, the other one was PCV23, PCV13, sorry. Does a higher serotype always confers higher protection? We always say when you take off bacillus, come on, you put so many bacillus, it's going to give so much of protection. Is it true? Answer is higher serotype does not translate into higher protection. You need to keep it in mind. How is this? What was the evidence? Studies done in Canada, in Quebec, where they did analyze in children less than 5 years of age the incidence of IPD, that is invasive pneumococcal disease. And although the serotype coverage difference between PCV13 and Synflorix was around more than 20%, yet there was no major difference in the reduction or the incidence of IPD. That is, both the vaccines were reasonably very good in controlling the cases of IPD. So despite the significant coverage difference, there are no substantial difference in the overall effectiveness between Synflorix and the PCV13. The other evidence, where was it done? In Sweden. Sweden was a country which was using both the strains of vaccine, including PCV10 and PCV13. This study was done principally in about 21 counties, where they did analyze the facts and came to know that more or less both had a similar statistical reduction in the incidence of or the reduction of IPD. So, yes, the serotype number, whether it is going to have a protection, we got evidence for this. Let's come to the fact, technology or the design and manufacturing process does it going to alter any of the protection? The answer is different vaccines have a different ways of manufacturing. Number one, let's take the example of Synflorix. Though based on the various serotypes which are here, I'll take a classical example of 19F, another serotype which is used for conjugation. In Synflorix or the PCV10, the method which is used is sign annihilation. If I take 19F serotype by sign annihilation method, there is no alteration in the structure. While in Prevnar 13 or the PCV 13, which the mechanism which is used in the manufacture, the conjugation method is reductive amination. So 19F, when it is subjected to conjugation process by the reductive deamination, there were minor alterations, but it will make a major difference, which I'll discuss in the future. Probably 19F alters a cross protection against 19A as well. So protection against 19A by Synflorix is very good and still approved in almost 94 countries all over the world. Now, preference of vaccine, whether you want to have vaccines with this called direct protection, cross protection. This cross protection phenomenon has been in our vaccination manufacturing techniques since ages. Let's go back to the Edward Jenner times. We all know that smallpox vaccine was available. What was the strain used? It was a cowpox. Next, we know what BCG. What was the strain used? Mycobacterium bovis, which cross protects against Mycobacterium tuberculosis, which again offers cross protection against various other strains of viruses, including Delta. And sorry, the results are still awaited for the Omicron strain. Next, I was just stressing to you about 19A. Whether 19A is very important, and what have they done? Whether 19A protection suffices from both the vaccines? Yes, of course. Extensive studies all over the globe were done, and for Synflorix, it was marked by the green diamond, and by the PCV, Prevnar vaccine is marked by the blue diamond. When we compare these two data of all the studies which have been mentioned here, there is no significant difference between both the vaccines. Now, what is, are we particularly concerned about the 19A strain, or are we particularly concerned about the whole protection by the pneumococcus? What is that? Now, to prove this, surveillance were done in India by various studies. We have got the famous IBIS study. We have got the ASIP study by Manohar et al. We have got the Pneumonet study which was done in India. And Jyoti Singh et al. In her publication in the year 2017 put all the studies into one basket and analyzed the predominant strain which is available in India. She found out the disease burden in India of 19A serotype is just 4.1% in a reasonably a good sample size of 1,331. So when we separately analyze these three vaccines, and particularly these two, because I'm just slightly keeping the newer vaccine aside, let's compare Synflorix with PCV 13. The indications were approved by the DTCI. The 19A effectiveness by Synflorix and PCV is again more or less the same. And the overall effectiveness of both Synflorix and PCV is comparable, and which is really good. We also, I just told you about 19A, which causes severe IPD and I have severe fulminant disease. Is this enough? I told you. Pneumococcus still causes a mild disease like AOM. And friends, we all know AOM is the bread and butter of any pediatrician, ENT surgeon. So thereby, giving a vaccine is definitely going to protect against both AOM and other diseases mentioned. And one of the commonest illnesses for which antibiotics are prescribed is AOM. Does it just suffice just by protecting with Synflorix, or we'll have to compare with other vaccine? How is the protection rate for AOM, both with Synflorix and other vaccine? Now, Synflorix offered more than 25% greater reduction of AOM compared to PCV 13. This was a study which was published by Jesselson et al. And where they analyzed, it was an outpatient study done between the ages of 0 to 4 years in in Sweden. And similarly, one of the other studies which was done in Korea, where They compare the incidence of PCV13 and Synflorix following the primary and the booster doses of the same vaccine. Definitely, they did find a decrease in the incidence of both AOM and the AOM recurrence. If you just look into the graphs there, definitely there is a reduction by 9.8% compared to 20.9 and 11% and 7.3%. And the AOM recurrence has definitely come down. Now, what is this NTHA? That is non-typeable Haemophilus influenza. This AOM is protected by this by giving this vaccine? Yes. Synflorix offer dual protection of AOM, both caused by Staph pneumoniae as well as non-typeable H influenza. You know that most commonly the organisms which are causing AOM are Moraxella catarrhalis, for which we don't have any vaccine. The other vaccine, the other bacteria being Staph pneumoniae, and the third one being non-typeable H influenza B. So when you look at parameters, when you compare these two, AOM indication, both Synflorix cover both Staph pneumoniae and non-typeable H influenza, whereas PCV just controls only Staph pneumoniae. The carrier protein here is protein D, which is nothing but derived from the same organism, whereas Staph pneumoniae does not have that. And nasopharyngeal carriage is also reduced by giving the PCV10 vaccine, and whereas the nasopharyngeal carriage is just persistent, even up to the extent of 5.5%, even after giving the vaccine. And specifically, when you see the efficacy of non-typeable H influenza, it is the extent of 35.3%. Not twice. Not perception. What it is, friends? It is just perception or evidence. Okay. Since ages, we have seen that it really takes some time to accept new ideas. People do not easily come out of the comfort zone or their old mindsets. It really requires some compelling evidences to change the set perceptions. So let's look for evidence. So this is the evidence-based choice of PCV. Immunogenicity, safety, yes. Efficacy, yes. Effectiveness, yes. Dual protection against AOM, yes. Schedule flexibility, yes. And use in special population, especially preterm babies, yes. Similarly, PCV, more or less the dual protection, which is the extent of 35%, which we see in Synflorix, slightly lacking in PCV13. And newer vaccine, definitely immunogenicity and safety is there, and no evidence is available as of now. Hence, friends, it is now time to ponder over the evidences and draw the conclusion. I hope I've been able to just kindle your thought process. Thank you.
Thank you so much, sir. Any questions? Thank you, sir.
Next up, we have our social neonatology paper. The session has been preponed, so please do not depart from this hall. One of the judges is Dr. Somashekhar Nimbalkar, and he'll be introducing the other two judges.
Thank you, Meika. We have two campaign judges in this. Dr. V.P. Goswami, past president NNF. Sir is here with us and has been judging papers for a long time in IIT conferences as well as NNF. Dr. Amit Raj is our new and young EB member from West Zone and has done his training in Singapore and various parts of India. And we'll start off in about 2 minutes time.
ये वाला उन्होंने एडिट किया
No?
हाँ ना no my project Fatima should project on this Slide changes. Mike.
We will give you 12 minutes for presentation. If you exceed the time for 12 minutes, you will lose marks. So this is 12 minutes. We'll have 3 minutes for questions. Only the judges will ask questions. There will be no question from any participants for attending. Anything else? Best of luck to the participants, and we can start the time now.
You can start your time now. Yeah.
Good afternoon to all. Probably all of us sitting here would like to improve the survival of all our sick babies. But does our responsibility end there? I'm Dr. Fatima Sabahat from the Department of Neonatology, St. John's, who will be presenting before you intervention bundle to improve high-risk neonatal follow-up in a tertiary hospital. Neonatal survival has tremendously improved with advances in neonatal care. The NICU graduates are at high risk for adverse growth and development outcomes. Focus on follow-up care and early childhood development is key to achieve the WHO goal to survive, thrive, and to transform. Multidisciplinary newborn follow-up clinic has been functional in our St. John's in the past 2 decades. When we achieved a single-digit neonatal mortality rate, we started focusing on our follow-up babies, and the digital data collection of follow-up babies started since 2018. When we reviewed the data at the end of 2020, we found that our follow-up rates were quite dismal, which was less than 20%. So interventions were thus the need of the hour to regularize the follow-up and to provide age-appropriate tests. The primary objective of the study is to study the effect of intervention bundle to improve the follow-up rates of high-risk NICU graduates at 40 weeks, 3, 6, and 9 months. The secondary objectives were to see if these high-risk babies, they get the appropriate age-appropriate test on follow-up, that is HNNE, that is Hammersmith Neonatal Neurological Examination at 40 weeks, Amil-Thiessen at 3, 6, and 9 months, and general movements at 3 months. So the research question was, in high-risk NICU graduates, does an intervention bundle improve the follow-up rates compared to a historical cohort in a time frame of 10 months? My methodology, my population were all high-risk NICU graduates. The study design is a prospective interventional before-after study. The pre-intervention phase was 2 years and the post-intervention 10 months. We included all newborns who met the NSC follow-up criteria. Our cases were neonates discharged between January to October 2021. Our controls were neonates discharged between January 2018 to December 2019. We deliberately did not include neonates discharged between Jan 2020 to December 2022 because as the follow-up services were interrupted due to COVID pandemic. The existing infrastructure in our setup is we have an excellent multidisciplinary follow-up clinic with all specialties under one roof. That is the neonatal team, the early intervention people, the lactation counselor, the special educator with the play therapy, the speech and hearing vision immunization. We also have a modified NFC booklet and a baseline follow-up rates. The follow-up schedule which we follow are age-appropriate neurological tests which will be performed. That is Hammersmith at 40 weeks, Amil-Thiessen at 3, 6, and 9 months, general movements at 3 months, apart from vision, hearing, anthropometry, nutrition, vaccination, gathers routine schedules, and the BSID and MCHAT. So, therefore, there was a need to improve the components components of the intervention bundle. The intervention bundle consists of orientation and training of the NFC protocols, the senior resident posted in NFC, and awareness among nurses and other healthcare personnel. The step 1 was training of all the residents, which was done by lectures and videos in a hybrid mode. And the skill-based demonstration and the assessment of the tests performed were done by the faculty when the babies came for NFC follow-up. The next step was an exclusively NSA resident being posted, whose duties were discharge counseling, the appointment reminders which was given to the staff so that they would remind the parents to come back for follow-up, the weekly update of the follow-up rates, and the prospective entry of data. The standard operating procedures for discharge counseling was made. Parents were given discharge counseling in a unit of Hope building where NFC is located, and it was given a day prior to discharge. The key components whose were parent education, debriefing them about the baby's course in the hospital, what they're supposed to do at their home visit, at their homes, with emphasis on the need of subsequent follow-up, and also an individualized follow-up plan was drawn. The third step was training and awareness among nurses and other supportive healthcare personnel. As we know, all these healthcare personnel also form an important part of any intervention program. Therefore, meetings were held to create awareness among the staff who would reinforce and guide the family for the process of NFC registration. The outcomes studied were follow-up rates at 40 weeks, 3, 6, and 9 months, and age-specific testing done at 40 weeks, 3, 6, and 9 months as a synonym with Hammersmith, Amel-Tisson, and gender movements. The sample size was calculated using OpenEpi, assuming two-sided confidence level of 90% with power of 90%, expecting at least 20% increase in the follow-up rates. The total sample size calculated is 264. Statistical analysis, all the categorical variables will be depicted by n percentage of chi-square, continuous by mean or standard deviation, and p-value of less than 0.05 would be significant. Coming to the results, the baseline characteristics were similar in both the pre-intervention and in the post-intervention group. And when we saw the follow-up rates of 2021, the total NICU admissions were 754 in the period of 10 months. The NFC required were 283. The babies who registered for NFC were 214. The follow-up rates at 40 weeks was 70%. Rates at 3 months were 49%. Rates at 6 months follow-up were 38%. And the follow-up rates at 9 months were 50%. This is amidst the COVID pandemic. So we compared the follow-up rates at pre and in the post-interventional phase. And we saw that the registration rates definitely improved significantly from 47.8% in the pre-intervention group to 76% in the post-intervention group. Babies who came for at least one follow-up at any age also improved from 43 to 61%. And the follow-up rates at 40 weeks also improved from 51.5% to 70%, which was significant. We also compared the follow-up rates at 3, 6, and 9 months. And we found that there was definite improvement at 3 months from 30 to 49.1%, 6 months from 25.7% to 38%, and in 9 months from 22.6% to 50%. And we also tried to analyze, this is our secondary objective, where did the babies get age-specific neurological tests when they came for our services for follow-up. And when we compared them, at 40 weeks in the pre-intervention phase was only 43.6%. And in the post-intervention, it had improved up to 67%. From 3 months gender movements from 7.9% to 29%. 3 months Amel-Tisson from 22.2% to 47%. 6 months Amel-Tisson from 18.2% to 34%. And 9 months from 15.4% to 33%. Therefore, neonatal follow-up services are often a neglected aspect of post-discharge care. Significantly improves the follow-up rates. This was found similar to a study which was conducted by Becchio et al. In New York, where the follow-up rates improved from 60 to 80% after application of a multi-level education system. The drop at 3 and 6 months follow-up could be due to severe second COVID wave in the city. This study also highlights the importance of discharge counseling, which was done prior when the baby is in the unit for an optimal transition to outpatient follow-up. The strengths of a study, it suggests ways and means of how to improve the follow-up of high-risk NICU graduates. The limitations is application of one intervention bundle to improve the follow-up rates at all ages. POCI, that is point of care quality improvement approach with multiple PCSA would be more appropriate. Conclusion, intervention bundle consisting of training and awareness, discharge planning and counseling, exclusive personnel for follow-up, significantly improve the follow-up rates of NICU graduates. What more can be done? Devise new interventions like tele-follow-up, where we can use ASQ and GMCD, improvisation in data capture, and alerts to provide optimal care beyond NICU for discharge for the high-risk infants. A QI project with multiple PDSA would also be helpful. Thank you.
Okay. So, thank you for useful presentation, especially related to quality improvement. But what else you could have done to improve the outcome? As certainly there is improvement in the outcome, but at the level of healthcare provider, especially doctor and nurses, what else could have been done?
What we found.
See, you have taken the baseline awareness of all this. You have carried out awareness. But what other intervention that can sustain or it can yield the more outcome rates as compared to whatever you have achieved?
At each subsequent visit when they come, when we reinforce the parents, like the emphasis on the need, like why are the baby supposed to follow up? So that would help significantly. The second thing is like if they understand that their babies are different and they require more care for their babies for a good outcome, I think that need would definitely help them also to improve. And analyzing also like what was the problem in coming back, if are they interested in coming back for the follow-up visits, or do they have any problems? If we start analyzing, then also if we emphasize the need or their problems and try to focus on them, maybe it would be a next step and it would also improve the follow-up.
Have you completed?
Oh, yes.
I think, reinforcement of awareness can be carried out at the healthcare provider level and on-job training also during the intervention. That can improve a yield to optimum level.
I have a few questions. You had an intervention bundle, the various components of the intervention, but one, was it standardized? So if or you were the only one person doing the intervention, or there were many other people involved? And if other people were involved, was the intervention kind of standardized? So that's one question.
Yeah, the intervention bundle was done by all of the NFC residents, like all the residents were being posted, and the skill-based assessments were done by the faculties.
The counseling, etc., was it standardized? You had a
Yes, sir. Yes, sir. We had a standard operating procedure so that we don't have a difference between each of us who would be doing these intervention bundles.
Another question is, many of these patients go home, and St. John's works in an area where many of the referrals come from in and around places. So there's an ASHA network which does follow-up at home. So did you consider that ASHAs will be following them at home and ensuring that they follow back in the hospital? Do you know that ASHA does newborn follow?
No, yeah, I know that, sir, but like I've not analyzed that. I've not spoken to them regarding that.
Okay, so is your intervention replicable? Do you think that anyone else can do that?
I feel definitely, sir, it is feasible and it is doable so that everyone else can apply to this and improve the follow-up rates of our babies.
You mentioned 50% increase at 6 months, right?
At 9 months, sir.
At 9 months. And you had anticipated increase of 20%.
Yes.
Was there any discussion on any results or discussed with respect to distance traveled or the amount of money spent to travel back to the hospital for follow-up, and education on the socioeconomic criteria, education on the mother? Did you analyze those aspects?
Yes, sir. We tried finding out. Because we get both inborn and outborn babies. Outborn babies are somewhere even from the outskirts and out of state also sometimes when they have been referred to us. And we tried finding out what is the cost of them, what is the journey hours they have been taking to come up, and So that we have also now, we are trying to decrease the cost for them and see what services we could provide and help them if they, with any chance if we could.
So 50% followed by the 50% that didn't follow. Any idea why they didn't follow?
Mostly the reason was that they were far off, sir, and because they have left the state and they have gone to other place.
Yeah, thank you. Thank you.
Thank you, sir.
Yeah, is there this study, like, it's a short-term follow-up, right? Now, like, is it continuing or like you have stopped?
No, sir, definitely we would like to continue. Although not like a study, but definite this continuation would be there, and each time we would like to analyze a little priorly so that we could see what next step we could do.
Because mostly in there is only short-term follow-up measures. Those were, but long-term follow-up measures are usually like people they lose the follow-up and they don't get what has happened in the longer perspective.
Yes.
So
actually, this is not stopped, so we are continuing this, and till now we have analyzed our data.
any other question? Yeah, thank you.
Yeah, thank you so much, sir.
Next, Dr. Yashoda Satish. Dr. Yashoda, you have 12 minutes with your presentation.
Good afternoon. I thank the organizers for giving me opportunity to stand before you and present my study. The title is Effectiveness of Developmental Supportive Care on Clinical Outcome of Preterm Infants in Tertiary Care Unit Intensive Care Unit. Coming to the background, as we know, India prematurely has been recognized the leading cause of mortality and morbidity. It is inversely proportional to the gestational age and weight. As the weight decreases and gestational age decreases, the complications are more. In last 3 decades, the standard of care of preterm infant has been advancing and also high technology required that are considered as essential for in infants. You can see here this study done by Barker and Redder. He has mentioned that they have taken 54 preterm infants who are less than 32 weeks, and also they had done over 3,000 procedures. Please note, here, Hill-Precast blood sampling has done majority of the children, and particle suction followed by intravenous. This is the procedure has been done. These procedures are stressful for the preterm infants, and as we should know that there should be consequences like physical consequences as well as developmental consequences. An observational study revealed that high-tech environment is with the light and noises are also stressful situation. And for infant, despite the advantages, okay, this is the important thing when you are taking care of the neonate, this is stressful for the patient, and later it may lead to physiological instability as well as long-term and short-term and long-term complication, and also delay the length of ventilation and also hospitalization. Keeping in this mind, okay, developmental supportive care intervention will be a non-pharmacological and cost-effective technique that will definitely help to prevent stress level and normalize the health status of preterm infant. Present study aimed to, okay, what I have exactly done as I have trained neonatal nurses and also mothers who are present in an ICU, and I implemented this DSN for preterm infants and assess the clinical outcome of preterm infants. The objectives were to assess, to evaluate the effectiveness of developmental supportive care in terms of stress level, that's assessed by salivary cortisol level, respiratory suppositor, that is modes of ventilation, duration of ventilation, oxygen requirement, occurrence of infection, intraventricular hemorrhage, retinopathy of prematurity, and hearing loss. And also I have seen the length of hospitalization. Coming to the research methodology, research
approach is quantitative approach. This design is randomized control trial. Setting neonatal unit of Kasturba Hospital, Manipal. Population sample and sampling technique. There are 50 nurses, 25 nurses in intervention group and 55 nurses in control group. This purposive sampling has been done for this and followed by randomization I have done for preterm infants as well as mothers. And tools used were demographic information of preterm infants and mothers, clinical performance of preterm infants as well as salary records has been estimated. The data analysis is done by frequency percentage, mean and standard deviation, chi-square and repeated measures of ANOVA. This is actually research design. Here we have compared the two groups, that is mothers as well as preterm infants, intervention group as well as control group. In intervention group, we have baseline data and of mothers and infants has been recorded. From the records we have collected, both group. And when the baby has been admitted, we have included in inborn as well as outborn babies. In inborn, less than 72 hours. Less than 72 hours, we have baby included. And on the day of recruitment, we have taken one sample followed by 24 hours as well as 7 days we have collected the salivary cortisol sample. And also we have collected clinical outcome, other clinical outcome in terms of duration, ventilation, hospitalization, incidence of infection or sepsis, retinopathy premature and IVH as well as hearing loss from the documents. Both groups have collected and recorded and data analysis has been done. This is the sample size we have collected. Sample size that was 72 using this formula with the help of statistician. And coming to the process of randomization, first one, block size and number of blocks. There were 20 blocks in 8 each. This is once again with the help of computer we have done. Sequence of generation, 20 sets, sequence were generated with the help of computer dimension. And allocation of concealment using sequentially numbered OPEX sealed envelope. Allocation ratio, the block sizes 1 and intervention control group, 8 we have used. And blinding, nurses we are not able to do blinding because of the logistic support. We have managed in our NIC itself, one block itself we have managed. This was our actually one of the problems. And mothers were blinded by giving standard health care of the preterm infant during admission itself. This was my actually module I have prepared for this. These are the sessions we are conducted for nurses. Inclusion criteria for nurses, mothers as well as preterm infants. Nurses who were working at period of data collection. This was went around 1 month, 1 year, 2015 and to 2016 and 2016 and it went that 2017 initially also we collected data and mothers were admitted to the hospital within 72 hours and preterm infant born before 32 weeks gestation. Coming to the exclusion criteria, neonatal nurses who were extended leave were not included. We assessed earlier itself. The nurses who were planning to resign within 6 months were not included, and preterm infants admitted 72 hours of birth after 24 hours, especially outborn babies were not included in the study, and preterm infants having major congenital malformation were not included in the study. Coming to the ethical consideration, these are things we have followed: admission permission, consent from the neonatal nurses as well as mothers, IEC permission as well as Jasmine registered in the clinical trial register in India. This is actually our intervention, what exactly done. We have tried to provide intrauterine simulation for the preterm infants. We have got the snuggle of positioning aids from Philips company. They have one of the person, she was from
you have 5 minutes.
US, yeah. She has supplied and we have compared with this. And intervention group, the main thing what you have done is positioning, healing environment, protected skin, provided in cluster care, family centered care as well as kangaroo care. And other group has received only standard care. This is mothers what they have done. They have handled the baby at the earliest and sensory stimulation like sensory stimulation by hearing as well as eye contact we encouraged them. This is our concert flow chart. And here background information, there is not much difference is not there. This is exactly the salivary cortisol at recruitment 24 hours as well as 7th day
It is actually significant. Repeated measures of NMR shows that there is significant result has been found. And also this plot diagram also showing the difference between different intervals. This is the clinical outcome. Here also there is no significant difference except there is hospitalization. I have found the mean difference of 6.28. There is no difference I found. There is difference, but there is no significant difference. Here also there is no significant finding. Has been some difference, but there is no significant difference. Coming to the discussion, study conducted, present study comparing with other study, there are also significant difference found in the salivary cortisol. And coming to the hospitalization as well as duration of ventilation, in our study we did not find any significant difference, but compared to study there was significant difference with the training of nurses. Limitation of study, separate structured DS unit was not available in our unit. DSC practice not available. Then salivary cortisol assessed only 3 times. Conclusion study concluded that caregivers should vigilantly observe the infants to minimize stress level by reducing the frequent handling and providing clean environment. DS is an effective intervention to clinical outcome, and it's also showed that infants were more comfortable when the intervention group comparing the control. And it is also simple, cost effective, and definitely anyone can use this this intervention. Definitely we can train the nurses and involve in this study, and we can decrease the stress level and outcome. Many studies are available, and this can be done anywhere. These are my references.
Thank you for the presentation. I have a few questions. Developmentally supportive care is generally standard of care. So how could you randomize? Because there is nothing to say that developmentally supportive care should not be given. It's generally
that thing what you have done was here, the snuggle up position is one of the thing in intra-iteral simulation that has been used, one thing. And the other thing, lighting control, already lighting noise control is there, but we tried further some more thing here. And kangaroo mother can also, we will give, I'm not telling we are not giving, but we started here from the ventilation itself, like patient is on, child is on this one CPAP. At that time itself, we tried to get, because I am an neonatal nurse actually, basically, I worked in NIC for 14 years. Then I went for my higher studies. I actually wanted to do whether we can start early. For that, in the CPAP itself, we have started. That's the one difference I can tell. Yeah, kangaroo mother can, more hours we have given, and early we have started. And mother touching, and usually we won't start that much early. But here we have started early, and we have nurses also observed this one. And it can be done. I made them tell them to do that. It can be done early also. That's what.
So KMC, do you have any comparison of KMC hours given in both the groups?
I have not documented, but I should have been documented, but not documented.
You have not documented. Then, so you have mentioned in the outcomes, you have not mentioned a single primary outcome. You have mentioned many outcomes. So what single outcome was your primary outcome?
Salivary cortisol is the main thing.
Okay.
I think not much. Except, most of the indicators of supporting care, it would have been proper if you have included that. You have much emphasis on this is just my suggestion.
That's advantage.
So you have more emphasis on the statistical method analysis. You can, in further presentation, you can mention which type of sampling you use, that is sufficient.
Okay.
We don't require that multi-stage sampling should be narrated or described in detail and all. So we should focus more on the intervention, and more indicators should have been included. Then the study would have been much better. Otherwise, your presentation was.
My talk got over, Kate. My talk got over.
Cortisol level. Was there any it was routinely measured?
Actually, routinely we are not measuring. Serum cortisol we are doing, sir. But salivary cortisol, my study we have started actually. We had biochemistry, we have got the special kit that we have purchased, and we have for my study. It was around 45,000.
So your bundle care approach, it was a modified, we can say, standard of care. That is what you were trying to achieve with your study? And in your standard care, what were the things you were giving to the baby?
Standard care actually holding the sheet and keeping one thing. And the kangaroo mother care, that hours, 1 or 2 hours they will give. We will, even if the infant maximum 3 to 4 hours. But here we have tried to give one is as early as possible. And hours we try to increase because mothers we have talked with them and we have told the importance. Second thing. And third thing, sensory stimulation. We have actually created one song. That song we have taught mother. That mother is whispering with the child. That song. And also eye to eye contact. More of hours eye to eye. This is not happening in our routine.
So why not the father and other family members were not involved?
I didn't get it.
Why not the father and other family members were not involved? Only you have mentioned about.
Yeah, mother I told, but some fathers also I have not mentioned here. Fathers, grandmothers given, but I have not mentioned here. In the absence of father has given as well as grandfather given, even auntie has given because we didn't want this. I have not mentioned here.
Okay, yeah, thank you.
Thank you, sir.
So 12 minutes for presentation and 3 minutes for questions.
Respected judges and seniors, I am Jonaki Pal from Burdwan Medical College and I'll be presenting my study on the outcome of coconut oil massage in newborns. Neonatal mortality rate is an indicator of socioeconomic status of a community. And late onset sepsis is the major contributor of neonatal morbidity and mortality, particularly in developing.
Can you just stop? Can you go back to the slide? Don't start the time. Can you go back? So if I'm not wrong, this study has been presented or published before. Kamirul Islam has presented
Yes,
the study.
the study was based only on preterm units. And this study has been done further, considering both term and preterm units.
Okay, I think go ahead, start the time now.
So neonatal mortality rate is an indicator of the socioeconomic status of a community, and late onset sepsis is the major contributor of neonatal morbidity and mortality, particularly in developing countries such as ours. Indian women are prone to deliver before term, and these preterm and low birth weight neonates are at increased risk of sepsis due to lack of vernix and immaturity of the skin. Oil massage has been a traditional practice in India since many years, and coconut oil massage has been hypothesized to be beneficial to babies due to augmentation of the skin barrier, supplementation of essential fatty acids, and its antimicrobial effects. Exploring economical ways of reducing hypothermia and promoting growth, we decided to study the effect of coconut oil massage in the newborn period on weight gain, skin maturity, neurodevelopment, and brain growth, and identify the adverse effects, if any. So a randomized control trial was conducted in the rural field practice area of our college from January 2018 to December 2020, considering all the newborns born in the year 2018. To detect a difference in weight gain of 6 grams per day with 5% alpha error and 90% power, approximately 250 newborns were required in either arm. And considering a 40% attrition rate in a 2-year follow-up period, 301 newborns were decided to be included in each group. Further, reviewing the registers of previous years, all the newborns born in 1 year were decided to be included in the study to achieve the desired sample size. The randomization list generated was concealed in sequentially numbered, sealed, and opaque envelopes. And when parents of an eligible newborn consented, these envelopes were opened by the on-duty nurse and the newborn was allocated a group. Finally, 585 consecutively born children over 1 year period were included in the study. 5 ml of virgin coconut oil was applied to newborns of group A 4 times daily in the first 30 days of life, along with specialized massage for 6 to 8 minutes. On the other hand, newborns of group B received massage without any emollient. All the newborns with major congenital anomalies, malformation or infection of skin, critically ill neonates, and parents planning to change address or denying consent were excluded from the study. The primary outcome assessed was weight gain per day in the first 28 days of life, while the secondary outcomes were weight loss in the initial part of life, incidence of hypothermia and sepsis, serum 25-hydroxy vitamin D levels at day 30, skin maturity scoring on 14th and 28th days, head circumference and neurodevelopmental outcome biannually till 2 years, and brain volume at 2 years age. Following up these neonates, Neonatal skin condition score was assessed on 14 and 28 days of life, and mental and motor developmental quotients were estimated biannually till 2 years using developmental assessment scale for Indian infants. Every 8th child underwent MRI brain for assessment of brain volume. Dryness, erythema, and breakdown of skin was used to assess neonatal skin condition score, and a higher score was associated with poorer maturity of the skin. We ensured quality control, ethical clearance, and consent from legal guardians. Sepsis was defined as positive sepsis screen and clinical signs, and hypothermia was defined as temperature less than 36.5 degrees Celsius. The data were collected in Microsoft Excel worksheet. Sapir-Whorf test was used to see whether data were normally distributed or not. And Kaplan-Meier analysis was done to compare cumulative hazard between both the groups, while log-rank chi-square test was used to see the significance of difference, taking hypothermia and sepsis as censored events. P less than 0.05 was considered statistically significant. This is the flow diagram of our study. By the end of 2 years, we could assess only we could assess 229 neonates in group A and 227 neonates in group B for neurodevelopmental assessment, and 261 neonates in group A and 262 neonates in group B could be assessed for vitamin D3 levels in the serum. 32 neonates were assessed for brain volume in group A and 33 for brain volume in group B. We found the mean gestational age of the study population to be 38.6 weeks, 42.2% were preterms, and 47.9% of the neonates were low birth weight. 36.8% of the children were delivered through cesarean section, and 68.8% of the mothers had received steroids antenatally. We found no significant difference between in the baseline characteristics of neonates of groups A and B, except for cesarean section delivery, which was significantly more in group B, and infants of diabetic mothers were significantly more in group A despite adequate randomization. Comparing the primary outcome, we found significantly more weight gain by neonates who had received coconut oil massage. On the other hand, weight loss was found to be significantly more amongst neonates who had received massage without any emollient. Incidences of hypothermia and sepsis were found to be significantly lower, and serum 25-hydroxy vitamin D levels were found to be significantly higher amongst neonates in the oil massage group. Neonatal skin condition score at the time of entry into the study did not show any significant difference. However, when assessed on 14th and 28th days of life, it was found to be significantly lower amongst neonates receiving coconut oil massage. Neurodevelopmental assessment reveals significantly better scores in the mental domain at 6, 12, 18, and 24 months, and in the motor domain at 6-month age amongst neonates who had received coconut oil massage. Motor developmental quotient at 12, 18, and 24 months did not show any significant difference between the two groups. Similarly, head circumferences assessed during follow-up and brain volume at the end of 2 years age also were comparable for both the groups. Subgroup analysis revealed significantly better weight gain amongst neonates who had received coconut oil massage for both term and preterm newborns, while weight loss was significantly more in group B for both term and preterm neonates. Incidences of hypothermia and sepsis were found to be significantly lower, and serum 25-hydroxyvitamin D levels were significantly higher amongst neonates who had received coconut oil massage for both term and preterm newborns. Neonatal skin condition score assessed at 14th and 28th days was significantly lower for both term and preterm newborns receiving oil massage. Neurodevelopmental assessment revealed significantly better scores in the mental domain at 6, 12, 18, and 24 months for preterm neonates receiving coconut oil massage. On the other hand, no such significant difference was noted amongst the term neonates. Motor developmental quotients, head circumferences assessed at 6, 12, 18, and 24 months, and brain volume at the age of 2 years were comparable for both the groups for both term and preterm neonates. Adverse effects like rash and slippage also did not show any significant difference between the two groups, either for term or preterm neonates. The Kaplan-Meier analysis was done, and the cumulative hazard of hypothermia in neonates receiving coconut oil massage was found to be significantly lower than neonates in the control group. Similarly, the cumulative hazard of acquiring sepsis in neonates of the oil massage group was also found to be significantly lower. To summarize, coconut oil massage was associated with less weight loss and more weight gain in the newborn period, lower incidences of sepsis and hypothermia, and better neurodevelopmental outcome in the mental domain, especially in preterm newborns, was noted in our study. Comparing with studies from India and abroad, we noticed several other researchers had come to similar conclusions like us. But most of these studies have been done considering preterm neonates only, while we have considered both term and preterms in our study. Fewer incidences of hypothermia and sepsis have been recorded previously, like our findings, which is probably because coconut oil supplies essential fatty acids required for maturation of keratinocytes and the formation of an effective barrier. A decreased load of pathological flora in the skin is also noted, which is probably because of antimicrobial effects of coconut oil. Contrary to our findings, Edward et al. Had noticed higher incidence of sepsis, but this might be due to inclusion of very sick, extremely low birth weight neonates in their study. And their findings are not very replicable in our scenario because of lower chances of survival of such neonates. Higher levels of vitamin D and better neurodevelopmental outcome in preterm newborns have also been noted by Konar et al. And Shankar Narayanan et al. Multiple toxic effects have been documented in a few studies, but we did not come across any such event. We ensured blinding of outcome assessors, but caregivers could not be blinded due to the nature of the trial. Severely ill newborns were excluded from our study, which makes generalization of our findings difficult. To conclude, coconut oil massage is a promising, cost-effective, and socially acceptable intervention for lowering neonatal morbidity and mortality. It prevents hypothermia and sepsis and is associated with better neurodevelopmental outcome in the mental domain, particularly in preterm newborns. This traditional practice is thus an economical way of preventing sepsis and thereby reducing neonatal mortality, particularly in countries like ours. My acknowledgements too. Thank you.
Thank you for the presentation. And I think in true science, it is a social neurology paper. But only my one suggestion to all the participants, those delegates who were presented, that at the beginning of the slide, you should have disclosure that there is no conflict of interest. So just I wanted to ask, is there any conflict of interest?
No, sir. There is no conflict of
And
interest.
for other two? No? Otherwise, good, very excellent.
Thank you, sir.
I have a question related to conflict of interest. A very big study. Funding was there. What is the funding? Because you had gone to villages, etc. It would require a lot of funding. So the previous two studies were more or less in the hospital. This is a community study.
So basically, local companies like Varcoco, present in Burdwan, they provide coconut oil for hospital supply. So we use coconut oils for hospital supply only for the study. So,
but you had to, this was in villages, right?
So pardon?
You had to go to the villages, or what was it like?
No, sir. It was done in collaboration with the Department of Community Medicine. So, and these neonates were followed up over phone. Not exactly followed up. The mothers, whether the mothers are continuing the massage or not, was followed up over phone twice weekly during the neonatal period. Other than that, the neonates were followed up in the DEIC clinic, that is District Early Intervention Center of our hospital, where we usually follow up the neonates.
Good. You said antenatal corticosteroids. Your slide on antenatal corticosteroids showed I think 66%. The preterm was some 49%. So how is it that more people, given term babies got antenatal corticosteroids? Your slide, if you look at the slide.
Yes, sir.
Why is that?
So predicting preterm deliveries, they had received antenatal corticosteroids initially, but the number of preterm deliveries were less.
Your sample size, you have done subgroup analysis of term and preterm babies.
Yes, sir.
Was study the sample size enough for doing analysis for both of them, or it was a post-hoc analysis?
No, sir. So the sample size was calculated previously. So the sample size.
Because you have done subgroup analysis for term and preterm and you have shown differences.
So sample size was calculated previously considering a superiority RCT, and when we reviewed the previous year's registers, we came to the conclusion that inclusion of all the newborns in 1 year period we would achieve the sample size.
So there are other oils that have been studied in terms of coconut oil, sunflower oil. Olive oil is one which is expensive and often used. So I think all your studies are on coconut oil.
So we only did coconut oil massage in the group. We did not include other oils like mustard oil or olive oil.
So your comparison to other studies, when you compared your discussion, have you looked at?
Yes, sir. Yes, sir.
Sunflower oil, is it different or is it the massage which is causing the weight gain or is it the oil causing the weight gain?
So it is a massage which has kinetic properties which causes weight gain. Also, coconut oil is said to be rich in essential fatty acids which permeates the skin and which is permeable and it causes weight gain as well.
Okay.
So in comparing other studies like Shankar Narayan and et al., they had used mineral oil instead of in comparison to coconut oil. And Konar et al. Had used coconut oil in comparison to only massage. Kumar et al. Similarly had used coconut oil only with massage.
Thank you.
Thank you, sir.
Thank you very much. All the three participants have done really well. Very well conducted studies, well analyzed, and of course, well presented. So thank you all, and I'm really impressed with the presentation. Thank you.
Kindly wait a few minutes as the results are being discussed.
A very nice session, I must say, because social neonatology and community neonatology and neonatology at grassroots level should be encouraged. Only when they work, our neonatal morbidity and mortality in the country will come down, because level 3 NICUs are required, urban facilities are required, but we need more input from the community and from the periphery. So considering that all the three studies were good, the judges I was listening really proud them regarding the methodology and various other aspects. So it was a very stimulating and nice session. Have you arrived at the
So there's one prize only, unfortunately, but I think you should not worry about the prize because all the three studies are good. And what I've noted is people who don't win a prize often publish, and people who win a prize don't publish. So be careful about that. But I think the person who's going to get a prize is going to publish. So I'll take out the name straight away. So Dr. Janki Pal, outcome of coconut oil massage in newborns, has won the.
May I request senior neonatologist pediatrician from Indore, our past president, Dr. VP Goswami, to give away the winner's medal and cash prize to the winner. Well done, congratulations. May I request the to present to the one of the contestants and Dr. Amit Dahat to distribute to the other one. Peter.
virtual meeting online connect
I must say the contestants are fortunate. You are judged by 3 top judges. The past president. Who is the third? Please do come. Very fortunate.
background. Google ಮಾಡಿ ಬೇಡ ಬೇಡ
What I was saying was 3 powerful judges were present. Past president, member of the EB, and another member of the EB, Dr. Amit Dahat is member of the executive board from the West. Somshekhar Timbalkar is member of the EB, editor of the journal, and a very keen researcher. So, thank you very much.
Dispersing for lunch. So please come back at 2:05 for an infectious disease symposium. Thank you. Gautam, they gave father mic.
ಎಷ್ಟೊತ್ತು ಲಂಚ್ ಮಾಡಾಯ್ತು 45 minutes.
Can we now go who's the next person's anticoagulation unit? MDR. So that MDR is already there, but I think she's joining us virtually. You ask her anyway.
Okay.
This is not. You open that file and keep for him. Next talk to 5. Okay. Please talk again. Correct time.
ಯಾವುದು
Come, we have some time. We go out.
ಊಟ ನೋಡಿ ಸರ್ ಬನ್ನಿ ನೀವು
ನೋಡ್ತಾರೆ
ನೀವು ಬಂದ್ಬಿಡಿ
No, I'll actually eat later. When one of the dogs, it will be there. Why not?
Where, ma'am?
It will be there at 2:30. I won't eat. I'll come, but I won't eat. I'm really not hungry. All wastages are there. All are there. All are there. Just to call and after this. But right now, call someone for right now only call. Gita बोला. Rita Bola is coming physically or virtually. See, Dr. Jagdish Sahu is here, by the way. Please call Dr. Jagdish Sahu as well. Starting at 2. Could you please send me a one-slide sheet and will you be coming to chair the session?
आपके अपनी की जो बात देखा
not picking up.
She's not picking. Yes. Yes.
I know.
Okay. We might notify 10 minutes when the first talk starts, I will call you. So you have 20 minutes.
Is the room please?
You have to introduce the chairperson. You have to that's what I'm telling you. He's there. Tell him to send the seat. He's there. We saw him in that place. Hello. In the last day, now we've dispersed for lunch. After that, yeah, it's going fine. You know, person to part. Minanti more important. Banaras. Awang part. And Diwali ko, and Diwali ma ije. Only the part. And Diwali ma to use not to be. It is going to be the part. Okay.
Hello. Is the admin there?
बंद पडला ना तो
कर सकता है।
Committee of NNF. She is the contributor in Government of India Manual for APMC, KMC, COVID-19. She is currently the Secretary Assam State Chapter of NNF. She is a DM examiner at West Bengal and FDA examiner in numerous states. She is the past executive body member of IIP Neonatology Chapter and NNF India. She has got 46 publications on international and national journals. So she has received IIP Neonatology Fellowship in 1995 and WHO Neonatology Fellowship in 2003. And she has got GNE India Fund Scholarship of AAP in 2011. Then she has gone trained as an observer in neonatology in the Northwestern University of Chicago and University of Minnesota. Welcome you, ma'am, for this enlightening talk.
I bring greetings to you all from the state of Assam, and I'll be talking on multi-drug resistant infections in neonates. As we all know, antibiotic resistance has become a big threat to human health. The CDC as well as the WHO has recognized antimicrobial resistance as one of the 10 global public health threats facing humanity. We also know from different studies which are available to us now that NICU-admitted patients, especially the preterm babies, are at risk for infections by multi-drug resistant bacteria, and also that when they are infected with multi-drug resistant bacteria, it is associated with high mortality rate. Now, in today's discussion, we'll be shortly trying to discuss what is multi-drug resistance, how do bacteria become drug resistant, what is the epidemiology of multi-drug resistance at present, and what are the risk factors in NICU for development of multi-drug resistant bacteria, and the prevention and management of multi-drug resistant bacterial infection in the NICU. So as per the European Center for Disease Control and the Center for Disease Control, that is CDC Atlanta, multi-drug resistant organisms are those which acquire non-susceptibility to at least one antimicrobial in more than 3 microbial categories. Extensively drug-resistant organisms are those which are non-susceptible to at least one agent in all but 2 or fewer microbial categories. And pan-drug resistant organisms are also there, which can become resistant to all kinds of antimicrobial agents. Now, how do bacteria become drug resistant? To understand that, we have to again revisit how antibacterial agents work on the bacteria to prevent their multiplication. So bacteria, when they are targeted by antibacterial agents, the antibacterial agents prevent the transcription, that is formation of RNA from DNA, then translocation, that is synthesis of protein from the RNA, and also interfere with cell wall synthesis. So when the bacteria become resistant to the antimicrobial agents, that is antibiotics, then acquisition of enzyme can be there, which can alter the structure of the antibiotic, thereby making them unable to act on the bacteria. There can be mutation in bacterial target sites, like mutation in the penicillin binding protein or DNA gyrase, or there can be formation of certain efflux pumps, which can prevent entry of the antibiotics into the bacterial cells. The same is being shown here, the mechanism of resistance to various antibiotics in bacteria. So we can see that inside the bacterial cell, there can be alteration of drug target, or there can be drug inactivating enzymes. This is not working. Then there can be formation of efflux pumps, which actually leads to efflux of the antibiotics from the bacterial cells, or sometimes, as we can see in the next diagram, there can be formation of matrix with a cellular matrix, which can prevent entry of the antibiotics into the cells, bacterial cells. So the multi-drug resistant organisms and the selected examples of resistance mechanism is shown in this slide. So amongst the gram-positive organisms, Staphylococcus aureus, when they become methicillin resistant, they acquire the MEC-A gene. When Enterococcus species become vancomycin resistant, they acquire VAN-A or VAN-B enzyme. Amongst the gram-negative organisms, when they become extended spectrum beta-lactamase producers, they would acquire many enzymes which have been listed out there. Enzymes can be through genes which are acquired on the plasmid or in the chromosome. So if they are acquired on the plasmids, these bacteria can actually transmit this resistance horizontally to other bacteria. And when it is on the chromosome, this resistance can get transmitted vertically to the next generation of bacteria. There can be carbapenem resistant Enterobacteriaceae when they acquire NDM1 enzyme or KPC enzyme. And also there has been development of certain colistin resistant bacteria, which occurs when they acquire enzymes like IMP or MCR1. Now, what is the epidemiology of multi-drug resistant organism infection at present time? So this is a study which was published by Patel et al. In 2017. He had collected the data from 4 NICUs in United States, and he tried to look at the antibiotic susceptibility of gram-negative bacillus, which were isolated in this study. And he found that amongst all organisms, gentamicin resistance was observed in almost 14.8% of isolates, whereas for other antibiotics like piperacillin, tazobactam, it was 7%. For third generation cephalosporin, it was almost 9.9%. And for carbapenem agents, it was only 0.5%. So we can see that even in the Western countries, in the developed countries, multi-drug resistance has started, but it is still in a lower range. However, if we look at the lower and middle income countries, we may see something different. Now, this is one study which was published in the Lancet in August 2021, the Barnard study, the burden of antibiotic resistance in neonates from developing societies. This was initiated in 2015, and the objective of this study was characterization of common sepsis pathogens via whole genome sequencing, antimicrobial resistance profile observation, assessment of carrier rates of AMR genes in normal flora of mothers and neonates more than 7 days of age, and to assess the risk factors associated with neonatal sepsis. So a sub-study of this Barnard was published, which we have shown in the previous slide, and it had tried to look at the efficacy of the current WHO recommended treatment for neonatal sepsis, that is ampicillin and gentamicin. So 7 centers in lower and middle income countries were included in this study, one being from Kolkata, and they had enrolled 36,285 neonates, out of which 9,874 were suspected of sepsis, and whole genome sequence data was available for 1,046 isolates, whereas the minimal inhibitory concentration data was available for 1,029 isolates. Apart from other objectives, there one important objective was to look at the frequency of resistance. So what they found was that amongst all isolates which were studied, around 445 isolates, 390 were gram-negative organisms. That means in the developing countries, gram-negative organisms are the predominant organisms which cause neonatal sepsis. And out of all gram-negative organisms, 379, that is 97.2% were resistant to ampicillin, and 70.3% were resistant to gentamicin. And if we look at the cefotaxime group here, the cephalosporin group here, we can see the ceftriaxone, cefotaxime, ceftazidime, cefepime, all drugs were there was resistance for all these drugs in this group of organisms which were grown in this study. There was also resistance which was coming up for fosfomycin, 15.6%, and meropenem, 14.4%, and for imipenem, 15.9%. So we can see that there was multi-drug resistance in these isolates which were isolated from the neonates from these lower and middle income countries. Amongst the gram-positive organism, again, oxacillin resistance was seen in almost 47% of the isolates. There was also resistance against flucloxacillin, around 30%. And it is interesting to note that both for gram-positive as well as gram-negative organism, the sensitivity for amikacin was much better than that of gentamicin. This is one study which we all know about, the landmark study published from Delhi, the Dennis trial. They had also included a large number of babies in this trial, and their study had also shown that gram-negative bacilli are the most common organisms causing neonatal sepsis. And amongst the isolates which they had found in their study, Acinetobacter was the most common organism leading to neonatal sepsis amongst the gram-negative organism, followed by Klebsiella, Escherichia coli, Pseudomonas, and Enterobacter. And we can also see here that multi-drug resistance was seen in a very high proportion of cases. In the Acinetobacter group, it was observed in 82%. In Klebsiella, it was seen in 54%. In case of Escherichia coli, it was observed in 38%. In case of Pseudomonas, 19%. And in case of Enterobacter species, it was seen in almost 50%. And they had also compared the case fatality rate, and they had observed that the case fatality rate was much higher in the group of neonates who had infections due to multi-drug resistant organism compared to those who had sensitive pathogens. The gram-positive organisms in the same study had also shown much resistance. The most common organisms were Coagulous negative Staph and Staphylococcus aureus, and both of them had methicillin resistance. Cons had resistance of around 61%, whereas for Staphylococcus aureus it was 38%. Vancomycin resistance was not observed in these two groups, but for Enterococcus there was around 27% resistance for vancomycin. This is another study which was published from Pune very recently in July 2021. They had also tried to look at the pattern of organism which is causing neonatal sepsis in 3 hospitals in Pune. And they also found that gram-negative organisms were the most common organisms. And they tried to find out the distribution of bloodstream infection by day of life, and they plotted it in this diagram. And we can see the dark color being signifying the infection by gram-negative organism, which were carbapenem resistant organism. And we can see that right from day 1 till day 20, there was infection of the neonates with gram-negative organism, which were resistant to carbapenem. Now, this is another study. It is not a study, but a review article, which was published in 2019 in BMJ by Chorasa et al. And there they had reviewed regarding the incidence, case fatality rates, and infecting organism for neonatal sepsis in hospital-based studies. They had included studies from India, Pakistan, Bangladesh, Nepal, and Sri Lanka. And they found that, again, the most common organisms causing neonatal sepsis was gram-negative organism, followed by Staphylococcus aureus. And when they tried to look at the multi-drug resistance, they again found that in Klebsiella, the resistance was up to the level of 70.7%. In case of Acinetobacter, it was almost 78.7%, and in E. coli, it was almost 54%. So we can see that most of the organisms which are growing in lower and middle income countries in neonatal sepsis are because of multi-drug resistant organism. So we can infer that antimicrobial resistance is a bigger growing threat to newborns in lower and middle income countries as compared to the high income countries. Now, this is another review article which was published very recently in the Pediatric Research. It was published in October 2021 and by Flannery et al. They reviewed the neonatal multi-drug resistant gram-negative infections, epidemiology, mechanism of resistance, and management. And they concluded that resistance to the WHO assessed group of antibiotics, that is ampicillin, gentamicin, cephalosporin, tazobactam, piperacillin, is high and more so in lower and middle income countries. And the extended spectrum beta-lactamase producing Enterobacter C and the carbapenem resistant Enterobacter C, the prevalence varied in different geographical areas. It was in the range of 5 to 9% in India, and it is only less than 1% in US, whereas it is as high as 50% in countries like Ecuador in South America. So they concluded with the theme of multi-drug resistant gram-negative infection epidemiology in ICU. And they say that the epidemiology is complex. E. coli and Klebsiella are the two most common multi-drug resistant gram-negative organism which is seen. However, Acinetobacter baumannii, which is a hospital-acquired infection, has also emerged as an important multi-drug resistant gram-negative pathogen in NICUs. The rates of multi-drug resistant gram-negative colonization and infection varies by geographical area, with higher burden in the lower and middle income countries. Now, what are the risk factors for multi-drug resistant bloodstream infection in the NICUs? So again, the same author, Flannery, had mentioned regarding two groups of risk factors, the patient level risk factors and center level risk factors. Amongst the patient level risk factors, prematurity, very low birth weight, maternal or neonatal multi-drug resistant gram-negative colonization. So this is important to note. And prolonged hospitalization, prolonged antibiotic therapy or invasive procedures, neutropenia, underlying renal disease are supposed to be the risk factors. Whereas in center level risk factors, it is understuffing, overcrowding, history of prior outbreak in the unit, poor infection control practices, high antibiotic consumption, contaminated express breast milk, then artificial fingernails in the health workers, and most importantly, cockroach harboring multi-drug resistant gram-negative bacilli are the risk factors. And if we just see our SCA news and the NICUs, probably many of these risk factors would be prevalent in our SCA news. Now, what is the outcome of multi-drug resistant infection in NICU? So we have already said that in the Danish study, they had found that the population attributed risk for mortality in those who were having multi-drug resistant infection was 15.7% versus 12% in the non-multi-drug resistant organism infection. So the case fatality rate increases when there is multi-drug resistant infection. There is also prolonged hospital stay. In a review article published in the Indian Journal of Pediatrics in 2020 by Wattal et al. They mentioned that amongst their neonates who are there in their hospital, that is in the Gangaram Hospital in New Delhi, the average stay for a patient who has multi-drug resistant infection was 27 days compared to 20 days in a baby who is infected with susceptible organisms. There is also increased cost of therapy. In the Barnard study, they tried to look at the cost of therapy, and they mentioned that with addition of meropenem, there is excess of $14 expense. And then if it is colistin, then $8, and for tigecycline, it is $30 per day increase in expenses, and which often exceeds the income of the parents. Even in the same article that I had mentioned by Wattal et al., they had mentioned that for babies who are infected with multi-drug resistant organism, the cost comes to around 4.5 lakhs in their hospital, whereas it is comes to only 1.5 lakhs when it is with sensitive organism infection. There is also difficulty in choosing empirical antibiotics for the physicians when there is multi-drug resistant infection. So now regarding prevention, so this is again the key interventions which are mentioned.
5 more minutes.
Yeah.
Thank you.
Yeah. So Torres et al., they mentioned regarding certain key interventions to reduce the burden of sepsis and antimicrobial resistance in Southeast Asian countries. And these are starting from antenatal care, then intrapartum care, postnatal care, home and community, then health facilities and community. So in all steps, especially in our area where we are dealing with resource poor setting, all these factors to be looked at, and then we need to try to reduce the multi-drug resistant infections by taking out over these procedures. Now, how can we prevent multi-drug resistant infection in the NICU setup? So antibiotic stewardship is a very important effort, which is a collaborative effort of intensivist infectious disease physicians, nurses, pharmacists, hospital epidemiologists, and bioinformatics specialists. Then we need to maintain appropriate infection control measures in our NICUs. Hand hygiene is very, very important amongst all. Avoiding understaffing and overcrowding is important. And we need to have a definite antibiotic protocol in our NICUs based on the cultures which we have done in the last 6 months to 1 year. And then antibiotic use has to be very judicious. We need to isolate and cohort infants who have multi-drug resistant infections. And there should be ongoing education of the stakeholders, right from the fourth-grade employees, the nurses. Everyone should be continually taught about the importance of maintaining hygienic practices. And also there should be accurate microbiology procedure, including information. Whenever a growth is seen which is multi-drug resistant, they should be informing immediately rather than waiting for the report to come by itself, so that appropriate antibiotics can be taken up and other measures can be taken up in the NICU setup. Just a slide regarding antibiotic stewardship, because it is very important. It is a coordinated program that promotes the appropriate use of antimicrobials to improve patient outcomes, reduce microbial resistance, and decreases the spread of infections caused by multi-drug resistant organisms. It has different components, and this should be instituted in the hospitals. Now, the treatment, the empiric therapy should be started based on the local infection epidemiology and sensitivity pattern, but it should be stopped whenever the culture comes sterile. The Cochrane review, which was published in 2021, does not show that any regime is good enough to be recommended as such. And the NEO-MERO-1 trial, which has included almost 18 centers in different countries, did not establish superiority of meropenem included regimes over standard regimes, success or mortality. The definitive therapy for carbapenem-resistant enterobacteriaceae and ESBL infections should be based on antibiotic susceptibility. We know that we have been using colistin and tigecycline in the difficult cases, but we have to understand that they have a lot of toxicity and it should not be prescribed routinely. As we have mentioned already, the protocol has to be there. Novel beta-lactam and beta-lactamase inhibitors, including ceftazidime, avibactam, meropenem, vivorbactam, imipenem, colistin, rilabactam. These have been tried in adults, and studies are coming up which are also including pediatric populations, and probably we'll be having the results of these pediatric trials soon. The cefiderocol, which is also used in adult patients, which can be used in CRE infections, has also been is under a trial now. The phase 2 trial is underway. So in conclusion, I'd like to say that multi-drug resistant bacteria in the NICU are an increasing threat to the well-being of our smallest and most vulnerable infants. And routine surveillance cultures, effective antibiotic stewardship, and meticulous hand hygiene remains the best weapons we have to combat antibiotic resistance in our NICU. Thank you for your patient hearing.
Thank you so much, ma'am, for the enlightening talk. So, MDR organisms is a real threat for the NICU, particularly the level 3 NICUs who are managing more and more extreme premature babies. And the simple reason being more advanced procedure, more central lines, so more use of cephalosporins in those centers. But ma'am has told, we don't have much antibiotics now. Polystyrene, tigecycline, those are come fast. So why no recently there is no new antibiotics which is being produced. We have to be very cautious on use of antibiotics, and we need to be very courageous actually not to start an antibiotic to a baby who doesn't require it, and to stop it courageously also when you get a blood culture negative report. We have to have a strict antibiotic stewardship program. So otherwise it's a more or less team effort. So if a resident or a consultant starts an antibiotic in the night without just looking at a simple deterioration without analyzing whether it is actually sepsis or it is because of some simple measures, then actually it is really difficult next day for the next consultant who comes to actually downgrade immediately. So the challenge is always there, but a team effort, good protocol-based management, written policy, antibiotic policy, static feeding yearly, and just removing the IV line as early as possible. That's antibiotic use, and ultimately that can reduce the MDR infection. So thank you so much, ma'am, for the nice talk.
Thank you. Thank you so much, ma'am, for such a great start to the infectious symposium. And thank you so much, sir, for chairing the session. Moving on.
Our next talk is on fungal sepsis, and for that, I would like to welcome Dr. Deepa Hariharan. This talk is chaired by Dr. Chaitali, who is a consultant neonatologist at JJM Medical College, national trainer in NRP, currently divisional coordinator in NRP. Please welcome her. Ma'am, you're there?
Yeah, I'm there. Am I audible?
Yes, ma'am.
Okay. Thank you. Very good afternoon. It's my honor and pleasure to introduce Deepa Hariharan for the talk. Ma'am has got a very vast experience in neonatology, and currently she's running a 30-bedded NICU in Chennai. She has finished her residency in pediatrics at Cook County Hospital, Chicago, and also done a fellowship in neonatology from Children's Hospital, Philadelphia. Today, ma'am will be talking and discussing all about the fungal sepsis in neonates. As we all know, fungal sepsis is one of the emerging sepsis we are commonly seeing in the neonates. So let's listen from the stalwarts, Dr. Deepa Hariharan, regarding the fungal sepsis in neonates. Over to you, ma'am.
Dr. Deepa, we can see your screen, but you have to unmute yourself.
Okay. Am I audible now?
Yes, ma'am, you're audible now, and we can see your screen as well.
Yeah.
Thank you.
Okay. Yeah. Sure. Okay. Good afternoon, everybody. I would like to thank the organizers for giving me this opportunity. I think this is a good follow-up to the previous topic. The indiscriminate use of antibiotics, extensive use of antibiotics, has led to an increased risk of fungal sepsis in neonates. Candida sepsis is a significant problem in modern neonatal intensive care, with increased in neonatal intensive care, saving smaller and sicker babies, more invasive technologies. Fungal sepsis, especially Candida sepsis, is a very significant problem in modern neonatal intensive care. As you can see in this slide, the most important risk factors for fungal sepsis are extremely low birth weight and prematurity. You can see on the left side, there's a very significant incidence of fungal sepsis in babies who weigh less than 750 grams compared to those who weigh 1 kilo or more. And you can see that all over the world, including in India, there is a trend towards a slightly increasing incidence of fungal sepsis because of more invasive intensive care and saving sicker babies. Usually, Candida sepsis is a hospital-acquired infection. It begins with colonization of the gut. It's a triad that begins with colonization of the gut with Candida. And the most important predisposing factor to Candida colonization is use of broad-spectrum antibiotics, especially carbapenems and third-generation cephalosporins. After colonization, invasion, dissemination happens, and infection begins when there are breaches in the mucocutaneous barrier, the most important of which, highlighted in red on the left of the slide, is a central venous catheter or a PICC line. In addition, breaches in mucosal integrity in either the gastrointestinal or the respiratory tract due to intubation, NEC, etc., predisposed to the fungal dissemination. And the third part of the triad is proliferation, more invasion when there is immune suppression. The most important intrinsic immune suppression being prematurity itself, when there is very deficient cellular and humoral responses. In addition, iatrogenic immunosuppression such as steroids. So colonization, breaches in mucocutaneous barrier, and immune suppression predisposed to hospital-acquired severe fungal infection. The majority of the infection previously was Candida albicans, but recently we see increasing incidence of non-albicans such as Parasylosis glabrata, cruzi, tropicalis, and oris, which is multi-drug resistant. This discussion will be limited to Candida infections, half of which is albicans and half of which is non-albicans. This has treatment implications. The initial signs and symptoms of fungal sepsis are non-specific, often subtle, and it usually mimics bacterial infections and cannot be differentiated from other infections in early stages. But the main feature is in fungal infections, it can be insidious, a little subtle in the beginning, and you realize you're in trouble only when the baby is almost crashing. The clinical features of systemic candidiasis in the early stages, as you can see, are non-specific and include lethargy, hypotonia, apnea, respiratory distress, shock, temperature instability, hyperglycemia, feed intolerance. Maybe hyperglycemia happens more in fungal than in bacterial sepsis, but all the other features are similar for any form of infection. So in view of this, certain prediction models have been developed clinically in order to diagnose fungal sepsis before the cultures are available. The prediction models state a high risk of fungal sepsis if any of the previously mentioned non-specific symptoms are present in the presence of these additional risk factors, especially extremely low birth weight with a PICC line in situ, most importantly, exposed to broad spectrum antibiotics such as cephalosporins, carbapenem within the last 7 days, and new onset thrombocytopenia on presentation. So a sick baby who has spent some time in the NICU and was exposed to broad spectrum antibiotics, when there are new symptoms, the possibility of fungal infection is high as per the prediction models. Next, dissemination happens rapidly in fungal sepsis and affects long-term outcomes. Dissemination is an important feature of fungal sepsis. As you can see in this slide, following hematogenous dissemination, invasive focal infections can happen in various organs, including the eye, lung, liver, heart, brain, etc. And as stated here by an expert very beautifully, positive Candida blood culture is almost always a tip of the iceberg, and it means that at least 4 organs have usually been involved already. And about 50% of babies with Candida infection have neurodevelopmental sequelae with or without CNS involvement. So the most common site of one of the most common sites of focal invasive infection is the urinary tract. Candida UTI is more common when there has been urinary tract obstruction, stasis, or presence of indwelling catheter. It is typically diagnosed by suprapubic aspirate culture for Candida. And sometimes there may also be fungal balls in the kidney or other evidence of obstructive uropathy demonstrated by ultrasound. The next common site of focal invasive disease is the CNS, especially more common in newborns compared to older age group. CNS involvement can manifest as meningitis, brain abscess, ventriculitis. But here an important feature is CSF analysis findings may be equivocal or even absent despite CNS involvement. And when there's a high index of clinical suspicion, imaging studies are also needed. Other organs in which you can get focal invasive infection include the eye. You can get those typical cotton wool infiltrates, more severe retinopathy of prematurity, focal bowel perforation or extensive NEC, vegetations, endocarditis, and hepatosplenic abscesses. Next is the diagnosis. Laboratory diagnosis of Candida sepsis continues to be challenging and mainly depends upon isolation of the fungus. Fungal isolation by blood culture is positive only in 50% of the cases, which is a big challenge in treating Candida based on cultures. Larger volumes, as much as 3 to 5 ml, multiple cultures, repeated cultures, culture of urine, CSF, peritoneal fluid, etc., may increase the isolation rate for the fungus. In addition, radiologic studies, eye exam are needed. But biomarkers such as beta-D-glucan, more used in oncology, etc., have only negative predictive value in neonates. So the diagnosis depends upon culture. And the more aggressive you are about chasing it by using larger volumes, repeated cultures, the more likely you're going to find it. Next comes the million-dollar question, which antifungal to use? Which antifungal to use needs a thorough understanding of the pathophysiology of the infection, as well as the pharmacokinetics of the drug. The pharmacokinetics matter more in fungal infection compared to bacterial and other infections, as you will see in the coming slides. There are 3 commonly used drugs in fungal sepsis: amphotericin B, fluconazole, and micafungin. And we are all interested in knowing which drug is the best, which drug should I use, etc. You can see amphotericin B, as shown in the left column of this table, is a fungicidal drug, effective against most species of Candida. Maybe a few auras, etc., might be resistant to it. It is available only by intravenous route, has good tissue penetration. But as you can see in the last row highlighted in red, amphotericin B therapy needs frequent monitoring in view of its toxicity, especially electrolytes, kidney function, and it carries a significant risk of phlebitis practically. The second drug in the middle column, fluconazole, a fungistatic azole, but very effective against most species. A few species of Glabrata cruzi may be resistant. You can see highlighted in green the 2 main advantages of fluconazole therapy. It has good oral bioavailability, so follow-up oral therapy is feasible, which is very important because duration of fungal therapy is usually prolonged, and non-compliance can lead to failures. And the most advantageous aspect of fluconazole therapy, which is not so well known, is that it has very excellent tissue penetration because it has very low protein binding. In almost all the organs, it reaches therapeutic levels, and it has very insignificant toxicity in neonates. The third category, in the third column, micafungin, fungicidal icanocandim, majority of species are sensitive to it, intravenous. But highlighted in red is a very major drawback while using micafungin. It doesn't have very good penetration into the CNS and the eye, the vitreous, which are very important sites of fungal dissemination in newborns. And rather than toxicity, cost is a major factor while using micafungin. Liposomal amphotericin B and newer azoles are not really recommended in neonates. But by using fluconazole, the drug that has excellent tissue penetration and oral bioavailability, there are 2 important factors that need to be considered while using fluconazole successfully. One is choosing the right dosage. This is a very important study done by pioneers in fungal sepsis worldwide. And you can see here that to reach therapeutic levels of fluconazole, doses as high as even 15 to 25 milligram per kilo per day have been used. And you can see that the higher the post-gestation and postnatal age, the higher the dose that's needed. So a therapeutic concentration of fluconazole in infants with invasive candidiasis requires dosing substantially greater than most commonly recommended in most reference textbooks. And the recent editions of the Red Book, the AAP guidelines, also state higher doses of fluconazole, starting at least 15 milligram per kilo. And the second important aspect of fluconazole doses, a loading dose is needed. It follows area under the curve target at about 800 milligram hour per liter. And you can see marked by the blue arrow here. Only 5 days after starting therapy, the therapeutic level of at least 800 AUC is reached. So giving a loading dose results in earlier therapeutic effect. So for better use of fluconazole, which has good tissue penetration, low cost, less toxicity, and oral bioavailability, higher dose and loading dose are needed. So this is a guideline, again, from one of the leading experts, Kaufman and all. And for starting drug, usually in adult and pediatric ICUs, is icanocandan. And once after the species is identified, step-down therapy can be done. But you can see highlighted by the red circle on the left-hand side, an alternative initial therapy for most of the species would be high-dose fluconazole. And step-down therapy to high-dose fluconazole is possible even in some strains which show partial resistance in vitro sensitivity, but a much higher minimum inhibitory concentration. So except for a few species of Krusei and Oris, most of the times initial therapy can be fluconazole, or even if an icanocandan is started, like it can be stepped down to fluconazole after sensitivity and clinical stabilization. And therapy should be started as early as possible, because even while awaiting the cultures, the 2 to 5 day delay also can result in adverse neurodevelopmental outcomes later. And treatment is prolonged. It is 14 to 21 days from microbiologic clearance. Microbiologic clearance should be documented in addition to clinical improvement by 2 negative cultures, as well as radiologic clearance or clearance by eye exam. And after clinical improvement and negative cultures, still 14 more days of therapy are needed. In addition to early efficacious antifungal therapy, starting it empirically in high-risk patients, giving the right dose, choosing the right drug, as important as early efficacious pharmacotherapy, source control is a very important determinant of successful therapy. As you can see here, in the chain of infection, everything begins with a portal of entry, and hitting the bug at the portal of entry, whether it's bacteria or fungus, is important. Hitting the portal of entry, stopping the portal of entry is important to get successful outcomes. More important in fungus, as you can see, compared to bacteria. And the most important source control is removal of the PICC line or the central venous catheter. You can see in this graph here, in the PICC line, a dense biofilm is formed by the fungus, in which bacteria cannot penetrate, and it will keep antimicrobials cannot penetrate, antifungals cannot penetrate the biofilm. And the only way to remove the portal of entry is to remove the PICC line. And as shown in this table here, when there's persistent candidemia for more than 3 days with the central venous catheter in situ, there's a significantly high morbidity and mortality. The longer you leave the central line, the more the morbidity and mortality. And inter-unit variability in fungal outcomes are related more to how early the central line is removed rather than to what drug is used. Other sources of control include nephrostomies, ureterostomies, ileostomies, CSF drainage procedures, etc., to control the virus at the portal, fungus at the portal of entry. So in summary, I would like to summarize our experience with Candida sepsis. We are a 32-bedded NICU, predominantly referrals. 90% of our cases are referred. This is under publication. And this illustrates the principles that have been talked about during this presentation. Consistent with world data, we find that it's the extremely low birth weight or the very low birth weight who are at great risk of fungal sepsis. This is based on 61 fungal sepsis in the last 3 years. Majority were less than 1 kilogram weight. We hardly see fungal sepsis in babies more than 1.5 kilos. These are the sickest babies who have more procedures, who are more exposed to antibiotics, who have more PICC lines in situ. And you can see, similar to the world literature, at least half of the Candida now roughly is non-albicans, while it used to be more than half were albicans a few years back. Increasingly, we see non-albican species. And this is the most important summary of my talk. You need to hit hard and early for better fungal outcomes in fungal sepsis. We compared 2 time periods where we aggressively implemented 5 principles of contemporary therapy. The 5 principles that we implemented very aggressively for better outcomes are shown in the box here. First, we used a loading dose of fluconazole, at least 15 to 20 milligram per kilo. Maintenance dose was higher, at least 12 milligram per kilo, 12 to 15 milligram per kilo. And in any baby in whom we strongly suspected fungal sepsis, the PICC line was removed within 24 hours of suspicion, not proving the diagnosis. And in babies who were very high risk based on the prediction models, that is, they were extremely low birth weight and exposed to broad spectrum antibiotics within the past 7 days, carbapenem or vancomycin or third generation cephalosporin, and had a PICC line in situ. Empiric therapy was started even while awaiting cultures to avoid the 2 to 5 day delay in starting antifungal therapy. And the 5th principle was that therapy was completed at least for 3 weeks and definitely for 2 weeks after demonstrating microbiologic clearance of the fungus by negative cultures. You can see the outcomes in the red arrow with the stopwatch sign. The left was before aggressive implementation of these 5 principles, and the right side is post implementation of these principles. Significant reduction in focal invasive disease such as urinary tract infection, fungal balls, obstructive uropathy, long-term kidney disease, very less CNS sequelae, no endocarditis, and very less mortality compared to before we started using high-dose fluconazole and before we implemented the prediction models for empirically starting fungal therapy rather than awaiting cultures. And after emphasizing that the full treatment is completed after demonstrating microbiologic clearance. With these principles, a significant reduction both in mortality, morbidity, as well as long-term complications. And finally, I would like to conclude by saying that for optimal outcomes in fungal sepsis, it should be a teamwork with the microbiologist and most importantly, the infectious disease expert. Infectious disease experts, they help us in treating fungal sepsis in 2 main methods. One is they understand drug pharmacokinetics better, and they understand the concept of minimum inhibitory concentration and how to translate minimum inhibitory concentration into clinical practice rather than go on resistance and sensitivity to a drug, which is a fairly crude term when it comes to fungal sepsis. Understanding the concept of minimum inhibitory concentration and translating it into practice allows you to less use the new fungal therapies like micafungin and even amphotericin B and predominantly use fluconazole effectively. For this, an infectious disease expert can guide you better understanding the MIC stated in the sensitivity pattern given by the lab. An infectious disease expert also pushes you to use reference labs that give you better minimum inhibitory concentrations compared to smaller labs that just identify the fungus. And more importantly, infectious disease experts are not as possessive about the PICC lines as we are, and therefore they push us to remove the central line earlier, all of which lead to better outcomes in fungal sepsis. Thank you for your attention.
Thank you, Deepa ma'am, for this wonderful talk. We have our next talk on lumbar puncture in a well neonate by Dr. Venkatesh, who has a fellowship in neonatology He has published many books and theses. He has received India Gynae Fund awarded by American Academy of Pediatrics. He was the secretary of NNF Karnataka and of Bangalore Neonatal Research Foundation. Please welcome him.
Hello. Thank you so much. I thank at the outset, I thank the organizers for giving me this opportunity to deliver this talk. The lumbar puncture in a well neonate. So we all know that the lumbar puncture is used all over the world routinely in the care of sick neonate. But here the topic is lumbar puncture in a well neonate. So I started wondering when the topic was given to me, there were many unanswered questions ran in my mind. So I thought actually whether this topic was given to me by mistake. And we all know that convincing parents for lumbar puncture so difficult even when we deal with sick neonates. When it is so, how it is possible for a well neonate? When I say that well neonate, then actually I start what actually I should understand by well baby, not even it was given in inverted comma. But still I agreed to deliver a talk thinking that just making the dialogue a modified one as apparently well-looking neonate. So why this lumbar puncture? We all know that if you see the cartoon here, the lumbar puncture evaluates my head, that evaluates my headache, can cause a headache. It's very, very important. That means clearly indicates that when you want to do this procedure, make sure that you're sure about this procedure and the, clinically you are suspecting this,
Venkatesh,
this.
sir.
Hi, hello.
Hello, sir.
Yeah.
So could you make it in presentation mode? Your slides?
Yeah, okay.
Full screen, sir.
Now?
Yes, sir. It's still in the...
Oh, really?
Yes. We can see your slides, but
One
make
second.
it full screen.
Yeah, I made it full screen.
Okay, sir. We can see your slides, though. Thank you, sir. We continue.
Okay, no problem. So we all know that the clinical features is challenging, and why this in neonatology? Because we all know that children below 1 year of age, they are more prone for meningitis, and we all know that CSF is the gold standard to rule out meningitis, but doesn't mean that the negative culture rules out meningitis, and of course the negative culture is always reassuring. So why this topic? Because most of the times we see the CSF culture. Positive CSF culture you see in 30% of cases, though there is negative blood culture. Similarly, if you see the negative CSF culture, if you see that the negative, the blood culture is negative in 15 to 38% of babies, but still you'll find the positivity in the CSF culture. This is very, very important. Why? There is a lot of confusion actually whether to do lumbar puncture in all the babies or only the babies who are demonstrating the blood culture positivity. So why is the need for the cerebrospinal tap? If you look at this graph, the incidence per that is the 1,000 live births. If you look at India stands second in this scale. If you look at the developing countries and developed countries, the incidence is very high. That clearly indicates that the need for lumbar puncture in our country. And we always do any suspected sepsis, and if there is positive CRP, blood culture, of course, and any neonate coming to you with a seizure disorder, to rule out meningitis, and of course, negative culture becoming positive. That is also another important thing. So you may find that one hospital doing lumbar puncture negative, but subsequently when the baby comes to you, that indicates the positivity. And of course, it also helps us to prognosticate in this neonate. I just start dealing with these scenarios step by step, taking cases into considerations. And case one, term appropriate for gestational age neonate, brought to emergency room with hurried breathing. She was born full term with premature rupture of membrane for 72 hours. The complete blood count was normal and CRP was around 8 milligram per deciliter and started on antibiotics. Blood culture was negative. The resident on duty calls me saying that she wants to do lumbar puncture in apparently normal baby. So if you look at the CRP in this scenario, everything was fine. The culture was negative, but the CRP was positive. Cutoff was 5 milligram per deciliter.
Sir?
What exactly I was going through the literature, do we find most of the times actually we say, oh, CRP negative, CRP positive, blood culture negative, hold on, just give for 5 to 7 days of antibiotics and stop it. Is it true?
Your
Just
slides
ask.
are not moving.
Hello.
Hello, sir. Your slides are not moving, sir. We are still on the need for CSF tab slide. The next slide. It's not moving.
It's not moving.
No, sir.
Oh. No?
No, sir, not yet.
I'll just, I don't know why it's not moving. One second. Is it okay?
Yes, sir. Yes, sir.
So looked at the
Slideshow
evidence.
mode.
Hello?
Hello, sir. Can you
Yeah.
slideshow mode?
Slideshow mode. I have already gone to slideshow mode. I am in the slideshow mode.
Okay, sir.
Yeah, I think, I don't know.
Yes, sir. Now we can see your next slide. We can see it, sir. Your case 2.
Okay, so no, I not finished the case one. So the CRP was taken as a guideline for, looking at whether the lumbar puncture is required or not. The NICE guidelines looked at, what did they do? The guidelines said CRP positivity, especially when the CRP in early onset sepsis demonstrating more than 10 milligram per deciliter, should have the lumbar puncture done. So what happened in Europe, in UK, the lumbar punctures and CSF levels seen in case of neonatal meningitis, they asked actually 137 trust hospitals were asked to look at the correlation between the CRP and the CSF analysis. And here the cutoff was more than 10 milligram per deciliter. What did they find was, there was no correlation between the CRP and the CSF result. So therefore, they said actually the recommendation that was given by the NICE guidelines could not be taken into considerations. Therefore, what they did, so they said, therefore, do not recommend a universal cutoff rather than considering the whole clinical picture. So look at the baby. If you feel that clinically baby is septic, so then it is, and in addition to that, the CRP being positive, that could be the reason for doing the lumbar puncture. The second case, a term male neonate born to a non-consanguineous couple, mother had fever and diagnosed to have urinary tract infection, cried immediately after birth and underwent septic screen for infection and had level of WBC count of 3,000 cells. The neonatal fellow on call wants a lipid done in an apparently normal neonate. He calls his consultant. So here again, going back to the effect of complete bed count timing on lumbar puncture rates in asymptomatic infants born to mothers with chorioamnionitis. If you look at, this is a study done at New York Hospital, and there are 230 babies were taken, and they were divided into 2 groups, early and then late. So a retrospective study was done in asymptomatic infants admitted for sepsis evaluation secondary to maternal chorioamnionitis. And the subjects were grouped into 2 groups, early, that is the CBC doing less than 4 hours of life, and late, that is doing the CBC after 4 hours of life. What they found out was asymptomatic full-term infants undergoing evaluation for sepsis secondary to maternal chorioamnionitis are less likely to undergo lumbar puncture if their initial CBC was obtained at a greater than 4 hours of age. So again, the time, according to timing, you could see that. But here again, if you look at this literature, they found out that just looking at the WBC count, not enough, and it always goes with the clinical sepsis and strong suspicion of clinical sepsis with blood culture positivity, and having 2 other parameters like platelet count low, all these things could be a possible thing actually to have lumbar puncture in apparently normal child. So it seems that there's no need to carry out lumbar puncture in neonates suspected to have early sepsis, who are being evaluated purely for perinatal risk factors. It should still be undertaken in babies with severe illness or obviously where meningitis is strongly suspected. So what the thing here turned out to be, the role of lumbar puncture in neonates who are healthy appearing but have maternal risk factors for sepsis is more controversial. The yield of lumbar puncture in these patients will be low. This is what exactly published in 2003 in Archives of Fetal and Neonatal Medicine. The third case is apparently normal neonate admitted for suspicion of sepsis. The debate was whether the lumbar puncture should be considered to complete workup in neonatal sepsis. So here again, there was a prospective study done for about 6 months. 169 babies were enrolled. The routine lumbar puncture done as a part of complete workup. Here, among babies with suspected clinical sepsis, only 5 were diagnosed to have meningitis. None of the clinically normal babies with high-risk obstetric factors alone had meningitis. And the lumbar puncture was traumatic in 22.9% and in 26.3%. The fluid obtained was inadequate for complete analysis.
Once again, slides are not moving, sir.
Okay.
We're still stuck on the case 2 slide.
Okay. Now it's okay?
Yes, sir. We can see this slide.
Yep. Yeah. So the prospective study was conducted here by Dr. Narang and the team. And here what they found out, so routine lumbar puncture may not be required in clinically normal newborns with adverse obstetric factors. In babies with clinical sepsis, though the yield is not very high, there are no reliable clinical or laboratory markers to predict which babies will have meningitis, and hence these babies should warrant a lumbar puncture. That's what the end of the story in this article. The case for a term neonate admitted into NICU with the maternal concern that her newborn became dusky a couple of times. On examination, the neonate looked well with normal bloods. The cerebrospinal fluid analysis was performed and was normal. The antibiotics were stopped after the reports became normal and discharged. Within 24 hours, she presented to the emergency room with poor feeding and she was looking dusky, often with video capture demonstrating the seizure at home. Lipid blood culture showed bacterial meningitis. So again, this is another important thing one should know. Recognizing early meningitis, but a missed opportunity to diagnose meningitis is very, very important. So when baby presented in the initial phase, when the cerebrospinal fluid was performed, that actually demonstrated it was sterile. But subsequently, when the baby presented to us again after 24 hours, so look at the CSF becoming positive. What does it indicate? It clearly indicates that in a sick baby, when the baby comes to us, thinking that looking apparently normal, and even then, actually, when we perform lumbar puncture and then having normal report, doesn't mean that that baby will not have meningitis. That's why to give parents appropriate safety netting advice if the initial CSF is negative, as it doesn't completely exclude meningitis, very, very important. So even when the baby is with suspicion of infection in the brain, but you think that it is apparently normal, do lumbar puncture, get the baby discharged, again baby coming back. So one caution always need to be informed to the parents that if any worries, please come back, you may require to do one more lumbar puncture.
Sir, is it okay if we project the slides?
Yeah, please. Yeah, sure. You can do that.
Tell us next, we'll move on to the next slide because we're having a problem with the slide.
Okay.
Okay, so we're just projecting our slides from your.
Okay. No.
So could you tell us a slide number you're on right now? Because we're still on slide 6.
Case 5. I stop share?
So you can stop sharing your screen.
Yeah.
So could you tell us which slide number you're on?
Slide number, okay. Case 2, 15. Oh, 1 second. Yeah, just you can keep moving, I tell you.
Okay, sir. So can you see our slides? We are sharing.
Yeah. Keep moving.
Yes.
Yeah. Case 5, case 6, yeah. Okay. Case 5, go to the case 5. I think, yeah. So a term with suspected sepsis underwent lumbar puncture and yielded no growth in the CSF culture. And then we thought of performing the CSF CRP, and we did it. Next slide, please. So evidence for performing this cerebrospinal fluid CRP So an article mentioning that CRP of cerebrospinal fluid as a sensitive approach for diagnosis of neonatal meningitis. Here again, a cross section was done, and around 49 babies were chosen for this. The diagnostic value of CSF CRP levels for differentiating between septic and aseptic infantile meningitis. Cross-section study was performed. The CRP levels were obtained as 0.9 to 0.68 milligram per liter. And then actually what they did, they divided into two groups, that is 20 of septic groups and 29 aseptic groups. And what they found was CSF CRP, as per the article, has suitable diagnostic value in distinguishing between the baby with bacterial and aseptic meningitis, especially in case of negative bacterial culture of the blood and spinal fluid. So there is still a role of performing cerebrospinal fluid CRP. When you suspect meningitis strongly, at least it differentiates between the septic and aseptic meningitis. This is an article again by a group published in Optical Health Science in 2019. Yeah, next slide, please. A term 40 weeks neonate admitted into NICU with history of not feeding well and not active on day of life. An examination looked well with normal vitals. The routine workup was performed to rule out sepsis. The CRP was positive, started on antibiotics. The blood culture was negative. The CSF culture grew E. coli. The baby was treated with antibiotics. The guarded prognosis was explained to the parents. Next slide, please. So again, this is an article looking at in a baby with meningitis, CSF positive culture, CSF negative culture. Here they looked at cerebrospinal fluid culture positive bacterial meningitis increases the risk for neurological damage among neonates. This is very important. Compare the clinical features. Now, if you look at the what they did actually, the babies who were clinically septic and then growing organisms with cerebrospinal fluid, and babies with the signs, demonstrating meningitis and not demonstrating any culture positivity in the CSF. So if you looked at the two groups and those babies who were positive for CSF culture, meningitis, so they all demonstrated neurological bad outcome. So those negatives actually, the risk of neurological outcome was less. So what does it indicate? In a baby where we demonstrate a positivity in the CSF fluid culture positivity, we should always give the guarded prognosis. Not that actually we should not give guarded prognosis to those babies with CSF negativity, but at least it is better compared to those babies who show the positivity in the CSF fluid. Next slide, please. So then the take-home message is here. The clinician has a big role in deciding which way we should have lumbar puncture. So always go with the clinics. The normal CSF values vary between preterm and term neonates. Hence, we need to have a reference value for the term babies, gestation-wise we need to have, because entirely they are different. Absence of growth does not rule out meningitis. And also it helps actually in the prognostication of the case. So thanks for the patient hearing. Next slide, please. Yeah, thanks for the patient hearing.
Thank you so much, sir, for that talk. Do we have any questions from the audience? Thank you, sir, for joining us on this talk.
Thank you.
Moving on.
Humankind has seen 19 major outbreaks from the plague of Justinian in 541 to the present COVID. Millions and millions have died. How can we prevent the death? By better and proper management. So now we have Dr. Aparna Chandrasekaran to give a talk on management of outbreaks. This talk is led by Dr. Rahul Verma. Welcome you, ma'am. Welcome you, sir. Dr. Aparna Chandrasekhar, Clinical Director, Neonatology, KIMS Pedals, Hyderabad. 20 publications in index journals and 20 book chapters. Young Achiever in Neonat awarded from the 2 Telugu states 2017 by Times of India. Over to you, ma'am.
Thank you very much. At the outset, I thank the organizers of NeoCon 2021 for giving me this opportunity. I shall be discussing over the next maybe 18 minutes or so on the aspects of managing an outbreak in the NICU. I hope my slides are visible. Could you confirm if the slides are visible?
Yes, they are visible.
Okay. So as we all know, and as we all have been hearing from the previous speakers, neonatal sepsis is one of the 3 leading causes of neonatal mortality, along with prematurity and perinatal asphyxia. Now, when you look at the profile of organisms causing infections, particularly in context of late onset sepsis in neonatal intensive care units, we find a stark contrast in the profile of the microbiological etiology in the high countries versus
in the slideshow mode. Slideshow mode.
Is it not in the slideshow mode?
Yes, ma'am.
Let me stop sharing and start sharing one more time. Please confirm if it's in slideshow mode now.
Yes, ma'am. It is in the slideshow mode now. We can see.
Thank you.
Thank you.
So, as we all know, while we compare the profile of organisms causing late onset sepsis in the high income countries versus low income countries, there is a remarkable, or there is a stark contrast in the profile of organism C. Now you can see this figure, which is derived from the NICHD data, which is quite old, from 2002, from Barbara Stoll and group, where it is seen that out of nearly 1,500 isolates, 1,536 isolates grown after 72 hours of postnatal life, almost 70%, that is 922 isolates, were gram-positive in high-income countries' NICUs, of which the most predominant organism was coagulase-negative Staphylococcus, seen in association with the use of central lines. Whereas Indian data from the Delhi Neonatal Infection Surveillance Group, the DENIS, which has already been presented in a previous talk, showed that 2/3 of organisms causing late onset sepsis in the Indian population is gram-negative. Now, looking at the 1,005 isolates which were born from the otherwise sterile sites in newborns in the DENIS study, nearly 60% were gram-negative, of which the predominant cause was Acinetobacter, which was responsible for 22% of the isolates, followed by Klebsiella and E. coli, whereas gram-positive organisms accounted for the remainder, of which coagulase-negative Staphylococcus accounted for 50%, followed closely by Staphylococcus aureus. Now, an outbreak is defined as the occurrence of a disease at a greater than usual, that is greater than expected rate or incidence within a geographical area and over a definite time period. Now, prevention or management of the outbreak would be essentially in lines of prevention or management of hospital-acquired infections in NICUs, and hence I shall stick to the various means and ways by which one can prevent the natural journey of a microbe. So the simplest way of outcoming an outbreak would be to try and imagine the journey, the natural journey of a microbe from the point of entry to proliferation and the transmission from baby to baby. So the points at which we can check this transmission would include hand hygiene and the use of various bundles of care for prevention of entry, prevention of proliferation by following strict housekeeping and disinfection routines, and prevention of transmission from baby to baby by the use of boundaries and disposables, and improving immunity by the use of mother's own milk feeding and early enteral feeding, kangaroo mother care, etc. Over and above all this, it requires administrative role and willpower. So focusing first, we are going to discuss 10 steps in the management or prevention of outbreaks. So all the steps of the World Health Organization recommendations on hand washing. And despite the knowledge of the role of hand hygiene in the prevention of transmission of neonatal infections, particularly hospital-acquired infections, it is found that compliance to hand hygiene remains as low as 23%, and this is data from 2 units in South India. And when we looked at the fishbone analysis of the study, looking at different factors related to the place, people, policy, and procedure, it was found that the various factors responsible for poor compliance to hand hygiene included the lack of availability of sufficient hand rub and soap solution, having inadequate hand washing stations and disposable hand towels not having a written policy on hand hygiene, and not following all the 11 steps of the World Health Organization's hand hygiene performance, and not following WHO's 5 moments of hand hygiene. Over and above all this, lack of knowledge and training and understaffing were found to be important factors in or barriers in the performance of hand hygiene. So this was the lessons learned from a quality improvement initiative, which was aimed to improve the compliance to hand hygiene with a smart aim of improving compliance from 20% to 60%. So they identified few key drivers in the form of improving awareness of hand hygiene through display of posters by morning, as well as continued ongoing education sessions for the healthcare providers through the day, by improving accessibility and availability of hand rub and hand wash solutions, by round-the-clock availability of soap and alcoholic hand rubs, and ensuring adequate availability of autoclaved paper towels, and by improving the motivation levels among healthcare providers, by giving weekly performance feedback and audits, and by appreciating those with good compliance to hand hygiene. When all these steps were performed using PDSA cycles over an intervention phase which lasted 32 weeks, it was found that the compliance to hand hygiene improved from 27 to 57%. So it has been seen from a systematic review of different observational studies on strategies and interventions to improve hand hygiene that a combination of behavioral changes and strategies is found to improve the compliance of hand hygiene by almost 42% with a confidence interval of 40 to 44%. And it is also found to translate into a lower incidence of hospital-acquired infections by 43% and a potential for reduction in in-hospital mortality by 46%. So a relative risk of 0.54 with 95% confidence intervals not crossing 1, which means a statistically significant reduction in the incidence of in-hospital mortality related to sepsis. So it shows that regular strategies and behavioral interventions must be undertaken to improve compliance to hand hygiene. Now, coming to the method of hand hygiene per se, we know that there are differences between hand wash versus alcohol-based hand rubs. However, studies which have compared hand washing versus alcohol-based hand rubs have found no difference in the incidence of hospital-acquired infections, central line-associated bloodstream infections, or in ventilator-associated pneumonia, although one observational study found that alcohol-associated hand rubs may be associated with better reduction in the bacterial load in the healthcare providers' hands. One has to remember that hand hygiene can be practiced by either hand washing or hand rubs in the 5 moments of hand hygiene, although hand washing may be preferable at NICU entry and when the hands are visibly soiled. Now, it is also important to remember some of the good practices with the gloving while discussing hand hygiene. So it is important to wear gloves when there is reasonable anticipated contact with blood or other potentially infected materials or mucous membranes. But it has to be remembered that gloving does not replace hand hygiene. So also important to remember that we should not wear the same pair of gloves for more than one patient or in the same patient while moving from a contaminated body site to another body site. Now, the second important strategy in the management of healthcare-associated infection outbreaks is ANTT or aseptic non-touch technique, which relies on the principle of protection of the key parts on the key sites. So the key parts of the patient's skin or body, especially the site of insertion of the central line or the site of the skin which underlies the dressing of the central line, and also the key sites in the equipment which include the tip of the needle, the tip of the hub, which come in close contact with the body tissues. So the key principles of ANTT are wash hands effectively, never touch key parts or key sites even when gloved, and touching non-key parts with confidence. As you can see here, the key parts such as the tip of the syringe or the tip of the needle are always protected and kept sterile even while preparing for the procedure. And this, when followed for peripheral intravenous line, central line insertion, or administration of intravenous solutions or endotracheal suctioning, again has been found to result in a reduction of episodes of hospital-acquired infection, CLABSI, and it also has been found to improve compliance to other steps of infection prevention, such as pre-procedure hand hygiene, correct use of gloves, key part protection, and non-touch technique use per se, and also the key part cleaning. The third important step is kind of adherence to standards in avoidance. So a clear floor space for level 3 and 100 SFT for level 2 area, and this is inclusive of 50 square feet of ancillary area. So if you're thinking about a level 3 NICU, it should be 100 SFT of clinical area and 50 SFT of ancillary area, and level 2 should be 50 plus 50 SFT each of clinical and ancillary space. So this is one of the very important considerations again in overcoming the burden of HAIs. Moving next to another very important consideration, nursing ratio. So again, it is important to remember at least 1:1 ratio must be there for babies who are on multi-system support, such as ventilation, peritoneal dialysis, multiple inotropes, etc. 1:2 ratio is preferable for babies who are on ventilator support but sick. And when it comes to step down, such as babies who are on oxygen or HFNC or CPAP, 1:3 to 1:4 ratio may be ideal, but up to 1:5 may be acceptable. And all this must also be kept in mind that there must be a 30% provision for leaves and offs. So essentially, when we look at the evidence, which is kind of evaluating the effect of optimal nursing ratio on neonatal outcomes, it has been clearly shown that having the higher nurse to patient ratio, that is having optimal ratio staff to patient, has been associated with a reduction in the risk of hospital-acquired infection with the odds ratio of 0.8, 95% confidence interval again are not crossing 1, showing a statistically significant reduction in the incidence of infections up to the tune of 20% by having optimal ratio of nurses. The fifth important step is air management by having 90% efficiency of filtration and at least 4 to 6 air exchanges per hour. This has gained a lot of importance, particularly after the COVID pandemic. I'll quickly move on to this bundle, the CLAPSI bundle and the VAP bundle. So in low middle income countries like India, the use of peripheral lines itself is associated with a high risk of infections, and having a dressing kit or a peripheral line insertion kit which contains sterile gloves, sterile cotton with a hand rub solution with a flush can be one of the most important steps in reducing the incidence of hospital-acquired infection. The steps to be remembered in an IV care, a simple IV care bundle will include compliance to hand hygiene, hand washing with all the steps followed rigorously, having an intravenous care set, an IV insertion kit which contains all the necessary devices, including a sterile surface below the hand or the leg, the limb of the patient, and following steps of skin asepsis, either using 2% chlorhexidine or using povidone iodine followed by alcohol. Choosing a more distal vein, preferably the upper limb more than the lower limb, and using a sterile flush solution and a semi-transparent dressing for fixation or for fixing the intravenous line. Similarly, when we look at the VAP bundle, which is a ventilator-associated pneumonia prevention bundle, one of the most important aspects is humidification. So having a heated humidifier is a must whenever we provide respiratory support, especially when we are using flows of greater than 1 liter per minute in newborn. So barring low flow nasal cannula, a heated humidifier is a must whenever we provide respiratory support, ensuring gases are delivered at 37 degrees Celsius and 100% relative humidity. Use distilled water in the humidifier. Always try to use the autofill technique rather than physically removing the ventilator tubings and refilling the humidifier, and ensure that there is no condensation in the inspiratory limb, and drain condensate which is present in the expiratory limb frequently to the water trap, and always consider condensate as a potential source of infection. Now, also other things to remember while we provide respiratory support is to remember that ventilatory circuits and oxygen therapy equipment should be readily available. Disposables must also always be readily available, and CPAP systems must never be allowed to remain standby for longer than 12 hours. So if we have stopped respiratory support for a baby, the tubing should be discarded after 12 hours and should not be allowed to remain standby for days together. Having resuscitation bags or ambu bags, which are kept bedside for all babies who are in respiratory support, and the circuit should be positioned parallel to the baby. So having sleeping endotracheal tubes rather than endotracheal tubes which are vertically oriented is again a very useful intervention to prevent that. Now, head end decubitus position, a lateral decubitus position is preferred, and 30-degree head end elevation is also found to reduce the risk of VAP, and very, very important to avoid the use of bulb suction while doing oral and nasal suction. Again, avoidance of acid blocking agents such as ranitidine and pantoprazole, which can kind of increase the gastric pH and found to be associated with a high risk of VAP is very important. And always try to start early enteral feeding with mother's own milk. So different studies have tried to evaluate the use of VAP bundles, and 2 large observational studies have found that the use of VAP bundles with a combination of all the evidence-based interventions we discussed was found to result in a reduction in the duration of mechanical ventilation as well as the length of stay. Moving on to the other important aspect of prevention of HAI, which is CLABSI bundle. We all know that central line associated bloodstream infections is a term used to denote lab confirmed bloodstream infections, which are found to begin when the central line is present or within 48 hours before the onset of infection. If a central line had been present, then we tend to call the bloodstream infection a CLABSI. Now, there are different routes of acquisition of CLABSI, and this underlies the different preventive strategies. And one of the most important things to remember that is the first week of life, as Dr. Deepa Hariharan was also mentioning, the presence of the microthrombi or fibrin sheath around the catheter is found to be one of the most important factors for infection, which is usually related to the skin commensals and due to the frequent movement of the catheter around the site of insertion. Whereas after the first week of central line usage, the contamination from the hub remains one of the most important routes of central line associated infection. Based on that, we have a combination of interventions for insertion as well as maintenance, and these are the key interventions in the central line insertion as well as the maintenance bundle. I should just like to re-emphasize on the importance of adequate skin antiseptic disinfection with 2% chlorhexidine in 70% alcohol, and to maintain a sterile field at the time of insertion. And when it comes to maintenance of central line, one of the most important steps is scrub the hub or cleaning the hub for at least 15 seconds with chlorhexidine solution. The EPIC guidelines actually recommends the use of transparent semi-permeable dressings over gauze for fixation of central lines, and these dressings could be changed once in 7 days or sooner if they are no longer intact or if there is moisture or blood collecting under the dressing. And when it comes to routine intravenous line changes, it is found that when we give just TPN or dextrose solution, the PMO lines may be allowed to remain for even up to 96 hours. But while we are dealing with lipid or blood products, the PMO lines have to be changed earlier. We have already discussed about scrubbing the hub, which is one of the most important steps in preventing CLABSI. And the combination of different interventions is found to result in a 60% reduction in the risk of central line associated bloodstream infection. Moving on to the other steps in preventing cross infections, one of the important steps is having an adequate sized sink, having a laminar flow for the preparation of TPN, and having separate refrigerators for the storage of mother's milk as well as various drugs. Now, a lot has been discussed about the use of gowns and routine masks for healthcare providers, which gained a lot of importance, especially during the recent COVID pandemic. But when you look at evidence from 8 randomized controlled trials, routine gowning of healthcare providers or families does not translate into reduction of hospital-acquired infections. Despite this, the use of gowns and gloves should definitely be encouraged whenever there is an infant who is colonized with a resistant bug or when there is an outbreak. Now, the 8th important step is promotion of breastfeeding, which requires a culture of early initiation of breastfeeding and a culture of breast milk friendly NICUs, because it is well known that feeding mother's own milk or human milk is found to be associated with a lower incidence of infections as well as necrotizing enterocolitis, and also an improved neurodevelopmental outcome, especially when we are dealing with very low birth weight neonates. One of the other important steps is adequate water management, as we have already discussed with regard to the use of water in humidifier circuits. Never consider the condensate as sterile. Similarly, changing water within the bubble flow meters as well as the suction jars. The last but not the least important step in preventing infections or hospital-acquired infection outbreaks is disinfection or housekeeping routines. Various guidelines have been published about the different ways of cleaning or disinfection or sterilization, as well as the frequency of cleaning different devices in the NICU, starting from suction jars, oxygen tubings, surfaces in the NICU such as windows, doors, the various furniture, procedure and examination rooms, as well as the regularly used equipment such as warmers and ventilators, and strict compliance to disinfection routines is one of the most important steps in preventing the transmission and entry of organisms into neonates. Coming to the role of surveillance cultures, there is not much role or not much evidence in favor of routine or random microbiological surveillance cultures of air or environmental surfaces. So regularly sending swabs from the sinks or from water may not be of much help, but in the research setting or when there is a definite indication, such as when a recent change in the hospital infection protocols or processes has been performed, or if there has been a sterilization processes which has been recently performed, then there may be a role of sending culture or in the event of an outbreak. I shall end with an emphasis on the 10-point rule by ISAPS on antimicrobial stewardship. Point 1, always take including culture of CSF or urine whenever indicated, with antibiotics whenever possible, preferably a combination of penicillin and an aminoglycoside. Point 3, do never start treatment as a general rule with a third generation cephalosporin or with a carbapenem. There can be rare exceptions though to this rule. Point 4 is to have local and national antibiotic policy. Point 5, always trust the microbiological lab, rely on the blood culture results. So try to stop antibiotics whenever the baby is clinically well, provided cultures are negative, provided cultures have been sent before antibiotic initiation. Point 6, do not believe abnormal results of a non-specific test, such as raised CRP. Never treat a raised CRP, always treat the clinical symptoms, clinical signs in a baby. So never treat a well neonate just on the pretext of an elevated C-reactive protein. Point 7, if blood cultures are negative at 2 to 3 days, and if the newborn is clinically well, it is almost always usually safe and appropriate to stop antibiotics. And point 8, try not to use antibiotics for long periods. As far as possible, try to restrict the duration of antibiotics. Point 9 is to treat sepsis and not colonization. And point 10 is to always try our best to try to prevent nosocomial infection rather than treating infections. And this can be done by reinforcing infection control measures, particularly hand washing. So with that, I thank you all for the opportunity and for the time, and we'll be glad to take questions if any.
Do we have any questions from the audience? No questions, ma'am. Thank you so much for gracing us with your presence, and that was a wonderful talk. Now, moving on, we have our next talk, which is upper airway problems in neonates, and that is being chaired by Dr. PMC Nair. He's MD, DCH, DNB, FIMSc, FRCP, DM Neonatology, PGI Chandigarh, Fellowship in Neonatal Intensive Care, Sydney, Australia. His current position is Professor at South Government Medical College in Trivandrum. He was the HOD Pediatrics and Neonatology at Sri Gokul Medical College, Trivandrum, Kerala. He's a National Faculty in Neonatal Resuscitation Program, DNP Inspector and Examiner of MD, DCH and DM. He has more than 100 publications in national and international journals. We welcome you, sir. It's a privilege to have you with us. Are you there, sir?
Yeah, thank you. Very good afternoon to all of you. And from infections, we are going directly to upper airway problems. Is actually usually upper airway problems present as an emergency, and not only the clinical acumen of the neonatologist to diagnose it, there should be a keen ENT surgeon or a laryngologist who is well versed in neonatal upper airway problems. In Trivandrum, we have the opportunity, luck to have a wonderful laryngologist, Dr. Jayakumar, and he does a lot of procedures to speak to us on this very important issue. We have a really expert person in the field, Dr. E.V. Raman. Dr. Raman is the convener of the Children's Airway and Swallowing Center at Manipal Hospital. He is the chairman of the Pediatric Otolaryngology Subcommittee of the Indian Academy of Otolaryngology and Head and Neck Surgery. He is the mentor, Pediatric Otolaryngology Fellowship at Manipal University. And also he has been awarded the Teacher of Excellence, the prestigious Teacher of Excellence Award by National Board of Examinations. So with this introductory words, I welcome Dr. E.V. Raman. Sir, yours.
Heart break.
Dr. Raman. We can see your slide.
So we can see your slides, but we can't hear you. Are you there with us?
Yeah, I think I unmuted myself now.
Yeah, now you can hear it.
Right. Good afternoon, good evening to all the people who are attending this conference. And my thanks to the National Neonatology Group for allowing me to speak today. And every time I come here, I learn something new. So it's been an educational experience for me. And every year, we've been in this business for about roughly 20 years. And every year I meet you, we've come with something new and we've learned something new. So thank you very much once again. So what we're going to give you is a panoramic view of the upper airway problems in neonates, especially the newer frontiers which we have reached in the recent past. Now, what are the objectives? We need to understand basically the airway concerns. We also need to differentiate between stridor and stertor, and also understand the laryngeal subsites where these lesions occur. Some of them are common, some of them are rare, and some of them we miss even though we may have taken care of neonates for a while. And it involves two different disciplines, neonatology and laryngology. So we need to establish good communication amongst each other. Now, we also need to understand what are the clinical manifestations which lead us to the diagnosis, what is the evaluation and what are the investigations that we will do, and what are the various laryngeal lesions that we see in neonates. Now, the concept should be the aerodigestive tract, because airway and swallowing both have to go hand in hand, and you have to assess not only the airway, but also the assessment of the voice is important, and we have to assessment of swallowing. And if you can do all that in the same way for the upper airway and upper GI tract, it will be good. And over a period of time, otolaryngologists interested in this subspecialty are getting more and more insights into these things, and close collaboration with neonatologists has educated us. Now, what are the concerns? Again, going through, we have stridor, which could be snoring, whether it is stridor which is inspiratory or expiratory or biphasic, regarding the respiration part. And regarding the voice part, whether it's muffled, hoarse, or breathy, or normal. And as far as the site is concerned, remember that the upper airway starts from the nose onwards and goes down to the trachea, till the carina at least. And then we have the feeding issues, whether the child has got difficult feeding, drooling, or whether the feeding is normal. And retractions can be normal. There can be no retractions, or they could be suprasternal, intercostal, or substernal or subcostal retractions. And the overall appearance of the child is a good indicator of what we are dealing with. It is a multidisciplinary team approach: neonatologists, pediatric ENT specialists, anesthetists, pediatric gastroenterologists, pediatric pulmonologists, pediatric surgeons, speech and swallowing therapists, and various support staff. Now, what are these various definitions and anatomic divisions? Stertor is basically snoring, where sound emanates from the nasal of the pharyngeal airway. Stridor usually comes from the upper airway, supraglottis, glottis, subglottis, and the trachea. Wheezing is usually the lower airway related issue. So you must try to find out whether you're hearing a stertor, or whether you're hearing inspiratory stridor, or biphasic stridor, or expiratory stridor. Now, in this particular case, you can see, I hope the sound is audible. So this is a stertorous sound and not much of retractions. So next you hear, you have to see whether what kind of sound is this. For example, this is an inspiratory stridor. So you need to differentiate between the three.
So the sound is not audible.
Oh, sorry about that. I don't know whether I can fix it. Let's move on, sake of time, to types of laryngeal, types of stridor and possible site of obstruction. You have inspiratory stridor till this region. Pharynx, supraglottis, and is inspiratory stridor. And what are the causes usually in this region is laryngomalacia, one of the commonest causes of upper airway problems encountered in neonates, laryngocele, stenosis, vascular malformations, and neck mass. Now, when you come to the glottis, this area, it could be subglottis and cervical trachea. It's a biphasic stridor. And what do we have here? We have vocal cord paralysis, intubation injuries, laryngeal clefts, glottic webs, stenosis, laryngeal trauma, and fracture. Then below this particular area, you have expiratory stridor. And going back to subglottis, very common region from where the stridor occurs, you can have croup, you can have intubation granulation of granuloma, acquired stenosis, hemangioma, cysts, congenital cricoid malformation, and foreign bodies. Now, how do you evaluate? I'm sure you're very aware of these. Just for the sake of revision, I'll go through this. Initiation of symptoms, it tells us when the symptoms started. Was it immediately after birth, 1 or 2 weeks after birth? Usually laryngomalacia gets manifest after 1 or 2 weeks after birth. The other obstructive symptoms may be immediately. And for example, congenital subglottic hemangiomas, it becomes manifest more around 4 to 8 weeks of life. The duration of symptoms, the episodes, which are asymptomatic in between, and whether it's episodic versus continuous, whether it's worsening, steady, or improved, weight loss, failure to thrive, associated feeding difficulties, intubation history, prior surgeries, neurological conditions, and whether it's part of some kind of syndromes. Now, difficult airway could be also due to craniofacial defects, which some of them will be obvious, and sometimes all these things can be taken care of with HFNC, or you have CPAP non-invasive methods sometimes lead to much better outcomes with too much of intervention. So our intervention could be intubation. Then if intubation is not possible, or you need to define where exactly the problem is, you need to go ahead for endoscopy. And sometimes, although we would love to avoid it, you can go into tracheostomies also. So our treatment management will be from non-invasive to invasive, initially nasal prongs, HFNC, intubation, and ultimately, if required, a tracheostomy. Now you have to identify the problem in a difficult airway, and identification of the problem is seeing is believing, and flexible fiber optic nasopharyngeal laryngoscopy is an ideal method of seeing, and it doesn't require any anesthesia, just local lignocaine jelly is good enough, and the child is restrained, and you have a look at the airway right from the nose till at least up to the carina and beyond if that is required. And what are the indications for flexible fiber optic nasopharyngeal laryngoscopy? As a neonatologist, when would you ask for it? Or when would the doctor decide to do that? One is severe stridor. When the stridor is progressive, stridor associated with unusual features like cyanotic attacks, apneic attacks, dysphagia, aspiration, failure to thrive, or if there's a radiological abnormality. And finally, stridor causing undue parental anxiety. There are parents who come to us that they're not able to sleep because all night the child is having noisy breathing. So sometimes you'll have to do that also. So let us look for a cause. What are the things? You start off right from the nose, where there could be a choanal atresia. Bilateral choanal atresia, relatively rare, and if you can't pass a 6 French catheter through the nose, most likely the child is having a problem, especially if it's bilateral bony choanal atresia. The child also can go into cyanosis cyclically. Feeding might be difficult, and so oral airway can help sometimes, but then bilateral choanal atresia, you may have to canalize it. And nasopharyngeal masses, though rare, are also present. They obstruct the airway. You can have sublingual mucocele, and you can have valvular cysts. You can have laryngomalicias. You can have a bifid epiglottis as part of the Pallister-Hall syndrome. You can have laryngeal hamartomas. So these are the various types of lesions that can be there at various subsites. Then there could be extreme problems like non-canalization of the larynx. As you can see, both the vocal cords are here. And there's a very small opening here, and this child was breathing through a tracheoesophageal fistula. Till the time the tracheostomy was done, the child was kept alive. And this is a much milder case where only a laryngeal web is there. This we can manage conservatively most of the time. Then you can have vocal cord palsies and laryngeal hemangiomas and subglottic stenosis. As you can see, they're graded from 1 to 4. And grade 1, sometimes you may not diagnose immediately. And this child may come to you with history of multiple groups history. And any group below 2 years, multiple times, hospital admissions with respiratory difficulties, is worthwhile looking at this. And that's the laryngeal cleft here. And this is a misdiagnosis most of the time. And unless you do a rigid scopy under anesthesia, separate both the clefts and see how deep it is, you won't be able to make out. This is tracheomalacia with the crescentic opening here. And you can also have a full-blown tracheal stenosis, which requires a slight tracheoplasty. So simple to complex. But now we've started using ultrasound in the pediatric airway. This is the point of care ultrasound, which we use. And you can see here is a case of a laryngomalacia. And this is a good way of screening these patients to find out also to see what type of, whether the tube fit is also fine or not. Otherwise, sometimes we use a larger tube, especially in a preterm baby, so you can check out on those things. And you can see the classical signs of severe laryngomalacia in this particular case. And this is another important thing I want to tell you. There are two important things. One is in the previous slide, which I missed, was hemangioma, subglottic hemangioma. Earlier, we used to use lasers, but now propranolol, which is given, kind of makes the hemangioma shrink. So we don't do big surgeries. And this propranolol is given over a period of time and shrinks in most of these cases. Now, the other advancement, so to say, is that whenever you feel that there's a neonatal tracheostomy needed, you can avoid that by doing a single stage widening of the air passage. Here we have this child, just to show you the size, the position, and here we are giving an incision here, horizontal incision. But instead of doing a tracheostomy, what you do is you do what is called as a split. You slit the thyroid cartilage below the vocal cords, slit the cricoid cartilage, slit the first two tracheal rings, and you've got a wide space here. The child is intubated with a slightly larger size endotracheal tube, which acts as a stent. And at this particular case, the real advancement has come because you take out a little bit of ala of the thyroid cartilage, put it here as a distractor. So this way we can avoid the tracheostomy, because tracheostomy is drains the resources, not only financial, but otherwise mental resources of the parents to take care in a child who is such a small baby. So that is the anterior cricoid split, which I described. Here you can see that, and here is the split which is given. And here you have a small thyroid ala cartilage which has been pushed here, and this is the diagrammatic representation. So what you're doing is you're widening the area. Most of the time the block is in the cricoid area, and that is, it is helping from that point of view. Now, of course, the other revolutionary procedure in the last so many years is the extrautero intrapartum treatment, which is an extension of the classical cesarean section. The baby is partially delivered, but remains attached by its umbilical cord to the placenta. I did show you a picture of a non-canalization of the larynx. In case the child had been prenatally diagnosed, we could have probably done that procedure. But at that particular point in time, that was almost 18 years back, we were not equipped for an exit procedure. But since then, we've done about 8 exit procedures for various upper respiratory issues. So this is the exit procedure for a child with cystic hygroma, as you can see here. And the child is partially delivered, and then you can either use a video laryngoscope, bronchoscope, or do a tracheostomy, depending on what's required. And all the subspecialties are around, and immediately an alternate airway is established, and then the umbilical cord is cut. Now, what are the problems we've managed since 1996 to 21? We have arrhythmias. We have congenital nasal pyriform aperture stenosis, which is the anterior correlate of the choanal atresia in the anterior part. And not all children require surgery, but some of them require surgery sublabial approach. Nasal gliomas, nasal fibromas, corneal atresias, which I showed you, laryngeal cysts at various subsides. Laryngomalacia, of course, is the maximum. And we have vocal cord paralysis and complete tracheal rings. We have laryngeal wedge, non-canalization of the larynx, laryngotracheoesophageal clefts, laryngotracheal stenosis, tracheomalicias, tracheal compression due to vascular rings. And this is out of place. This is not in this age group. Sorry for that. And cystic hygromas. So to conclude, the neonatal airway, when it's difficult, ask for a multidisciplinary team approach. You need to evaluate both the, see whether the child has got synchronous lesions. It's not always that you identify a lesion and that is the cause of the problem. Almost 20 to 50% of these children may have an additional airway problem. If they are part of a syndromic situation, they could have multiple problems. And as I said, again, seeing is believing. Identify the problem early. Keep your anesthesia and ENT team informed about the case. Airway adjuncts, that is to develop the skill to use appropriately to do that, and associate with your OBGY colleagues to plan exit procedure if needed, if the diagnosis has been made antenatally. And remember, most important is all stridor is not laryngomalacia. Very, very important. And if you, this particular child is about, I think, 9 or 10 years old. He's about 14 years old now. This was when he was 9 years old. And because of the good management of the child being identified at birth with congenital subglottic stenosis, and the same thing using an anterior cricoid split and widening the airway, what we want to give is should be able to swallow, child should be able to breathe. I hope you can hear now. This child is singing Hindustani classical music. So this is the kind of outcome we want. We want a good voice. We want good swallowing capabilities, and the child should be able to swallow, breathe, and have a good voice. This is my thanks to my pediatrician, neonatologist, anesthesiologist colleagues of Manipal Hospital, Bangalore, and very importantly to the Neonatology Foundation for giving me this opportunity to talk today. Thank you so much.
Thank you, Dr. Raman, for that wonderful presentation. And if you can know that the person who is doing it, if he's presenting, we can know how it is. So it's direct from the horse's mouth. So like if there are any postgraduate or undergraduate there, one important point I'd like to, from the clinicians or the neonatologist point of view, you should have a clinical acumen to make a diagnosis, especially if you see a upper suprasternal retraction and or stridor in a newborn. Always think of upper airway obstruction unless otherwise proved. We had so many cases like that presenting that even the cardiologist said is pulmonary hypertension, but ultimately proved to be like arterial ursoria. We had an abnormal right subclavian artery surrounding the trachea with the ductus forming a compression causing severe retractions. So many cases which can easily save if they, now we have a lot of facility. I'm speaking about 40 years or 30 years back when we didn't have much opportunities. Anyway, the ENT specialist close association is very important. And we are lucky in that way in Trivandrum because Dr. Jayakumar is there, always ready to help us. Thank you very much. Any questions from the audience?
Any questions from the audience? No questions, sir.
So we're keeping correct to the time. It's great, no?
Thank you so much, sir. And thank you, E.V. Raman, sir, for joining us. That was a perfect end to our conference. Indeed, seeing is believing, and your presentation was full of pictures and videos, which made it so easy for us to understand what you were talking about. Thank you so much for joining us and gracing us with your presence.
Thank you so much.
Thank you.
I just need to say that we are starting a 1-week small upper airway familiarization course for neonatologists. Spend 2-3 days with us and we'll show all recorded videos of what we've done and case discussions. So we'll probably publicize it because we find a lot of neonatologists eager to understand upper airway to the maximum extent possible. Thank you so much. And our center does all these surgeries free of cost.
Oh, very good, very good.
For the last 20 years, we have public funding and always welcome to take care of them.
Good.
That is wonderful. Thank you so much for joining us. And with that, we come to an end to our conference. Thank you so much for all of you to be a part of this conference the last 4 days. I hope everyone learned something new. Thank you to everyone who's present here physically and virtually. We thank you so much for your attention. And with that, we end the conference. Thank you so much. The valedictory function will be at 6 o'clock, 5:30 actually, 5:30 p.m. in Hall A. Thank you.
ಅಲ್ಲ ಅದು ಕ್ಯಾಮ್ರಾ ಆಫ್ ಮಾಡು ಇಲ್ಲ ಬಿಡಿ ಅದು ಬೇರೆ ಬಿಟ್ಟಿರುತ್ತೆ ರಿಮೂವ್ ಮಾಡ್ಬಿಡ್ಬೋದು ಚಲಕ್ಕೆಲ್ಲ ಲೇಟ್ ಆಗೋಗ್ತದೆ ಸರ್ 6:30 6:30 ಆಗೋಗುತ್ತೆ 7:30 ಆಗುತ್ತೆ ಅಯ್ಯೋ ಬೇರೆ ಒಂದು ಅದಿಲ್ಲದೆ ಹೋಗಿದ್ರೆ ಹೆಂಗ ಅದು ಇದ್ದೇ ಇರುತ್ತೆ ಆ ಕಡೆ ಎಲ್ಲ ಜಾರಿ ಬರುತ್ತೆ ಯಾರಿಗಾದ್ರೂ ಒಬ್ಬರು ಬೀಳುತ್ತಿಲ್ಲ ರಿಮೂವ್ ಮಾಡೋಕ್ಕೆ ಲೇಟ್ ಅವ್ರದೆಲ್ಲ ಬೇಗ ಏನ್ ಹೇಳಿ
ಅದು ಚಾರ್ಜ್ ನಿಮ್ದಲ್ಲ
ಇದೆಲ್ಲ ನಮ್ದು
ಎಸ್
ಏನು ಇನಾಗ್ರೇಷನ್ ನೋ
ಅದು
1 hour ಇರುತ್ತಾ ಏನಣ್ಣ ಮಾಡೋದಕ್ಕ ಬೇಕಾಗ್ತಲ್ಲ ಎಲ್ಲ ರಿಂಗ್ ಆಗ್ತಾ ಇದೆ.
ನನಗೆ ಮುಖ ತೋರ್ಸಲ್ಲ. ಪ್ರೀತಿ ಮಾಡೋದೇ ಆಗ್ಲಿ ದ್ವೇಷ ಮಾಡೋದೇ ಆಗ್ಲಿ ಎರಡರಲ್ಲೂ
ನನ್ಗೆ ಏನ್ ಮಾಡಿದ್ದೆ ಇದು
ಹೋಲಿಸ್ತೀನಿ ನನ್ನನ್ನು. ಫ್ರೆಂಡ್ಸ್, ಇದೆಂತ ಗೊತ್ತುಂಟಾ, ಇದು ಕುದಾನೆ ಅಂತ ಹೇಳುದು, ಕುದಾನೆ ಅಥವಾ ಕುದಾನೆ ಹಾಗೆಲ್ಲ ಹೇಳ್ತೇವೆ. ಇದು ಬದನೆಯ ತಮ್ಮ ಅಂತ ಹೇಳ್ಬೋದು ಇದನ್ನು. ಬದನೆ ಹಾಗೆ ಉಂಟು, ಸಣ್ಣ ಸೈಜಲ್ಲಿ ಇಷ್ಟು ಸಣ್ಣ ಇರುತ್ತೆ. ಮತ್ತೆ ಇದರ ಎಲೆ ನೋಡಿ, ಎಲೆ ಕೂಡ ಬದನೆಯ ರೀತಿಯಲ್ಲಿ ಉಂಟು. ಮತ್ತೆ ಇದರ ಹೂ ಕೂಡ ನಿಮಗೆ ಇಲ್ಲಿ ಕಾಣ್ಬೋದು, ಬಿಳಿ ಹೂ ನೋಡಿ ಈ ರೀತಿಯಾಗಿ. ಈಗ ನೋಡಿ, ನಿಮಗೆ ಕುದನೆಲ್ಲ ಇಲ್ಲಿ ಸ್ವಲ್ಪ ಉಂಟು. ಇದನ್ನ ಇವತ್ತು ಕೊಯ್ದೊಂದು ಗೊಜ್ಜೆ ಮಾಡ್ತಾ ಇದ್ದೇನೆ. ಆಗಿ ಗೊಜ್ಜೆ ಮಾಡುವಂತದ್ದು, ತುಂಬಾ ಕೆಲಸ ಎಲ್ಲ ಏನಿಲ್ಲ ಇದಕ್ಕೆ ಮಾಡ್ಲಿಕ್ಕೆ ಕೂಡ. ಹೇಗೆ ಮಾಡುದು ಅಂತ ಹೇಳಿ ಇವತ್ತು ನೋಡೋದು, ಕೊಯ್ಯುವ. ಮತ್ತೆಂತ ವಿಷಯ ಅಂತ ಹೇಳಿದ್ರೆ, ಈ ಇದರ ಗಿಡ ಉಂಟು, ಇದು ಲೋಕಲ್ ಅಂದ್ರೆ ಕಾಡಿನ ಗಿಡ ಅಂತಲೇ ಹೇಳ್ಬೋದು. ಅಂದ್ರೆ ಕಾಡಲ್ಲಿ ಆಗುದಲ್ಲ, ಅಂದ್ರೆ ಅದರಷ್ಟಕ್ಕೆ ಆಗುವಂತದ್ದು, ಹಳ್ಳಿಗಳಲ್ಲೆಲ್ಲ ಆಗ್ತದೆ ಸಾಮಾನ್ಯವಾಗಿ. ಮತ್ತೆ ಬದನೆ ಉಂಟಲ್ಲ, ನಾವು ಬದನೆಯ ಗಿಡವನ್ನು ಅದರ ಗೆಲ್ಲನ್ನು ತುಂಡು ಮಾಡಿ ಗ್ರಾಫ್ಟಿಂಗ್ ಎಲ್ಲ ಮಾಡ್ತೇವಲ್ಲ, ಅದೇ ರೀತಿ ಇದರ ಗೆಲ್ಲಿಗೆ ಗ್ರಾಫ್ಟಿಂಗ್ ಮಾಡಿದ್ರೆ ಉಂಟಲ್ಲ, ಇದರಲ್ಲಿ ಬದನೆ ಆಗ್ತದೆ, ಹಾಗೆ ಸಿಗ್ತದೆ. ಮತ್ತೊಂದು ವಿಷಯ ಇದರಲ್ಲಿ ರೋಗ ಎಲ್ಲ ಕಡಿಮೆ, ಕಾಡು ಗಿಡ ಅಂತ ಆ ರೀತಿ ಆಗುವ ಕಾರಣ ರೋಗ ಎಲ್ಲ ಬಾಧಿಸುದು ಕಡಿಮೆ. ಈಗ ಇಲ್ಲಿ ಕಾಣ್ತಾ ಉಂಟಲ್ಲ ನಿಮಗೆ ಇಲ್ಲಿ ಕುದಾನೆ, ಇದೆಲ್ಲ ಈಗ ಕೊಯ್ಯುವ ರೀತಿಯಲ್ಲಿ ಉಂಟು. ಜಾಸ್ತಿ ಬೆಳಿಲಿಲ್ಲ ಈಗ. ಇದು ಜಾಸ್ತಿ ಬೆಳೆದ್ರೆ ಎಂತ ಆಗ್ತದೆ ಅಂತ ಹೇಳಿದ್ರೆ, ಅದರ ಬೀಜ ನಾವು ಗೊಜ್ಜು ಮಾಡೋದ್ರ ಬೀಜ ಎಲ್ಲ ನಮಗೆ ಅದು ಗಟ್ಟಿಯಾಗಿರ್ತದೆ, ಬೆಳೆದಿರ್ತದೆ, ಅದು ಗಜ ಗಜ ಅಂತ ಹೇಳಿ ಸಿಗ್ತದೆ. ಈಗ ಇದು ಕೊಯ್ಯುವ ರೀತಿಯಲ್ಲಿ ಉಂಟು. ಇದನ್ನೆಲ್ಲ ಈಗ ನಾವು ಕೊಯ್ಯುವ, ಮತ್ತೆ ಇದರಿಂದ ಗೊಜ್ಜು ಮಾಡುವ. ಕೊಯ್ತಾ ಇದ್ದೇನೆ ಇದನ್ನ. ಈಗ ನೋಡಿ, ಇದರಲ್ಲಿ ಇದೀಗ ಗೊಂಚಲು ಉಂಟಲ್ಲ, ಹೀಗೆ ಗೊಂಚಲಾಗಿ ಕೊಯ್ದು ಚಂದ್ರದಲ್ಲ ನಿಮ್ಮ ಡಾಕ್ಟರ್ ಮಾತು ಕೇಳಿ, ಯಾಕೆಂದ್ರೆ ಅಸ್ತಮಾಕ್ಕೆ ನೋಡಿ, ಇದರ ತೊಟ್ಟನ್ನೆಲ್ಲ ತೆಗಿತಾ ಇದ್ದೇನೆ. ತುಪ್ಪದ ಮೇಲೆ ಮತ್ತೆ ತೊಳಿವ, ಈ ರೀತಿಯಾಗಿ ಮಾಡಿಕೊಳ್ಬೇಕು. ಬಿಡಿಸಿಕೊಂಡ್ರೆ ಆಯ್ತು, ಈಗ ಹೇಳ್ತಾರೆ ಬರ್ತದಲ್ಲ. ಬಿಡಿಸಿಟ್ಟಂತ ಉದಾಹರಣೆ ಉಂಟಲ್ಲ, ಈಗ ತೊಳಿವ, ಸರಿಯಾಗಿ ತೊಳಿಕೊಂಡು ಈಗ ಸರಿಯಾಗಿ ತೊಳೆದು ಅದಷ್ಟು ನೀರನ್ನು ಸೋಸಿ ತೆಗೆದು ಒಂದು ಬಟ್ಟೆಗೆ ಇಟ್ಟಿದ್ದೇನೆ, ಬಟ್ಟೆಗೆ ಹಾಕಿಬಿಡ್ತೇನೆ. ಈಗ ಪುನಃ ಹುರಿಲಿಕ್ಕೆ ಉಂಟಿದ್ದಾನೆ, ತುಪ್ಪ ಹಾಕಿ ಹುರಿ ಹಾಗಾಗಿ ಕಸ ಎಲ್ಲ ಹೋಗಿ ತೆಗೆದುಕೊಂಡು ಒಂದು ಬಟ್ಟೆಗೆ ಹಾಕಿದ್ದೇನೆ.
ಇಲ್ಲ ತಿರ್ಗಾ ಇದೆ
ನೋಡಿ, ಒಲೆಯಲ್ಲೊಂದು ಬಣಲೆ
ಇಲ್ಲ ಅದು ವ್ಯಾಲೆಂಟಿಟಿ ಅಂದ್ಬಿಟ್ಟು ಎಲ್ಲರೂ ಮಾಡಿದವರಿಗೆಲ್ಲ ಅವಾರ್ಡ್ ಕೊಡ್ತಾರಲ್ಲ.
ಮಣ್ಣಲ್ಲಿ ಒಂದು
ಅದು
4 ಚಮಚದಷ್ಟು ತುಪ್ಪ ಹಾಕಿ ಬಿಡ್ತಾ ಇದ್ದೇನೆ.
7 ಗಂಟೆ ಆಗುತ್ತೆ.
ನೋಡಿ ನಿಮಗೆ ಕುದನೆ ಉಂಟಲ್ಲ ಬಟ್ಟೆಯಲ್ಲಿ ಹಾಕಿಟ್ಟದ್ದು ಅದನ್ನ ಅದಕ್ಕೆ ಹಾಕಿ ಬಿಡ್ತಾ ಇದ್ದೇನೆ.
ಏನು ಬಟನ್
ಚೆನ್ನಾಗಿ ಕುದಿಕೊಳ್ಬೇಕು. ಕುದನೆ ಒಂದು 60-70 ಇರ್ಬೋದು.
ಹೌದು.
ಸಣ್ಣ ವ್ಯಕ್ತಿಯಲ್ಲಿ ಇಟ್ಟುಕೊಂಡು ನಾವು ಮಾಮೂಲಿ ದ್ರಾಕ್ಷಿ ಎಲ್ಲ ಹುರಿತೇವಲ್ಲ ಒಣ ದ್ರಾಕ್ಷಿ ಅದರ ರೀತಿಯಲ್ಲಿ ಇದನ್ನು ಕೂಡ ಹುರಿದುಕೊಳ್ಳಿ. ಇದು ಮಾತ್ರ ಸ್ವಲ್ಪ ಹಸಿರೋದಲ್ಲ, ಜಾಸ್ತಿ ಹುರಿಬೇಕಾಗ್ತದೆ, ಒತ್ತು ಜಾಸ್ತಿ ಬೇಕಾಗ್ತದೆ. ನೋಡಿ ಇದು ಹಾಗೆ ಬಣ್ಣ ಕೂಡ ಬದಲಾಗ್ತಾ ಉಂಟು, ಅದೇ ಮೇಲೆ ಕಾಣ್ಬೋದು. ಇದರ ನೀರಿನ ಹಸೆ ಉಂಟಲ್ಲ ಅದು ಕೂಡ ಸ್ವಲ್ಪ ಆರ್ತದೆ. ಈ ಕುದನೆ ಉಂಟಲ್ಲ ಹಸಿರು ಆಗ್ತದೆ ಕುದ್ದಿ ಮತ್ತೆ ಈ ರೀತಿಯಾಗಿ ಹುರಿದು ಮಾಡ್ತಾರೆ ಕೆಲವು ಜನ. ಆ ರೀತಿಯಾಗಿ ಮಾಡಿದ್ರೆ ಎಂತ ಸಮಸ್ಯೆ ಅಂತ ಹೇಳಿದ್ರೆ ಇದರ ಬೀಜ ಉಂಟಲ್ಲ ಬೀಜ ಎಲ್ಲ ಹೊರಗೆ ಬಂತು. ಈ ರೀತಿಯಾಗಿ ಹುರಿಯುವಾಗ ಕಪ್ಪಾಗಿ ಬಿಡ್ತದೆ. ನಾವು ಇಡಿಯಾಗಿ ಈ ರೀತಿಯಾಗಿ ಹುರಿದು ಮತ್ತೆ ಹುರಿದುಕೊಳ್ತೇವೆ. ಆ ರೀತಿಯಾಗಿ ಮಾಡಿದ್ರೆ ಬೀಜ ಕಪ್ಪಾಗುವಂತ ಸಾಧ್ಯತೆ ಇಲ್ಲ. ನೋಡಿ ಈಗ ನಾನು 4-5 ನಿಮಿಷ ಹುರುತ್ತೇನೆ. ನೋಡಿ ಈಗ ಬಣ್ಣ ಕೂಡ ಬದಲಾಯ್ತು, ಸ್ವಲ್ಪ ಕಲರ್ ಕೂಡ ಬಿಳಿಯಾಗಿ ಬಂದಿದೆ. ಇನ್ನೀಗೊಂದು 4-5 ಗಾಂಧಾರಿ ಕೂಡ ತಗೊಂಡಿದ್ದೆ, ಅದನ್ನು ಕೂಡ ಇದಕ್ಕೆ ಹಾಕಿ ಹುರಿದುಕೊಳ್ಳುವ, ಮತ್ತೆ ಇದನ್ನು ಇಳಿಸಿಕೊಳ್ಳುವ. ನೋಡಿ ಇದು ಹುರಿದಾಗುವಾಗ ಒಂದು ಸಿಡಿತದೆ, ಜಾಸ್ತಿ ಹುರಿಯೋದು ಬೇಡ. ಇನ್ನೀಗ ನಾನು ಇದನ್ನು ತೆಗಿತಾ ಇದ್ದೇನೆ. ನೋಡಿ ಇದರಲ್ಲಿ ನನಗೆ ಸಿಡಿಲಿಕ್ಕೆ ಶುರುವಾಯ್ತು. ತೆಗಿತಾ ಇದ್ದೇನೆ ಪಾತ್ರೆಗೆ
चला गया सर. नहीं वैलिडिटी पर
ಈಗ ಇದೊಂದು 2 ನಿಮಿಷ ತಣಿಯಿತು ಈ ಕುದನೆ ಎಲ್ಲ ಗಾಂಧಾರಿ ಮೆಣಸು ಈಗ ನಾನು ನೋಡಿ ಸೌಟಿನಲ್ಲಿ ನಮಗೆ ಹೀಗೆ ಜಜ್ಜಿಲಿಕ್ಕೆ ಆಗ್ತದೆ. ಸ್ವಲ್ಪ ಈ ರೀತಿಯಾಗಿ ಜಜ್ಜಿಕೊಳ್ಳ ಮಾಡಿ ಅಲ್ಲಿಗೆ ಜಜ್ಜಿಕೊಂಡ್ರೆ ಅಂದ್ರೆ ಅದು ಹುರಿದಾಗುವಾಗ ಒಳ್ಳೆ ಸ್ಮೂತ್ ಆಗಿರುತ್ತದೆ. ಹೀಗೆ ಸೌಟಿನಲ್ಲಿ ಜಜ್ಜಿದ್ರೆ ಸಾಕು. ಇಲ್ಲದಿದ್ರೆ ಕುಟ್ಟುಕಲ್ಲು ಅಥವಾ ಎಂತಾದ್ರೂ ಕತ್ತಿ ಅದರ ಕಡೆಯಲ್ಲಿ ಯಾವ್ದಲ್ಲಿ ಬೇಕಾದ್ರೂ ಹೀಗೆ ಜಜ್ಜಿಕೊಳ್ಬಹುದು. ಅದು ಒಂದು ಕಪ್ ಎಂತಾದ್ರೂ ಇಟ್ಟದ್ರೆ ಹಿಂದಿನ ಭಾಗದಲ್ಲಿ ಗ್ಲಾಸಿನ ಹೇಗೆ ಬೇಕಾದ್ರೂ ಜಜ್ಜಿಕೊಳ್ಬಹುದು. ನಾನೀಗ ಸೌಟಿನಲ್ಲಿ ಈ ರೀತಿಯಾಗಿ ಮಾಡಿ ನೋಡಿ. ನಮಗೆ ಗೊಜ್ಜು ಮಾಡ್ಲಿಕ್ಕೆ ಮೊದಲಿಗೆ ನಾವೊಂದು ಒಗ್ಗರಣೆ ಮಾಡ್ಬೇಕು. ಒಗ್ಗರಣೆ ಮಾಡ್ಲಿಕ್ಕೆ ನಾವು ನೀರುಳ್ಳಿ ಕೂಡ ಹಾಕ್ಲಿಕ್ಕೆ ಉಂಟು ಒಗ್ಗರಣೆಗೆ. ಹಾಗಾಗಿ ಇದರೀಗ ಉದನೆಯನ್ನು ಸ್ವಲ್ಪ ತುಪ್ಪ ಕೂಡ ಬಾಕಿ ಉಂಟು, 2 ಚಮಚ ತುಪ್ಪ ಉಂಟು. ಇನ್ನು ಕೂಡ 1 ಚಮಚ ತುಪ್ಪ ಹಾಕ್ತೇನೆ, 3-4 ಚಮಚ ಇರಲಿ ತುಪ್ಪ, ಯಾಕಂತ ಹೇಳಿದ್ರೆ ನೀರುಳ್ಳಿ ಹುರ್ಲಿಕ್ಕೆ ಉಂಟು. ಹಾಗಾಗಿ ನೋಡಿ ಮೊದಲಿಗೆ 1 ಚಮಚ ಸಾಸಿವೆ, ಒಟ್ಟಿಗೆ ಮೆಣಸು ಕೂಡ ಹಾಕಿ ಬಿಡ್ತಾ ಇದ್ದೇನೆ. 4-5 ತುಂಡು ಹಾಕಿ ಬಿಡುವ. 1 ಮೆಣಸು ತಗೊಂಡು 4-5 ತುಂಡು ಮಾಡಿ ಒಣ ಮೆಣಸಿನ ಊಟ ಮೆಣಸು ಸಾಸಿವೆ ಎಲ್ಲ ಸಿಡಿ ಒಂದು 4 ಗಂಟೆ ಬೇವು ಕೂಡ ಹಾಕಿ ಇದಕ್ಕೆ ಕೊಚ್ಚಿಟ್ಟ ಒಂದು ನೀರುಳ್ಳಿ ಅದನ್ನು ಕೂಡ ಸೇರಿಸ್ತೇನೆ. ಸ್ವಲ್ಪ ಇದನ್ನು ಕೂಡ ಹುರಿ. ಬೆಳ್ಳುಳ್ಳಿ ಹಾಕುವವರು ಈ ಹೊತ್ತಿನಲ್ಲೇ ಹಾಕಿಕೊಳ್ಬೇಕು. ಈಗ ನೀರುಳ್ಳಿ ಎಲ್ಲ ಚೆನ್ನಾಗಿ ಬಾಡಿತಲ್ಲ, ಈಗ ನಾನೊಂದು 2 ಗ್ಲಾಸ್ನಷ್ಟು ನೀರು ಹಾಕಿಕೊಳ್ತಾ ಇದ್ದೇನೆ. ಅದಕ್ಕೀಗ ರುಚಿಗೆ ಬೇಕಾದಷ್ಟು ಉಪ್ಪು ಹಾಕಿ ಬಿಡ್ತಾ ಇದ್ದೇನೆ. ಒಂದು ಸಣ್ಣ ತುಂಡು ಬೆಲ್ಲ ಕೂಡ ಹಾಕಿ ಬಿಡ್ತೇನೆ. ಹಾಗೆ ಒಂದು ಸ್ವಲ್ಪ ಮೆಣಸಿನ ಅಡಿ ಕೂಡ ಹಾಕಿ ಬಿಡ್ತಾ ಇದ್ದೇನೆ. ರುಚಿಗೆ ಬೇಕಾದಾಗಿ ಹೆಚ್ಚು ಕಡಿಮೆ ಬೇಕಾದ್ರೆ ಮಾಡಿಕೊಳ್ಬಹುದು. ಮತ್ತೆ ನಾವಿಲ್ಲಿ ಗಾಂಧಾರಿ ಮೆಣಸು ಕೂಡ 4-5 ತಗೊಂಡಿದ್ದೇನೆ. ಹಾಗಾಗಿ ಕಿವಿಚಿಟ್ಟಂತಹ ಹುಳಿ ನೀರು ಕೂಡ ಹಾಕಿ ಬಿಡ್ತೇನೆ. ಉಪ್ಪು ಹುಳಿ ಬೆಲ್ಲ ಎಲ್ಲ ಹಾಕಿದ ನೀರು ಉಂಟಲ್ಲ ಇನ್ನೀಗ ಸರಿಯಾಗಿ ಕುದಿದೆ. ಮತ್ತೆ ನಾವು ಈಗ ಜಜ್ಜಿಟ್ಟಂತಹ ಕುದನೆ ಉಂಟಲ್ಲ, ಹುರಿದಿಟ್ಟು ಜಜ್ಜಿಟ್ಟಂತಹ ಕುದನೆ ಅದನ್ನ ಇದಕ್ಕೆ ಹಾಕಿ ಸರಿಯಾಗಿ ಕುದಿಸಿಕೊಂಡ್ರೆ ಆಯ್ತು. ಸರಿಯಾಗಿ ಕುದಿಲಿಕ್ಕೆ ಸ್ಟಾರ್ಟ್ ಆಯ್ತು. ಈಗ ನೋಡಿ ನಾವು ಕುದಿಟ್ಟಂತಹ ಇದು ಉಂಟಲ್ಲ ಕುದನೆ ಅದನ್ನು ಹಾಕಿಕೊಳ್ತಾ ಇದ್ದೇನೆ. ಇದು ಹಾಕಿದ್ಮೇಲೆ ಸಹ ಒಂದು ಕುದಿ ಬಂದ್ರೆ ಸಾಕು. ಈಗಲೇ ಕುದಿತಾ ಉಂಟು. ಈಗ ಕುದನೆ ಹಾಕಿದ್ದೇವಲ್ಲ, ಕುದನೆ ಹಾಕಿದ್ಮೇಲೆ ಸರಿಯಾಗಿ ಕುದಿಲಿ. ಕುದನೆ ಕೂಡ ಉಪ್ಪು ಹುಳಿ ಬೆಲ್ಲ ಎಲ್ಲ ಸರಿಯಾಗಿ ಹಿಡಿಲಿ. ಮತ್ತೆ ಸರಿಯಾಗಿ ಕುದ್ಮೇಲೆ ಇದನ್ನು ಇಳಿಸಿದ್ರೆ ಆಯ್ತು. ಅದೇ ಪಾತ್ರೆ ಹಾಕಿಕೊಳ್ತಾ ಇದ್ದೇನೆ. ಬಿಸಿ ಕುದನೆ ಗೊತ್ತು ರೆಡಿ ಇದೆ. ಊಟಕ್ಕೆಲ್ಲ ಉಂಟಲ್ಲ ಈ ಕುದನೆ ಗೊಜ್ಜು ಭಾರಿ ಒಳ್ಳೆದಾಗ್ತದೆ. ಈ ಕುದನೆ ಗೊಜ್ಜನ್ನು ಬೇರೆ ಬೇರೆ ಕಡೆ ಬೇರೆ ಬೇರೆ ರೀತಿಯಲ್ಲಿ ಮಾಡ್ತಾರೆ. ಆದ್ರೆ ನಾವಿಲ್ಲಿ ನಮ್ಮ ಮನೆಯಲ್ಲಿ ಮಾಡುವ ರೀತಿಯನ್ನು ನಿಮಗೆ ನಾನು ತೋರಿಸಿಕೊಟ್ಟಿದ್ದೇನೆ. ಮತ್ತೆ ಈ ಕುದನೆಯನ್ನು ಕೂಡ ಒಳ್ಳೆ ಒಂದು ಆರೋಗ್ಯಕರ ಆಹಾರ ಅಂತ ಕೂಡ ಹೇಳ್ಬೋದು. ಯಾಕಂತ ಹೇಳಿದ್ರೆ ಇದರಲ್ಲಿ ತುಂಬಾ ಆರೋಗ್ಯಕರ ಅಂಶಗಳು ಕೂಡ ಉಂಟು. ಹಾಗೆ BP ಶುಗರ್ ಹೀಗಿರೋದೆಲ್ಲ ಒಳ್ಳೆ ಕಂಟ್ರೋಲ್ ಆಗ್ತದೆ ಅಂತ ಕೂಡ ತುಂಬಾ ಜನ ಹೇಳ್ತಾರೆ. ಹಾಗೆ ಈ ಗಿಡವನ್ನು ಸರಿಯಾಗಿ ಗಮನಿಸಿಕೊಂಡು ಉಂಟಲ್ಲ ನೀವು ಕೂಡ ಇದನ್ನ ಟ್ರೈ ಮಾಡಬಹುದು, ಆಯ್ತಾ? ಹಾಗೆ ಮುಂದಿನ ವಿಡಿಯೋದಲ್ಲಿ ಸಿಗ್ತೇನೆ. ಸೇರಿಸಿ ಅನ್ನದೊಟ್ಟಿಗೆ ಹುಳಿ ಮೆಣಸಿನ ಕೊದಿಲು. ನಮ್ಮಲ್ಲಿ ಈ ತೊಂಡೆಕಾಯಿಯನ್ನು ಇಡಿಯಾಗಿ ಗುತ್ತಿ ಹಾಕಿ ಒಂದು ಹುಳಿ ಮೆಣಸಿನ ಕೊದಿಲು ಅಂತ ಹೇಳಿ ಮಾಡ್ತಾರೆ. ಆ ಹುಳಿ ಮೆಣಸಿನ ಕೊದಿಲು ಉಂಟಲ್ಲ, ಈ ಊಟದೊಟ್ಟಿಗೆಲ್ಲ ಸೇರಿಸಿ ತಿನ್ಲಿಕ್ಕೆ ಒಂದು ಪ್ರತ್ಯೇಕವಾದ ರುಚಿ ಇರ್ತದೆ. ಇವತ್ತು ನಾನು ನಮ್ಮಲ್ಲಿ ಮಾಡುವಂತಹ ಸಿಂಪಲ್ ಆದಂತಹ ಒಂದು ಸಾಂಬಾರ್ನ ರೆಸಿಪಿಯೊಂದಿಗೆ ಬಂದಿದ್ದೇನೆ. ನಮ್ಮಲ್ಲಿ ತುಂಬಾ ಜನ ರಿಕ್ವೆಸ್ಟ್ ಕೂಡ ಮಾಡಿದ್ರಿ ಸಾಂಬಾರು ಮಾಡೋದು ಹೇಗೆ ಅಂತ ಹೇಳಿ ಹೇಳಿಕೊಡಿ ಅಂತ. ಹಾಗಾದ್ರೆ ಇವತ್ತಿನ ಈ ವಿಡಿಯೋದಲ್ಲಿ ಸಾಂಬಾರು ಮಾಡೋದು ಹೇಗೆ ಅಂತ ಹೇಳಿ ನೋಡುವ. ಹಾಯ್ ಫ್ರೆಂಡ್ಸ್, ನಾನು ಸುದರ್ಶನ್ ಭಟ್ ಮೆದಡಿ. ವೆಲ್ಕಮ್ ಬ್ಯಾಕ್ ಟು ಸಚಿನ್ ಭಟ್ ಚಾನೆಲ್. ಮೊದಲಿಗೆ ಸಾಂಬಾರಿಗೆ ಬೇಕಾಗುವ ತರಕಾರಿಯನ್ನು ಕೊಟ್ಟುಕೊಂಡು ನಾನಿಲ್ಲಿ ಕುಂಬಳಕಾಯಿಯನ್ನು ತಗೊಂಡೆ. ಈ ರೀತಿಯಾಗಿ ಕುದಿಸಿಕೊಳ್ಳುತ್ತೇನೆ. ಹೀಗೆ ಹೋಳುಗಳನ್ನು ಬೇಯಿಸುವಾಗ ಹೋಳುಗಳು ಮುಳುಗುವಷ್ಟು ನೀರು ಹಾಕಿ ಒಂದು ಕುದಿ ಬಂದ ಮೇಲೆ ಉಪ್ಪು ಮೆಣಸು ಹುಳಿ ಎಲ್ಲ ಹಾಕುವ. ನೋಡಿ, ಈಗ ಕುದಿ ಬಂತು. ಈಗ ಇದಕ್ಕೆ ರುಚಿಗೆ ಬೇಕಾದಷ್ಟು ಸ್ವಲ್ಪ ಮೆಣಸಿನ ಹುಡಿ, ಚಿಟಿಕೆ ಅರಸಿನ ಹುಡಿ, ಅಥವಾ ಸಣ್ಣ ತುಂಡು ಬೆಲ್ಲ ರುಚಿಗೆ, ಇನ್ನೊಂದಿಷ್ಟು ದೊಡ್ಡ ಹುಳಿಯನ್ನು ನೀರು ಹಾಕಿ ಕಿವುಚಿ ಹಾಕಿಕೊಳ್ಳುವುದು. ಕಿವುಚಿದಂತಹ ಹುಳಿ ನೀರು. ಇನ್ನೀಗ ಇದು ಬೇಯಿಲಿ. ನಾವೀಗ ಮಸಾಲೆ ಮಾಡೋದು ಹೇಗೆ ಹೇಳಿ ನೋಡುವ. ಈಗ ಮಸಾಲೆ ಹುರಿಲಿಕ್ಕೆ 3 ಚಮಚ ತೆಂಗಿನೆಣ್ಣೆ, ಹಾಗೆ 1/4 ಚಮಚ ಮೆಂತೆ, 1 ಚಮಚ ಉದ್ದಿನ ಬೇಳೆ, 2 ಚಮಚ ಕೊತ್ತಂಬರಿ, 1/4 ಚಮಚದಷ್ಟು ಜೀರಿಗೆ, ಒಂದು ಸಣ್ಣ ಗಟ್ಟಿ, ಹಾಗೆ ಸ್ವಲ್ಪ ಬೇವು ಸೊಪ್ಪು, ಮತ್ತೊಂದು 4 ಬ್ಯಾಡಗಿ ಮೆಣಸು ತಗೊಳ್ಳಿ. ಖಾರ ಬೇಕಾದವರು ಊರಿನ ಮೆಣಸು ಕೂಡ ಸೇರಿಸಿ. ಮೊದಲಿಗೆ ಒಂದು ಬಾಣಲೆಗೆ ಎಣ್ಣೆ ಬಿಸಿಯಾದ ಕೂಡಲೇ ನಾವೀಗ ಸಾಂಬಾರು ಪುಡಿಯನ್ನು ಸೇರಿಸಿ ನೀವು ಒಂದು ಕಪ್ಪಿನಷ್ಟು ಕಾಯಿ ತುರಿ, ಇದಕ್ಕೆ ಹುರಿದಿಟ್ಟಂತಹ ಮಸಾಲೆಯನ್ನು ಕೂಡ ಸೇರಿಸಿ ಇನ್ನೀಗ ಇದನ್ನ ಕಡೆದುಕೊಳ್ಳುವ. ಸಾಂಬಾರು ಪುಡಿಯನ್ನು ಸೇರಿಸಿ ನೀವು ಸಾಂಬಾರು ಮಾಡಿಕೊಳ್ಬಹುದು. ಸಾಂಬಾರು ಪುಡಿ ಮಾಡೋದು ಹೇಗೆ ಅಂತ ಹೇಳಿ ನಾನು ಮೊದಲೇ ಒಂದು ವಿಡಿಯೋದಲ್ಲಿ ಹೇಳಿದ್ದೆ. ಅದರ ಲಿಂಕ್ ಅನ್ನು ಕೂಡ ನಾನು ಡಿಸ್ಕ್ರಿಪ್ಷನ್ ಅಲ್ಲಿ ಕೊಟ್ಟಿರ್ತೇನೆ. ಅದನ್ನು ಕೂಡ ನೀವು ಸ್ಟಾರ್ಟ್ ಮಾಡಿಕೊಳ್ಳಿ. ಹಾಗೆ ಮಾಡುವುದಾದ್ರೆ ನಾವಿಲ್ಲಿ ಮಸಾಲೆಯನ್ನು ಸೇರಿಸುತ್ತಲ್ಲ, ಆ ಹಂತದಲ್ಲಿ ಸಾಂಬಾರು ಪುಡಿಯನ್ನು ಸೇರಿಸಿಕೊಂಡು ಕಡಿದುಕೊಳ್ತೇವೆ. ಕಡೆಯಲಿಕ್ಕೆ ಬೇಕಾದಷ್ಟು ನೀರು ಕೂಡ ಸೇರಿಸಿಕೊಳ್ತೇವೆ. ನೋಡಿ, ಈಗ ಹೋಳುಗಳು ಚೆನ್ನಾಗಿ ಬೆಂದಿದೆ. ಈಗ ಕಡಿದಿರುವಂತಹ ಮಸಾಲೆಯನ್ನು ಸೇರಿಸ್ತಾ ಇದ್ದೇವೆ. ಕರಿಬೇಳೆ ಬೇಕಾದ್ರೆ ಇದಕ್ಕೆ ಸೇರಿಸಿಕೊಳ್ಳಿ, ಬೇರೆ ಬೇಯಿಸಿ ಇವತ್ತಲ್ಲೇ ಸೇರಿಸಿಕೊಳ್ಳಿ. ನಾವು ಮನೆಯಲ್ಲೇ ಮಾಡುವ ಕಾರಣ ಸೇರಿಸಿ, ನೀವು ಬೇಕು ಅಂತಿದ್ರೆ ಸೇರಿಸಿಕೊಳ್ಳಿ. ಸ್ವಲ್ಪ ನೀರು ಸೇರಿಸ್ತಾ ಇದ್ದೇವೆ. ಇದನ್ನು ಚೆನ್ನಾಗಿ ಮಿಕ್ಸ್ ಮಾಡಿಕೊಳ್ಳಿ. ಈಗ ಇದನ್ನ ಸರಿಯಾಗಿ ಕುದಿಸಿಕೊಂಡ್ರೆ ನೋಡಿ, ಚೆನ್ನಾಗಿ ಕುದಿ ಬಂತು. ಇಷ್ಟಾದ್ರೂ ಸಾಕು. ಒಗ್ಗರಣೆ ಮಾಡುವ. ಈಗ ಒಗ್ಗರಣೆಗೆ ಸ್ವಲ್ಪ ಎಣ್ಣೆ ಬಿಸಿ ಆದಾಗ 1 ಚಮಚ ಸಾಸಿವೆ, 4 ತುಂಡು ಮೆಣಸು, ಸಾಸಿವೆ ಸಿಡಿದಾಗ ಬೇವು ಸೊಪ್ಪು, ಈಗ ಸಾಂಬಾರಿಗೆ ಹಾಕಿಕೊಳ್ಳುವ. ತೊಗರಿ ಬೇಡ ಇನ್ನೊಂದಿಷ್ಟು ದೊಡ್ಡ ನಿನಗೆ ಇದಕ್ಕೆ ರುಚಿಗೆ ಬೇಕಾದಷ್ಟು ಸ್ವಲ್ಪ ಮೆಣಸಿನ ಹುಡಿ, ಚಿಟಿಕೆ ಅರಸಿನ ಹುಡಿ ಅಥವಾ ಸಣ್ಣ ತುಂಡು ಬೆಲ್ಲ ರುಚಿಗೆ, ಇನ್ನೊಂದಿಷ್ಟು ದೊಡ್ಡ ಹುಳಿಯನ್ನು ನೀರು ಹಾಕಿ ಕಿವಿಚಿ ಹಾಕಿಕೊಳ್ಳುವುದು. ಕಿವಿಚಿದ
ನೀನ್ ಬದುಕ್ಬೇಕಾ ಒಟ್ಟಿ ತರಗ ತರ ಬದುಕು. 3 ಹುಡುಗರು ಹಿಂದೆ ಬಿದ್ರು ನಾನು ತಿಂದು ನೋಡಿಲ್ಲ.
ಏನ್ ಮಾಡತ್ತೀರಿ ಇಲ್ಲಿ? ಓ ಮಾರ ಜನ ಹಿಂಗೆ ನೋಡಿ ಹೋಗಿ ಕೆಲಸ ನೋಡ್ಕೊಳ್ಳೋದಿಲ್ಲ, ಬರೀ ವಿಡಿಯೋ ಮಾಡಲ್ಲೇ
ಅಪ್ಪ ನೀನ್ ಏನಪ್ಪ ಯಾವಾಗ ನೋಡ್ರೆ ನಂಗೆ ವಿಡಿಯೋ ಮಾಡ್ಬೇಕ ಟೆನ್ಷನ್ ಕೊಡ್ತೀಯ. ನೀನ್ ಅದನ್ನ ಕೆಲಸ ಮಾಡೋ ನಾನು ವಿಡಿಯೋ ಮಾಡ್ತೀನಿ.
ಒಳ್ಳೆ ಮುಂಜೆ ಮುಂಜೆ ಕಸ ತಂಗಿ ಹೋಗ್ ಮನೆಗೆ ಕಸ ಮಸ್ತಿ ಮಾಡು. ನಿಮ್ಮ ಹೊಯ್ಕೊಂತೀರ ಹೇಳತ್ತ ಮುಂಜೆ ನೋಡಲ್ಲಿ ಒಂದೇ ಒದ್ದಾಡಕತ್ತದ.
ಹೋಗಪ್ಪ ಹೋಗಪ್ಪ ನೀನು
ಹೋಗರೆ ಕರೆಂಟ್ ಬಂದು ನೋಡ್ಕೊಂಡು ಹೋಗ ಮಾರ. ಬರೇ ಊಟ ಕೆಲಸ ಮಾಡ್ಬೇಕು, ಬರೇ ನೀ ಏನ್ ಮಾಡ್ತೀರಿ ಒಳ್ಳೆ ನಿಂದ ಕೆಲಸ ಮಾಡೋ ನೋಡ. ಸ್ವಲ್ಪ ನಾನು ಫೇಮಸ್ ಆಯ್ತೀನಿ ನಿಂದ್ರೆ ಹಿಂಗ ಮಾಡತ್ತಿ. ಏನ ಫೇಮಸ್ ಹಾಕಿರೋ ನಿಮ್ಮ ಒಟ್ಟಿಗೆ ಅನ್ನ ಹಾಕೋದ್ ನೋಡ್ರಿ ನೋಡ್ರಿ ಒಳ್ಳೆ ಏನ್ ನಮ್ಮ ಹೆಸರು ತರ್ತಾವ, ನಮ್ಮ ಹೆಸರು ಹೊಯ್ಕೊತ ಹೋಗೋದು ಏನ್